is most commonly involved for further progression towards the tumor or some non-tumorous conditions. So it is frequently seen in children and young adults. The nature of virus, everywhere it is present. In our surrounding, virus is present everywhere, but in inactive form. Once it just enters inside the human body, they start multiplying in millions. So that's why virus is very, very dangerous for the human being. Clinical features, if patient is suffering from periungual warts, are there is presence of firm keratotic papules involve the hyponychium at the distal nail bed. The biopsy is done in adult to rule out Bowen's disease and amelanotic melanoma. See, Bowen's disease is a pre-malignant condition and it is limited within the epithelium or epidermis. So, amelanotic melanoma, basically it is present in the basal layer. See, the name is amelanotic melanoma, means no melanin pigment is present, but melanocytes are active. So it is very important to recognize active melanocytes under the microscope. So biopsy is done in adult to rule out Bowen's disease and amelanotic melanoma. See, in the Bowen's disease, if pathologists, they are not reporting whether there is dysplastic feature is present or not. It is very important to write in our report whether dysplastic feature is present under the microscope or not. So in the HPE, first thing is the acanthosis. What is acanthosis? What is acanthosis? Anyone? Any PG? How many PG students are sitting here? Please raise your hand. How many PG students? Okay. Now tell me, what is acanthosis? Thickening of the stratum spinosum. Okay. So thickening of the stratum spinosum. So many of names of stratum spinosum. And this is the main layer in the skin which determine the thickness of the skin. Okay. But this is important in nail also. Okay, not though it is not very prominent in nail, keratin layer is most prominent in nail. Okay, so there is presence of acanthosis, papillomatosis. What is papillomatosis? Finger-like projection. So we can write finger-like projection, and we have to give importance of the tip of the finger-like projection, whether it is pointed or whether it is blunt. So this is very important. Then parakeratosis means there is retention of nucleus in the stratum corneum layer. That is parakeratosis. Coilocytes, large cell, perinuclear halo is present. That is indicative of HPV infection. If coilocyte is present, we have to see whether large cell is present or not with irregular nuclear margin and presence of perinuclear halo. That is the feature of coilocytes. So important inflammatory conditions of the nail are, first is the psoriasis. So the microscopic feature of psoriasis of the skin should be the tip of the tongue of all the PG students. It is little bit different in the nail. In psoriasis, there is presence of spongiosis, loss of granular layer in hyponychium. That's why it is very important to identify the normal anatomy of the nail. Presence of granular cell layer. Usually in the nail matrix, there is absence of granular cell layer. Here there is presence of granular cell layer in nail matrix and nail bed. Once there is presence of granular cell, it is indicative of inflammatory diseases, hyperkeratosis and parakeratosis, as well as important microscopic feature is the accumulation of serum-like material. It is homogeneous, okay, very shiny. If it is serum-like material, it is homogeneous and shiny. Another thing is the lichen planus. In the lichen planus, in the skin, most important is the presence of vacuolar degeneration. Vacuolar degeneration where? At the dermoepidermal junction. So this is the most important finding, is the vacuolar degeneration. It is present in the nail also, along with band-like infiltration of chronic inflammatory infiltrate, predominantly lymphocytes at the dermoepidermal junction. These are the two classic feature of lichen planus, if it involve nail. Now Derriere white disease. See, examination of nail carefully is very important. See, in the Derriere white disease, there is longitudinal red and white streaks is present. So you can you can take the biopsy, and if under the microscope there is presence of white longitudinal streaks and subungual keratosis, it is characterized by epithelial hyperplasia, marked parakeratosis, multinucleated epithelial cell. See, I have not written here giant cell. You cannot say this is giant cell because of the multinucleation. Multinucleation is present inside the epithelial cell only. Okay? In the giant cell, there is presence of cytoplasm and multiple nucleus is present inside one cell. But here, in the epithelial cell, there is presence of multinucleation. That is a feature of Derriere white disease. Pemphigus vulgaris, it is important to have the facility in our institute, already started immunofluorescence facility. So it is very important where there is deposition of IgG and C3. So it is very important to see the IF finding before. Now come to the melanocytic lesions. Melanocytic lesions means there is activation of melanocytes, means there is presence or accumulation of melanin pigment. So under the microscope, there is melanocytic activation, means there is pigmentation of the matrix. There is importance of nail matrix, and epithelium is seen without increase in the density of melanocytes. If there is increased density of melanocytes, it is going towards lentigo and melanocytic hyperplasia. So lentigo, there is presence of increased number of matrix melanocytes. So then the diagnosis is lentigo. Another thing is the nevi. Nevi is nothing but accumulation at one place of the melanocytes. Okay? Site depends whether it is present inside the epithelium, at the junction, or in the just below the epithelium. See, the color of the nail is black. And then if the color is black, you have to follow ABCD rule. A means asymmetry, B blurred borders, heterogeneous color, diameter if it is more than 6 millimeter, and evolving lesions. If these 5 is present, it means patient is suffering from melanoma.
Ma'am, please wind off.
Okay, sir. So in the melanoma, there is presence of large cells and there is accumulation of melanin pigments. In the non-melanotic tumors, most important are basal cell carcinoma. How to diagnose? Presence of peripheral palisading cells. So if there is presence, it is very bluish in color. So it is basal cell carcinoma. If it is pinkish in color, it is away from the basal cell carcinoma or subdivision of some microscopic category of basal cell carcinoma. This is the last slide. There is presence of Bowen's disease and squamous cell carcinoma. How to identify Bowen's disease? It is limited. And squamous cell carcinoma, there is infiltration of below the epidermis, then patient is suffering from squamous cell carcinoma. In the two things you have to remember: basal cell carcinoma, bluish in color; squamous cell carcinoma, pinkish in color. Okay, because of the abundant cytoplasm. So that is called. Thank you very much. So for the patient hearing and inviting me to just deliver on the nail. Although we are receiving very less nail pathology, nail biopsy, but it is important for the prevention of diseases, for the prevention of infection, inflammation, as well as tumors. Thank you.
Thank you, Dr. Poonam, for enlightening us on the onychopathological aspects, what we see under the microscope and their clinical significance. Thank you very much, ma'am. Do you have any questions? Okay, thank you. Please, Sachidan sir.
It's not a question, it's a comment. Very nice talk, madam. Thank you so much. See, nail dermatopathology also was not, a very popular subject even for pathologists. Now the dermatologists have taken up nail pathology, nail biopsies. More and more samples and specimens come to you. And that's how the interest in pathologists also has generated. I think that's how a subject has to grow. And so thank you so much for having taken interest in dermatopathology. Thank you.
Thank you. Thank you for patience.
Thank you so much, ma'am, for such an enlightening session. I would now request respected Professor Dr. Poonam Badani, ma'am, and respected chairpersons Dr. P.C. Das sir and Dr. Hare Ram Kumar sir to kindly receive their memento. I would now like to request Dr. Pankaj Kumar sir and Dr. S. Mishra sir to kindly chair the next session. And I now invite Dr. Shikha Bansal ma'am to deliver her session on the topic management of ingrowing nails.
Good morning to all. This is a very important topic. So when we think of nail disorders and especially the surgical management, majority of us might start our nail surgery with the ingrowing nail. So ingrowing nail I've written and not ingrowing toenail because less often the ingrowing nail can be present in the hand also. I bring greetings from Nail Society of India. So what I hope to achieve at the end of the session, there's a whole spectrum of ingrown nail. It is not only one clinical presentation. To understand that spectrum, recognize the range of manifestations. It is important to grade the severity of ingrown nail because once we grade the severity, then we'll be able to decide upon the line of management whether it's conservative or it is surgical. Be well versed with the various surgical outcomes. So ingrown nail is a common condition. It is often tender, and when it's an advanced stage, then it is unsightly also. It frequently impairs the function to the extent that I had a senior officer coming and saying that I haven't walked for 3 months because of ingrown toenail, and he had uncontrolled diabetes because of that. So we cannot underestimate the importance of an ingrown nail. It typically predisposes to development of paronychia, and the patient presents with the pus formation and usually operated previously with a recurrence or a dystrophic nail. That is also very important. A lot of patients come that have been operated once or twice from somewhere and the spicule of the nail which embeds has not been properly removed. So just a brief touching upon the types of ingrown. The reason to put the slide here is in our OPD we often get our pediatric patients and we have to understand that all ingrown nails are not to be operated upon. In neonate, free margin of the nail has not yet overgrown the toe tip. So if you next time ever see a child neonate, then you will see that the nail plate, soft small nail plate seems to be embedded inside the nail bed. That is not to be done anything. In infantile, hypertrophic lateral lip of the nail plate is there, harmless malformation. Now there is congenital malalignment of gray toe. That is a separate topic altogether wherein we do X-ray and confirm the diagnosis. In adolescents, distal lateral ingrowing due to narrow nail bed. In adult, it is the sharply bent lateral margin, and in geriatric, sir had shown yesterday, there is a progressive thickening and curving of the nail, so pincer nail also. So types of ingrowing nail based on nail fold involved. Again, this is important because it will decide upon the surgical line of management. Slowly I will be showing one by one. Distal lateral ingrown is most important, then the distal ingrown and proximal ingrown or retronychia, which we see very less common in Indian setup. So types of ingrown based on direction of growth. Lateral ingrown is the distal lateral, which I said is the most common. Distal embedding when the nail is too short, I'll be showing a photograph, and retronychia. which I said is uncommon, and pincer nail was shown yesterday, wherein there's a wide base of distal phalanx. It is important to understand this because, as Tahilyani sir had shown yesterday, that you have to create a burr on the distal phalanx to take care of it. Now please pay attention to the severity grading. It is important because that will determine the line of management for us. So this is stage 1, wherein there is pain which is more on walking, inflammation or swelling. In this stage we do the conservative management. This is stage 2, wherein there is marked swelling and inflammation and there is oozing of the wound. In such cases, you go for the surgical management, which was shown yesterday, but I'll be showing the videos for the people who were not there yesterday. And this is stage 3, abscess formation, granulation, tissue and chronic induration of nail fold. The importance of recognizing an abscess formation is that we do not operate on the nail wherein secondary infection is there because the surgical outcome is poor. So whenever a patient of ingrown comes with a stage 3 wherein abscess formation is there, then do consider giving a course of oral antibiotics for 7 days and then proceed on to the surgery once the wound is dry. So this is one of the examples of stage 3, and as you can see there is an abscess formation on the lateral nail fold. This is a bilateral ingrown. This is Modzena's classification. Theory becomes a little important in ingrown because first we have to recognize and then decide upon the line of management. Stage 1, I've already shown the photographs. This is just a revision. There is erythema and slight edema and pain when lateral pressure is applied. Stage 2A, symptoms are present and there is a hypertrophic nail fold but less than 3 millimeters. Stage 2B, there is hypertrophic nail fold more than 3 millimeters. And stage 3, it's magnified symptoms of stage 2 with granulation, tissue and nail fold hypertrophy as I had shown in the previous slide. So how to plan the management? Stage 1 is conservative. If you remember the photograph I had shown, there was a pain on touching the nail fold. Stage 2 onwards is surgical. That is why the importance of the previous slides. Now depending upon the speciality, if you are a podiatric surgeon or a pedicurist, we prefer braces and similar devices, but dermatologists are well versed with the surgical correction and majority can and do perform surgery. So for us, we might consider doing a surgery. So this is the correct way of cutting. If you can see, this is a horizontal way of cutting the nail fold. So proper trimming advice is to be given, and preferably if the patient has soaked the feet in water to avoid shattering of the nail plate when you are using a nail clipper. So tell the patient to cut the nail plate straight. Many a times they try to cut in a curvature form that they think that they might take away the lateral nail plate which is impinging on the nail fold, but that does not help. It aggravates the condition as in the second photograph. And in the third, they many a times cut too deeply, though. So it is a small advice, but it has to be given diligently to the patient. So conservative technique, you give it in mild to moderate lesion where there is minimal to moderate pain, there is less erythema, no purulent discharge, or there is any kind of contraindication for surgery, like there is some kind of a vascular compromise, uncontrolled diabetes, then you can start with conservative technique. So I always keep this Dynaplast in my drawer and I demonstrated to the patient that anybody can do in the clinical practice. Just put this elastic bandage. So if you can see, this is the grade 1. I cut it into half, and in the next slide this is the collage. Can you see in the stage 1 there is a lateral nail fold, and B, I have draped it. I'll be showing the video for distal embedding. So the elastic tapes keeps the nail fold away from the nail plate, and the patient can do this at home. You can demonstrate it in your clinic, and then maybe it sticks for a day or two. If they want to take bath, they can remove it and apply it again. So this is a distal embedding. Can you see here? The nail plate is getting inside the nail bed. This is the lateral view. I'll show the video for the taping. So that is the way you take the distal nail fold away from the nail plate. So this is the choice of surgical treatment approach based on classification of the severity index. In retronychia, the surgical treatment is proximal nail avulsion. For people who were present yesterday, Dr. Chandar had shown how the proximal nail avulsion is done. In retronychia, because we don't Indians wear too much of a closed toe in sandals or belly, so that is why we see lesser retronychia in our setup. The lateral ingrown is something which we commonly see. This slide is just a revision. In stage 1, conservative management. In stage 2 and 3, it's the nail matrix phenolization. In the distal part, it is Super U or Howard-Dubois technique, but I'll not be discussing that. I'll be discussing the commonly done ingrown today. So prerequisites for surgical approach are higher the severity, use the surgical approach, familiarity with the surgical procedure. You have to understand plate versus fold surgery. And conservative measures are still required even if surgery is being done. So advice regarding proper footwear, wide toe box or open toe shoes, straight cutting of nails, which I've already told. Management of coexisting hyperhidrosis. Hyperhidrosis is common predisposing factor for ingrown. Management of onychomycosis. Soaking of feet or affected toe in warm water for 15 to 20 minutes. So soaking of feet is very important. You can soak it in antiseptic solution also to take care of the bacterial infection which is there. It is followed by application of topical antiseptics, reduces inflammation and secondary infection. So surgical management depends upon the stage of the disease. In the later stages, definitive surgical procedures are done. Lack of evidence on ideal surgical procedure. So total nail avulsion is absolutely not to be done. The reasons were discussed yesterday in very detail. Most commonly used procedure method of choice is lateral partial avulsion with selective lateral nail matrix phenolization. So just a brief word about the separate set of instruments, the sturdy nail plate and delicate nail matrix. So different instruments are needed. Just a basic go through of the instruments. Can you imagine such simple nail spatula, English nail splitter and Castroviejo scissors if need be. So this is the partial nail avulsion in which the large portion of normal nail plate will remain in place, exerting a pressure on the underlying tissues, reducing the risk of distal embedding. So partial nail avulsion, these are the instruments which will be used. Cleaning of the site. Cleaning we have already discussed. Nail unit anesthesia, we can use lignocaine with adrenaline. There is no contraindication to it. Local anesthesia, please note the direction of the needle of the local anesthesia. It is important. This is the cadaveric dissection. Can you see the nerve which is there? So you should not poke the needle perpendicular, but it should be horizontal. This is the correct way of putting the needle. This is the distal nail unit anesthesia if need be, because the tissue is inflamed many a times. You might need to give the distal anesthesia. Tourniquet we have discussed. This is the glove tourniquet which I have got in the habit of using. Even gauze tourniquet is very effective. Okay, now coming to the important part of the presentation, after I have anesthetized the nail unit and given a proper tourniquet, both steps are very important. This is the nail spatula with which we separate the nail fold from the nail plate. This is the partial avulsion of the nail plate which is done. You keep the curved edge away from the bed towards the nail plate and gently separate it. Horizontal motions are to be avoided because you're damaging the vertical or longitudinal ridges. Can you see there's a spicule which has come out which is impinging? Now please use the spatula, nail spatula, to give a guard, and then you can cut with either the English nail splitter or a sharp scissor also will do. This is an important step. And then the curating. Curating, we use a toothpick over which we use the cotton, make a thin tip, and then in the to and fro motion 2 to 3 times we should ideally repeat it. Matrix destruction can be done with the help of phenol, KOH, TCA. We have phenol which is commonly available in our OT and it works very well for it. So procedure of choice is optimum is 1 minute vigorous rubbing and terminate action by normal saline. So this is chemical cauterization of the nail matrix. So you rub off the excess. First you do lateral and then this rubbing motion is very important and you should do 1 or 2 repeat cycles of this rubbing motion. This is one of the most crucial steps of ingrowing nail surgery. As you can see, this has the hemostatic effect also, and this is absolutely a bloodless field which is obtained after this, and then you can pour betadine over the operated site. And ideal dressing we have discussed yesterday only. It should be a non-sticky paraffin dressing, over that an adherent, non-adherent gauze which absorbs the secreting material, and the post-operative advice is serous drainage can be prolonged because of the cauterization which has been done. So somebody was asking whether post-operative antibiotics are to be given. We are a hot tropical country and usually we operate the foot. So yes, you can give an antibiotic, analgesia, leg elevation ideally for 48 hours. To conclude, ingrown nail is multifactorial. Predisposing factors need to be addressed like onychomycosis or hyperhidrosis. Proximal nail, partial nail avulsion with lateral horn matrixectomy is simple and safe procedure, and phenol has a low recurrence and prolonged healing time. So I hope I've generated a little interest in nail procedures. These are simple procedures to begin with. All must go and do it. Thank you so much for a patient listening.
Thank you, madam. Thank you for your nice lecture and video demonstration.
So what is the experience with? So the experience is very good if we use the partial nail avulsion with lateral nail matrix. Fevikwik. Sir, I haven't used Fevikwik, sir. Sir, I have no experience. Sir, can...
Thank you so much, ma'am, for such an enlightening session. I would now request respected chairpersons and speakers to kindly receive their memento. The next session will be chaired by Dr. Anup Deb Sarkar sir and Dr. Gopal Prasad sir. I would like to request them to please join us on the dais. I would like to invite respected Dr. Sushil Tahiliani sir to
Hello. Our next topic is pincer nail, my approach, will be presented by Dr. Sushil Tahiliani, who I think needs no introduction. I'd request Dr. Sushil Tahiliani to please start the session.
Good morning, everybody. Thanks for having me here. The pincer nail, also called trumpet nails, omega nails, convoluted nails, unguis constringens, were first described by Cornelius and Shelley in 1968. It means a transverse over curvature. The curvature of we all know the nail plate is convex transversely, but when the convexity increases progressively from proximal to distal part, that's called transverse over curvature, because of which the nail bed is pinched and there's a pressure on the groove. It's quite common on the toes and rare on the fingers. So these are some of the examples. As you can see, it can be more, it can involve multiple digits, and it can be complete. So you can see the two lateral nail edges touching each other. The entire nail bed is totally obliterated. And you can see on one side folding or vertical moving down, that's called plicated pincer nail. You see there are two types, hereditary and acquired. Acquired are more common, and of the acquired, the two most common causes are deformities of feet with deviation of the phalanges due to ill-fitting footwear, and osteoarthritis of the distal interphalangeal joints. Of course, you have so many other causes also. And wherever you see multiple nails, and beginning before adolescence and family history, then you think of hereditary. So one of the most common concepts of why this could be happening is, they say, when the distal phalanx broadens at the base, the nail matrix is firmly attached to the base of the distal phalanx with a collagen which has strength of ligament. So there's a flattening of the nail matrix. And the nail plate, being a semi-malleable structure, overcurves at the other end. And the over curvature leads to the nail bed getting pulled up. The nail bed is attached to the distal part of the nail, distal phalanx, which also gets sucked in, and you can see a traction osteophyte. The nail bed is shrunken. You see inflammation, fibrosis, and contraction of nail bed, and there are mechanical forces. So this is how you explain flattening of the nail matrix, over curvature of the distal part of the nail plate. The same thing over here, any semi-malleable thing, if you stretch on one end, the other end will be overcurved. But there are other concepts also, because there are not all the people. What about the hereditary? What about those people who are bedridden? How do they get? So they say there's a balance between the upward pressure when you stand and the downward pressure because of normal curvature of the nail plate. When the balance is disturbed, and you have less of pressure from the floor and more of over curvature, you may see. And in contrast, they say if the pressure from the floor is more and the over curvature, the normal curvature is less, you may have conditions like onychia. These are new concepts of some other concept, because nobody knows exactly. You cannot explain the in all the patients. How do you decide how to treat? Whenever it causes pain, inflammation, difficulty in trimming, and so many people find it aesthetically not very pleasing, and guys will find it difficult to wear shoes. So conservative treatment works in neonatal and mild adult cases. This means you have to thin the, anyway, since there is, you cause thinning of the central part of the nail plate. You can cause it through grooving, nail burr, 40% urea, or you can put a orthonics. You can put a brace from here to here, and it has a memory, so it will try and stretch the nails. But these are all time-consuming methods, and there's a good tendency to relapse. So these are braces. These are not my images. You can have steel braces and plastic braces. Now there are shape memory alloy devices. You fix it on the side. They say the shape memory alloy device at a temperature of less than 24 degrees can be molded. So you mold it in the AC operation theatre and fix it, and then at temperature more than 30 degrees at body temperature, it will become more rigid. So it will go back to the old shape gradually, and the nail plate gets flattened. Then there's also superelastic nickel titanium wire bonding. You remove some part of the nail plate, make it thinner. Then you glue this device which has got a memory, and because of the shape memory, it will stretch out the nail plate. And I thought there's another interesting device which I should show. Here you use thermoplastic polyurethane filament with a 3D printer to form a brace. Then you insert shape memory alloy in the holes in the brace. The brace is attached to the surface of the nail using Dermabond Mini, so you don't have to fix it from the sides of the nail plate, so you don't have to give any anesthesia. And they showed significant improvement in 1 week, and device was removed in 2 months. The results were maintained after 1 year. So if you see, this is how the brace was prepared, and shape memory alloy was put into the brace. The brace was glued to the nails, and the nail plates straightened out. They have shown their results like this. I thought though they have shown ingrown nail, but this is actually pincer nail. So they show how the results are, but only thing is that you have to be sure there is no significant spicule of the bone if you don't remove it. So surgical treatment means permanent removal of the lateral matrix ons. This was shown by Dr. Shikha to all of us. By itself is sufficiently effective because what you have done is you have removed the pressure on the nail matrix. So gradually the new nail will grow less overcurved at the tip. But sometimes you may have to complement this procedure with laterally expanding the pinched nail bed, and you could cut the distal dorsal traction osteophyte. That's what I'll show you here. So you use digital block, cause hemostasis, vertical partial nail plate avulsion, chemical matrixotomy shown to you already. Then you do transverse partial nail plate avulsion. Then you take an inverted T incision of the nail bed, and protruding osteophyte is removed, and sides are resutured. So this is the patient, the end-on view. I'll bypass this part because this has been shown by Dr. Shikha, and we have to respect time. Then you got to mark the part of the nail plate which is to be removed and separate it by vertical movement so that you don't disturb the longitudinally arranged nail. What is it? You saw the anatomy in the nail bed. The ret ridges are longitudinally aligned, so you should not disturb those. And then you use the nail splitter to remove that part of the nail plate, though it's very thick, but it can be managed if you got good instruments. So I'm sure you got so this is what happens. You remove the distal part of the nail plate through transverse partial nail plate avulsion. Then you got to plan an incision from here and then take an inverted T beyond hyponychium and take the flaps out. That's what we are doing now here. You could use a 15 number blade, you don't have to use a 11 number blade here actually. Just tell me when how much more time do I have? Actually, there's no timer. Achha, we have enough time. Since there are so many juniors, so I thought I'll just revise with them. Remember, it's not easy because the nail bed is attached, I told you, to the osteophyte, the bone phalanx with the collagen, which is the strength of ligament, and you have to separate at the level of periosteum so that the nail bed is not disturbed. This is how the nail blade is reflected out, and you can see it protruding osteophyte here. Next, you must remove the osteophyte either by using a bone ronger, cut it, or you could use a battery operated motorized diamond burr, which we all are good used to using because of vitiligo surgeries. Just remember, when you use this, you're generating heat, and small bones can get necrosed because of heat, so therefore you keep pouring cold saline. So this is how it is smoothened. Then you put the flaps back and suture with absorbable 5-0 suture material. This is Dr. Haneke's concept that you should be removing this osteophyte, which is small osteophyte, but you should remove it generously so that you have the same level. Then you got better results. So I told you then the nail bed and nail flaps are put back and sutured with absorbable sutures. Then you put non-adherent tool gauze dressing followed by bulky dressing, elevate the limb. Whenever you're touching the bone, the pain can be moderate to severe, so give them adequate analgesia. And one good tip is post-procedure you could inject bupivacaine or ropivacaine so that the pain control can last for 4 to 8 hours. And elevation of the limb. This is a patient 1 year after the surgery. This is how you compare the pre and post treatment results. So not only the pain can be taken away, but it can be quite gratifying. With that, I conclude my talk about how I manage pincer nails. Thank you.
Many thanks.
So
Dr.
chances of recurrence are more if you have not, ideally they say you should be taking a lateral X-ray of the toe, specified to the radiologist who should be sensitized to requirements that you're looking for a dorsal distal traction osteophyte. Normally the X-rays are taken by technicians. Radiologists sit in their console, they look at this image on the screen, and the standard copy and paste report is if there is any osteoarthritis, if there is a fracture, osteoporosis, bone erosions, and soft tissue swelling. Full stop. Nobody looks at the osteophyte because they are not sensitized. And that can be tiny. In fact, there are studies to show that sometimes it will not be seen on the X-ray, but when you, on the table, when you touch the blade will see a protrusion. So you have to be sure that you treat the osteophyte if it is significant. Yeah. The osteophyte. I have a bucket list of going to attend the European Academy of Dermatology masterclass on nail surgeries, because as you will know, here we are trying to be at the edge of the technology, but there are not many more people we can look up to teach how much is the ideal. Yeah. But you can see a protrusion, just remove the protrusion, only you should not be overdoing it. But when you see this article from Dr. Haneke who says generously, that means you have a greater risk of undercorrecting than overcorrecting.
Many thanks, Dr. Tahilani sir. If any question, then you can ask from sir, Dr. Tahilani sir. Any question from the audience?
Thank you so much, sir, for such an enlightening session. I would now like to invite respected Dr. Mrityunjay Kumar sir and Dr. Mohammad Jisan sir for chairing the next session.
Today I'll be talking on dermoscopy of nails, a guide to refining basics. Now, why should we do nail dermoscopy? Because it reflects systemic and cutaneous disease. The clinical examination is often insufficient, and biopsy is difficult and painful. So onychoscopy bridges the gap between clinical examination and nail biopsy. Now this onychoscopy, what it offers? It is a non-invasive method. It improves diagnostic confidence and it reduces unnecessary biopsies. Now, how does dermoscopy work in nails? There's a light source and the skin surface. Then it reduces reflection if we are doing a polarized onychoscopy, and there is better visualization of nail bed. Now, onychoscopy practical techniques. You have to have minimal pressure on the lesion which you are examining, because there will be blanching of capillaries, and as a result of that there will be misleading of the vascular architecture. The hand should be at the heart level just to ensure that the blood flow is appropriate. We have to do a dry dermoscopy and a wet dermoscopy, and there are two methods used. It's polarized and non-polarized. You can use any dermoscope, whether it be a derm light or a photo finder. I'm using both. I have a derm light, photo finder and video dermoscopy all. Now, why do we do dry and wet onychoscopy? If you want to see the surface, you do dry examination. If you want to see the depth of the lesion, you do wet dermoscopy. So dry actually gives you the nail surface abnormalities, the pitting, the ridges, and the wet dermoscopy deals with the nail bed and pigment, and of course it tells us the vessels and the hemorrhages. Now, onychoscopy is the examination of nail unit. I've already spoken about it. Nail matrix is not visible, but it can be partly visible when we are doing or during intraoperative procedures. Now, dermoscopy is magnified visualization of nail features not seen with naked eye. Why onychoscopy reduces unnecessary nail biopsy? I'll be dealing in the later slides. Nail dermoscopy is technically challenging because the difficulty arises from nail unique anatomy. The entire nail is not visualized in a single unit. Frequent adjustments are needed. Photographic documentation is challenging. The nail hardness and convexity that limits proper contact with dermoscope lens. And non-contact methods allow assessment of nail fold capillary and architecture without pressure-induced blanching. The International Dermoscopic Society has a few terminologies which we should follow. We should not be giving a lot of names to the methods what we are using. So in case of color, we should define it as brown, black, gray. The lines should be defined as parallel lines or irregular lines, and dots and clots should be mentioned. The vascularity should be mentioned as linear vessels, dotted vessels, glomerular vessels, regular or irregular. These are few images showing the parallel pattern, the subungual hemorrhages, the nail pitting, and so on. The nail bed and hyponychium terminology should be in terms of vessels. I've already discussed dilated, linear, globular, red dots, subungual hemorrhages, homogeneous globular, erythematous border, or salmon colored structureless areas. Now these are the small capillary morphology. The first picture shows the normal pattern, that is U-shaped pattern. The second shows the dilated capillaries. The third, the C-section shows the giant capillaries, and so on. So in terms of capillaries, we need to define whether it's a looped capillary, it's a hairpin capillary, or giant capillaries, or dotted vessels, and so on. Now, one more feature is important in systemic sclerosis. This capillary dropout, we need to see if the normal nail anatomy, the normal vasculature, if there is dropout of that, we can call it a vascular dropout. Now, these are the vessel descriptions. It can be dot clots, linear vessels, different types of linear vessels. It can be helical vessels or coil vessels. Onychoscopy relation with anatomy, the nail plate allows transparency, so it allows pigment visualization. The nail bed deals with the vascular architecture. Nail matrix is important, it deals with site of melanocytic lesions. Hyponychia is critical in advanced melanoma. We should know the nail normal anatomy, otherwise we will not be able to deal with the abnormal. So normal nail plate looks pale, pink, irregular longitudinal lines, and there is uniform vascularity. And this is the examination of the normal nail plate. The first shows longitudinal ridges, that is indicated by an arrow. The second is its examination under polarized light, where the light blunts out the nail place irregularities. So you need to do a dry dermoscopy to see the nail surface irregularities. Now there is application of minimal mineral light that increases transparency and it decreases surface glare. So this is the normal anatomy or normal nail plate dermoscopy. Now proximal nail plate capillaroscopy, this is done by a 10x magnification, but you need to do a video dermoscopy to find out the normal nail anatomy or normal nail vascularity. So normal nail plate capillaries is indicated by an arrow in figure 4, and in figure 5 you can see the vascular dropout areas in diffuse cutaneous systemic sclerosis. Now when we do onychoscopy, so we are dealing with onychomycosis. When you see jagged proximal edges, and if there is spike, you should see that is fungal infection. So you can see the jagged proximal edges along with spikes. So whenever you deal with this, you will see it's onychomycosis. Lichen planus deals with pterygium. You need to find that out, and that is also visible on normal clinical examination of the nail. Psoriasis, you should see pitting, crumbling. This is important. So whenever you see these kind of lesions, you will define it as psoriasis. But psoriasis, onychoscopy is important because when the skin lesions are minimal, we will be able to deal with this disease per se on onychoscopy itself. So onychoscopy is really helpful in early psoriasis detection. Chronic paronychia, you need to deal with loss of cuticle. That is also visible in clinical examination, but in early stages you can find that out. The loss of cuticle will be dealing with chronic paronychia. This is a case of onychophagia. Now melanonychia, this is most important. So what should I do? If there are regular lines plus if it's stable, we should observe. If there is irregular lines, if there is widening of the area, we should biopsy. If there is Hutchinson sign, we should do an urgent biopsy. Hutchinson sign is a spread of pigment along the proximal nail edges. So that is a very, very important thing to add on. Now melanonychia, when there is melanocytic activation in multiple nails, it's great, it's probably not melanoma. But if it's from proliferation, we should deal it either benign or malignant. So proliferation of a single nail, brown, black, we should be cautious enough to see if it's a melanoma or not a melanoma. Benign melanoma, there's regular parallel lines, there's uniform color, and there's stable width. This is normal dermoscopy frictional melanonychia of the fifth toenail, showing gray brown with a brown background with parallel thin lines. So there is no irregular parallel lines. This is a biopsy. This is a monodactylic involvement of the nail, but it's not a melanoma. So we should deal, if there is, the parallel lines are good enough, there is no irregularity, and there is pseudo Hutchinson sign, it's not Hutchinson sign. Nail unit melanoma, there are irregular lines, there's color variation, there's proximal widening, and there is Hutchinson sign. Hutchinson sign, and if it's monodactylic and there is nail there is single nail unit involvement, we should probably do a biopsy. This is a picture of JAMA dermatology showing Hutchinson sign, and there's irregularity seen already. The other sign is also showing regular brown back pigmentation of lateral nail fold, Hutchinson sign. Subungual hemorrhage is easy to diagnose. So there's red, brown, black globules. There is peripheral fading. There is no pigment network or nail fold extension in Hutchinson sign, and it moves distally with nail growth. Glomus tumor, onychopapilloma, squamous cell carcinoma is rarely seen. So these are all features which are seen. Glomus tumor has reddish, bluish, black telangiectasia. Onychopapilloma has splinter hemorrhages. Squamous cell carcinoma has irregular keratosis, hemorrhage, and the lesion are very vascular. When should we biopsy the nail? Irregular melanonychia, single nail involvement is most important. If you get single nail involvement, irregular pattern, irregular parallel lines, Hutchinson sign, or nail plate destruction. Practical clinical tips. All 20 nails to be examined, compare with other digits, documentation of the photographs, and low threshold for biopsy when in doubt. Nail dermoscopy, powerful extension of clinical examination, pattern recognition, and is central to diagnosis. Thank you.
Any questions from audience, please?
Dr. Abhijit, very good talk. Thank you so much
Thank
for
you, sir.
highlighting the importance of onychoscopy in diagnosing nail disorders. I have one small reservation, not this thing, take it in the right spirit. Why do you call the onychoscopy replaces skin biopsy, but not unnecessary skin biopsy?
No, sir, correct. I totally agree.
Yeah, that
I totally agree.
definitely yes, because you can emphasize saying that it can replace skin biopsies.
No, I said it does not replace, maybe that would, I did not say that, sir, but it is it bridges the gap between the biopsy and the clinical examination.
Something akin to saying that, unnecessary cesarean sections.
Correct.
Thank you.
Thank you, sir.
Okay, any other question? No. Okay, thank you, Dr. Abhijit Jha,
Thank you, sir.
for your presentation.
Thank you so much, sir, for such a wonderful session. I would like to request respected speakers and respected chairpersons to kindly receive the memento. I would like to invite Dr. Anjinshu Prakash sir and Dr. Shashank Shekhar sir to chair the next event. Sirs, kindly come on the dais.
Good morning, everybody. Now I invite Dr. Rashid Shahid. Welcome.
Good morning, everyone. Today I'll be speaking on reactive arthritis and nail changes associated with it. So, reactive arthritis, which was previously called Ritter's syndrome, it is an autoimmune condition that develops in response to GI or genitourinary infection. It is a multi-system disease, as we all know, which involves skin, joints, nails, eyes, and skin lesions can precede, develop simultaneously, or follow joint involvement along with nail changes. So there is no fixed pattern. Anything can develop first, then it can follow by other findings. It is sometimes difficult to suspect reactive arthritis without skin and mucosal involvement. Reactive arthritis is often confused with psoriasis vulgaris because they both present with joint pain and they have skin lesions, which is confusing, and also they both have nail changes. So distinct alteration in the nail changes may help in distinguishing reactive arthritis from psoriasis vulgaris. We did a retrospective record-based cross-sectional study at AIIMS Patna in 2019, between 2019 to 2022. It was in 64 patients, and we observed mucocutaneous findings like papules, pustules, keratoderma blenoregica, and succinate vaginitis and valinitis. Succinate crusted papules were present in almost 82% of the patients. So thing is like, in most of the patients who present with skin lesions with joint involvement, many people often confuse with psoriasis vulgaris. So there is a very small differentiating features which should be examined carefully. Like in reactive arthritis, patient will develop papule which become crusted after 3 to 4 days or 1 day also and falls off leaving smooth surface. But in psoriasis, the scales will be coalesced to form a plaque, and they leave the scaling in layers, and there will be no smooth surface on peeling of the skin. Now coming to nail changes in reactive arthritis. In our study, we observed that nail dystrophy, total nail dystrophy, was present in around 56% of the patients. As you can observe here, both hands and feet, all the nails are destroyed. All total dystrophy is present along with periungual nail changes. Nail plate thickening and subungual deposits was observed in 36% of the patients. Nail fold inflammation was observed in 17% of the patients. The nails can become thickened and rigged. It may resemble mycotic infection and psoriatic onychodystrophy. So it's very important to differentiate reactive arthritis nail changes from other conditions. Most common disease which come close to the reactive arthritis is psoriasis. So we have to differentiate it, nail findings. We observed in our study in reactive arthritis, the total nail dystrophy was more severe in reactive arthritis patients with periungual inflammation and more subungual deposits. Subungual deposits can be present in psoriasis also, but those are non-destructive and often present as a compact. This is the photograph of reactive arthritis patient with nail dystrophy, and this is the photograph of psoriasis patient. The nail plates are intact. They are dystrophic but intact, and subungual deposits, these are a bit compact. Nail plating, we observed it was very occasionally present in only few patients, and distal onycholysis can present in both the patients psoriasis and reactive arthritis, but in our study we observed it was more present in reactive arthritis patients. Now, to summarize, reactive arthritis is an inflammatory arthritis that manifests after several days to weeks after a gastrointestinal or genitourinary infection. It occurs due to abrupt autoimmune response to gastrointestinal infections like Salmonella, Shigella, Campylobacter, and Chlamydia. To date, there is no agreement regarding reactive arthritis diagnostic criteria. Consequently, the diagnosis is essentially clinical based on careful history and physical examination. In our study, the most common age group was between 16 to 20 to 35 years reproductive age group. And though arthritis is the most common presentation, other systems like skin, genitourinary, ocular, and cardiac involvement sometimes dominate the disease. Nail changes are often present in reactive arthritis, so it can help in early diagnosis and prevent the patient from deformity. More severe nail involvement is often associated with chronicity, increased severity of the disease, which was observed in our study. Meticulous dermatological examination, including mucosa, palm soles, nails, and scalp can be great help in diagnosis of reactive arthritis and differentiating it from psoriasis. Multi-system involvement, though not common, not rare in reactive arthritis. Hence, other investigations can also be done, like HLA-B27 and C-reactive protein, ESR. This study on these 64 patients we published in IJDVL. Thank you.
Thank you, Dr. Rashid. Any question from the house, audience?
No question. Thank you, Dr. Rashid. No.
Thank you so much, Dr. Rashid sir, for such a wonderful session. I would now request the chairpersons and the speaker to kindly receive their memento. I would now like to invite Dr. Rajesh Kumar sir and Dr. Richa Thakur ma'am to chair the next event.
Yeah, good morning, all of you. Dr. Ghazala Ahmad, topic is
nail lichen planus.
Nail lichen.
It's not written here, so I'll show you.
Lichen planus, nail diagnosis, clue and management. So now start.
A very good morning to all of you and my chairpersons. My topic today is specifically nail affection in lichen planus. What are the diagnostic clues and what is the management? How to manage it? So lichen planus, it's very easy to diagnose when its nail is associated with the cutaneous manifestations as well. It's very easy, but when the difficulty comes when the nail is the only part which is affected by lichen planus. So in general, around about 0.9% of the population is affected by lichen planus, of which 5 to 10% presents with nail LP. And even in that fraction, there are some who present only with nail LP. It is seen more in males, but till now I have seen more in females in my personal practice, I don't know why. And it presents late in the age, like 5th to 6th decade. Early diagnosis helps prevent scarring of the nail and the irreversible changes. So this is one patient who presented only with the nail affection of the lichen planus disease. A short etiopathogenesis. It is an autoimmune disease, CD8 T cell mediated, but there should, in any disease, there should be any genetic predisposition. So HLA, so many HLAs are associated. The environmental factors, especially Hep C, has been proved to be associated with lichen planus. There are many other viruses, HHV 6, 7, even HSV, VZV has been documented in reports. Then what happens? There is a complex of cytokines like interferon gamma, interleukin 17, interleukin 21 and 23. There is a complex cytokine that mediates the apoptosis of the basal layer by fast ligand, perforin granzyme association and TNF alpha. So this was in short, but this when happens only in the nail unit and specifically most commonly the nail matrix. That is the most common part that is affected by LP in nail unit. Next comes the nail bed, and sometimes if there is isolated presentation, you can see nail LP changes over the proximal nail fold. Here. So what are the clinical findings? This is the most common clinical finding. There will be longitudinal ridging that will end in splitting. This is the most common. There will be nail plate thinning as well. Sorry. Thickening is seen in psoriasis, thinning is seen in LP. These are changes when the nail matrix is affected. If nail bed is affected, there will be onycholysis. There can be splinter hemorrhages and there can be dyspigmentation, melanonychia can be seen. This is onychoschizia. That means there is lamellar separation of the nail plate. Here we can see this. There is lamellar separation of the nail plate. So here we can see the tracheonychia pterygium, which is the most pathognomic of nail LP, but it is less commonly seen. If it is present, when we ask what is the nail changes to any student, they'll say pterygium. But this is not the most common, and it is a very late manifestation. It is very difficult to irreversible the disease at this stage. So our aim is to prevent pterygium from early diagnosis and prevent so that the nail is saved. You can see here. Here even proximal nail fold has been affected. We can see if we do a dermoscopy, the classical findings can be seen, or the dermoscopic findings of cutaneous LP can be seen in the proximal nail fold. There is very famous pup tent sign. It's rare, but it can be seen when the ridging and the splitting, everything is an onycholysis, everything combines and presents like this. Pup tent is a small tent used by the army. It is named after that because of the similarity of appearance. This is the end stage. We have onychonychia, scarring and permanent nail damage. our management is aimed at preventing this stage. What are the differentials? Onychomycosis is the most common differential. Like even I get confused whether it is nail LP or onychomycosis. And if you do a dermoscopy, you can see jagged spikes. You can see the spikes here. There will be spikes. Onycholysis will be there. There will be jagged edges and spikes. And if you see from the head on the toe, you can see tunnels. That is one differentiating, easy to differentiate between nail LP and onychomycosis. Next is psoriasis. Pitting is very common in psoriasis. Coarse, irregular pitting of nail plate, very common. Pitting can rarely be seen in nail LP as well. So you have to see other findings as well. Subungual hyperkeratosis. Nail, this is salmon patch, onycholysis, and there will be erythema surrounding it. In nail psoriasis and onychomycosis also this helps. In nail psoriasis it will be a smooth border of onycholysis, while in onychomycosis there will be spikes. And many a times there are patients who come only with nail psoriasis. There you can do a dermoscopy. The proximal nail fold will show hairpin like blood vessels. That is very characteristic. Only nail psoriasis, and you do a dermoscopy of the proximal nail fold, hairpin like vessels, you can easily differentiate between onychomycosis, nail LP and nail psoriasis. Nail alopecia areata can be a differential, but it is easier than the other two because it is fine pitting, no other cutaneous manifestations are there. Fine regular geometrical pitting will be seen. Nail LP is mainly a clinical diagnosis, but dermoscopy helps a lot. This is an article where you can see that red bars are the dermoscopic findings. So it is always easier to diagnose, like earlier changes can be seen on dermoscopy, so you will diagnose it earlier and prevent the scarring. In all, nail matrix, nail bed, nail plate, everything dermoscopy can detect earlier and in higher percentage. Biopsy is rarely needed in LP, but if there is a lot of confusion, like there is uncertainty in diagnosis, there is atypical presentation, you have given the treatment of nail LP but it has failed, there is only isolated nail involvement, or if the disease is rapidly progressive to dystrophic nail, then you can do a biopsy to confirm the diagnosis. Better to take a longitudinal nail biopsy including the proximal nail fold. Here we can see the hyperkeratosis. This is the hypergranulosis, and these are the inflammatory infiltrate both in the dorsal and ventral lip of the proximal nail fold. Even here there is a slight infiltration of the inflammatory cells. Now what is the management? Before telling that, our aim is to treat early and prevent the scarring. And use a camera before using a pen. Because once we prescribe, even I do the mistake, like I do a lot. I forget the camera and prescribe, the patient takes the prescription and leaves. First, document by a photograph, especially if the nail is involved. And only the nail is involved, because the nail grows very slow, like 3 to 4 mm in a month. And you will call the patient in 1 month. So, you take the camera of the patient, their phone, take a picture on a good background, let them take the photograph and tell them to bring that photograph in the next follow-up so that we can compare. Because they will not say that there is improvement. We have to see if there is an improvement or not. So we have to compare the proximal, like the basal 2 to 3 mm of the nail plate on both sessions, and there will be the changes or if there is any benefit in the treatment. Also, we have to always rule out onychomycosis. If the nail LP findings are classic, we can give directly the treatment. But if there is any confusion in onychomycosis and nail LP, we should always give a trial of antifungal, like 20 days, take a before photograph, call the patient in 20 days and then compare. That will give a lot of clarity. So this is the first line treatment, high potent steroid or tacrolimus 0.1%. Under occlusion is best. This is how we can occlude. We can also take the non-powdered glove, cut the finger part and tell the patient to put on so that there is occlusion. This is very commonly done. Intramatricial injection of triamcinolone, like 2.5 to 10 mg. Better not to go above 5 mg per ml. Give in monthly sittings and see the improvement. Like 4 to 6 weekly sittings can be done, and in around about 3 months you can see the benefit. We can also give intramuscular injection of triamcinolone, 0.5 to 1 mg per kg, 4 weekly, 3 to 6 months can be given. Oral steroids, better to give in oral mini pulse to minimize the side effects. And you can try even daily dosing. You try for daily dosing. If there is an improvement in 20 days, you'll confirm that it is responding to the treatment, then you can shift to OMP. Oral retinoids has also been documented. Acitretin shows a good result, 0.2 to 0.3 mg per kg per day. Alitretinoin not available here, but it has been documented in evidence that 30 mg per day can be given. If this is not working, you can go for other immunosuppressants like methotrexate, azathioprine, cyclosporin or MMF. There are some case reports like JAK-I is everywhere. So they have tried tofacitinib and they got a very good result. Like tofacitinib 5 mg BD for 6 months. The before after picture shows very promising results. They have tried abrocitinib as well, 100 mg per day. Baricitinib, I couldn't get the before after picture, but it also shows good results. Etanercept has also been tried, injection etanercept 50 mg weekly. They have given, this is the 3-month after pic and this is 6 months. Any nail, if it is very severely affected, it will take at least 3 to 6 months to show some benefit. So this is an algorithm. Nail LP, if it is like number of nails affected, severity and the response of in treatment, these are the 3 things we should see before giving the treatment. Less than 3 nails and it is mild and less chances of scarring, we can give the topical steroid, we can give intramatricial injections. But if it is multi-nail, to give injection to every nail is a bit painful, so go for systemic drugs and like oral steroid, intramatricial triamcinolone and other immunosuppressive. If it is refractory, you can also try JAK-I and injection etanercept. Even low dose naltrexone has been tried in one case report and they have shown good results. This is my personal patient in 2 months, round about 2 months. I gave OMP and this here, if I can, this is the best. This nail shows the best result. This here and here. So this also shows. It was, the prognosis is like good in OMP with minimal adverse effects. So that brings to me to the end. Thank you for patient listening.
Thank you, Dr. Ghazal Ahmed, for a very informative talk. Thank you.
Thank you, ma'am.
Any questions from audience? No, thank you.
Thank you so much.
Thank you so much, Dr. Ghazal ma'am, for such an enlightening session. Now we are going to have a panel discussion. I would like to invite Dr. Shriparna Deb ma'am to conduct the session.
A very good afternoon to all. So, I would like to call upon my panelists first. Dr. Nazan Shagufta, Assistant Professor, Consultant Dermatologist. Dr. Punkesh Kumar Sir, Consultant Dermatologist, Patna. Dr. Richa Thakur Ma'am, Associate Professor. Dr. Rakhi Gupta Ma'am, Associate Professor. And Dr. Shri Rupa, Consultant Dermatologist in Cos Derma. So I have already told my panelists, our topic is inflammatory nail disorders, and this panel would be all about how they approach it, because I find all the inflammatory disorders having near about the same treatment. So yeah, they are here to clear our doubts. Let's start. So my first question is, let's say a patient walks into the OPD of yours with a nail dystrophy. So what are the cues that you have that yes, it is an inflammatory disorder? We should go into that direction and not a purely infective or traumatic one that has caused the dystrophy. So what features help you say that is an inflammatory disorder rather than an infective? Will you look for the number of nails, the pattern, you ask about the progression, or what you go ahead? Richa ma'am.
You are asking about the first clue, about visual.
Yes, ma'am.
Then first clue for visual, I will see is there is any joint involvement, because we are suspecting about the inflammatory nail disorder. Then the most common cause is psoriatic arthritis, and in most of the cases of psoriatic arthritis, there is nail involvement. Then next is if you are asking about the number of nails, as in showing in the picture, there is single nail. Can you please repeat?
Two were there. Two. I don't have the full picture, but only two were involved in him.
There is only two nail involvement.
Yeah.
Then if you are asking about the number of nails, then that is, it may be just like if I are suspecting about the infective etiology in onychomycosis. Though most of the cases in onychomycosis I saw there is sparing of one or two nail. But in case of psoriasis or in other inflammatory nail disorder, then all of the nail may involve. The pattern, you are asking about the finding.
Ma'am, how do you approach, like a patient has come, only one or two nails are involved. So how will you say that yes, it's more looking like an infective or an inflammatory, the first look thing that comes to your mind, or how you approach that case?
Then I'll go for, if in case of fingernail and toenail, like in onychomycosis, there is more chances of involvement of fingernail, toenail. In psoriasis condition, there is more involvement of fingernail. Associated skin finding. If you are suspecting for an inflammatory disorder like LP nail, then there is involvement of other side like mucosal involvement. If you are suspecting psoriasis, then other skin finding, joint involvement, scalp involvement.
Isolated are there, only like you are getting a nail thing, then how?
Then you are asking about the specific nail finding.
What do you look into it?
Sorry, please.
Only if you have the nail finding. How do you say, like, what are the questions you ask your patients and what are the involvement? Like you ask, how did it progress or something like
duration.
that?
Any other complaint, like pain or any discharge or duration or family history. These questions.
Richa ma'am, would you like to add anything to it?
The most important is like the duration of nail involvement. If the nails are involved for a very long time, if there is any discharge present, and most important, whether the involvement is of the toenail or fingernail.
Sir, would you like to add anything?
Occupation. I already asked about occupation. Is it manual labor or housemaid or a manual worker? The history is important thing and occupation is one of them.
So as has rightly been said, if it is an inflammatory disorder, it is more likely to have a symmetrical and chronic changes. And there will be signs like ma'am has said, mucosal or other skin disorders might be present along with it. Multiple nails are generally involved if it is an inflammatory disorder. And like ma'am said, if it were a onychomycosis, a few nails might be spared. So I'll ask, do you do a dermoscopy regularly for this kind of patients? Do you incorporate dermoscopy into your diagnosis?
We often find dermoscopy informative add-on to the cases, like in onychomycosis, as we have seen in the previous slides also, that in dermoscopy we can see the jagged appearance with spikes and all. So that helps in ruling out onychomycosis. In addition, we can do always KOH, obviously, because we have to rule onychomycosis that can be associated with nail psoriasis or nail lichen planus.
Anything you would like to add, Dr. Shrirupa? Do you do a dermoscopy for this kind of patients, or you start the treatment?
I don't do dermoscopy that frequent because it's quite difficult to differentiate between the two. Yeah.
So yes, dermoscopy is something which aids to the diagnosis, and onycholysis is present in both psoriatic or onychomycotic. As has been told by Abhijit sir as well, onycholysis will have spiked irregular border. And this is very difficult to appreciate, but we can have the cues from there. So if nail dystrophy is something that you find in the patient, what helps you say it's more of a nail psoriasis or a nail LP? If pterygium is not present, like the specific pathognomic markers are not present, then how? Like, what helps you say that I will treat this in line of psoriasis and not a lichen planus or a lichen planus? What helps you start the treatment scenario, ma'am?
When nail dystrophy is predominantly matrix related, and you're asking whether the difference between nail psoriasis and nail lichen planus, then I think first difference in lichen planus, there is thinning of nameplate. And in nail psoriasis, there will be pitting, and that will be the coarse pitting. If you're asking about the risk of scarring, then there is more chances in case of nail lichen planus.
Ma'am, you would like to add something to it?
Almost same thing. In nail psoriasis, there will be hemorrhages. You can see that is more prominent. Oil drop sign can be seen, whereas in lichen planus, that is not.
I think in this kind of cases is where dermoscopy actually helps. Psoriasis has the pitting, the salmon patches and splinter hemorrhages, whereas lichen planus will have the melanolichia, longitudinal splitting, and ranunula is present in both, but trachonichia is again something that can be present in both. So talking about investigation, do you investigate any of this patient? Like, do you go for KOH or anything?
If you are suspecting about the inflammatory nail disorder, then I think in most of the cases we go for the clinical diagnosis. The most of the cases.
Do you think there is any existence of both being together?
In that condition, we can go for the nail biopsy.
Directly nail biopsy.
Ideally, we should do a KOH because in most of the psoriatic nails, they have superimposed infections.
Yes.
So ideally, it should be done. But in clinical practice, it's very difficult.
So do you go for an antifungal treatment along with it?
Yeah, in that condition, yeah. See, saying true, in most of the, in some condition, there may be coexisting of nail psoriasis along with onychomycosis. In that condition, we can go for the trial of antifungal treatment.
So will we start the antifungal treatment, or
if we can suspect, then we can go for otherwise we can go for the KOH or culture.
Sir, will you go for past staining or anything
no,
like that?
I always go for, before antifungal treatment, I always go for KOH staining. Generally, culture we can not do that.
Anything you would like to add?
No, KOH I do, because I want to rule out.
As has been rightly said, we should rule out onychomycosis before blatantly saying that it's a nail psoriasis. If we are suspecting onychomycosis, in case there is onycholysis, which is spiked and irregular, there is subungual hyperkeratosis, which can be present in both. But yeah, KOH is a simple test that can help us. Past staining is again, if you have KOH negative, but your suspicion of fungus still remains, past is definitely the go-to. The next thing, nail biopsy, definitely not the first line, but if there is only a single nail involvement and there is progressive disease with risk of scarring, in these cases we can go for a nail biopsy. Please tell me your views on the coexistence of this disease, like onychomycosis with psoriasis, psoriasis with LP. What do you think? Can a patient have both together?
Yes, what onychomycosis and psoriasis mostly they overlap. Most of the times it can.
Any other thing that you think have overlaps or anything you have come across in your
Most of the condition we found there's onychomycosis with psoriasis. Because in lichen planus there is a typical finding like thinning of nameplate, longitudinal striations, rizing, pterygium on tent formation. But in onychomycosis there are some findings overlap with the nail psoriasis.
Anything you would like to add?
Most cases onychomycosis is coexistent with the psoriasis nail disease. So first we should treat onychomycosis, then we can move forward with treating the psoriasis.
Sir, in your treatment practice, have you seen like coexistence of like LP and psoriasis together? Do you find such cases?
No, we can't find LP with psoriasis.
Ma'am, anything you would like to add?
No, I also have not found.
Psoriasis with onychomycosis only, that way.
This is what, because psoriatic nails, the nail plate involvement is there along with the capillary abnormalities which lead to decrease in the natural defense, and it's more prone to develop onychomycosis. So these are the studies that shows that yes, there is a correlation between the two. Another study is of Journal of Onychology and Nail Surgery as well, which says that there was this patient who has nail psoriasis, biopsy proven, and later that person developed an oral and cutaneous lichen planus. So yes, they might coexist as well. Coming to our next case is a 38 years old man who presented with progressive nail changes involving 6 digits for the past 10 months. He reported gradual separation of the distal nail plate, discoloration, difficulty trimming. On examination, multiple nails showed coarse irregular pitting, distal onycholycosis and erythematous border with yellowish orange discoloration of the nail bed and subangular hyperkeratosis. There was no pterygium as such. So how do you approach the case? The diagnosis I think is clear that it's a psoriasis nail. So how do you approach it? How do you see if there is a systemic disease or you find an isolated one commonly? What is more likely seen?
There is a typical finding of nail psoriasis. If there is no systemic involvement or there is no any finding of systemic psoriasis, as you can say, there is a scalp involvement.
Yeah, history of scalp involvement, but he was not on any systemic drugs.
Any history of scalp involvement?
Yes.
And what about the body surface area involvement of psoriasis?
Mild scalp psoriasis.
Mild only scalp psoriasis.
He just said that he had some flakes during the winter, which can be a sebopsoriasis or a seborrheic dermatitis, but we are taking it, it was not a proven thing, but he has a history of psoriasis. We are taking it as a mild scalp.
There is history of any joint involvement?
No.
No, there is no joint involvement, no cutaneous involvement, history of scalp involvement, scalp psoriasis, and duration is only 10 months.
Yes.
And 6 nail is involved. No.
6 nails.
6 nails. Then I think in this condition we should start the systemic therapy because that may be progressive. Along with topical therapy, we can start with the systemic therapy. In systemic therapy, we have so many options. But if any treatment modality, if you people or we are using, that will take time. So first is the proper counseling of the patient because they have so many expectations. But any treatment modality, that will take time, around 6 months to 1 year. So in systemic therapy, we can start with the methotrexate, cyclosporin and acitretin. But in my practice, as I found good result with acitretin. Yeah, acitretin.
Sir, if only 1 or 2 nails are involved as an isolated nail psoriasis, so will you start the treatment? How will you approach such cases?
With isolated nail ulcer, yeah, 1 or 2 nail ulcer, we always go for topical therapy, like topical clobetasol, topical tazobactam, enhance the action of topical clobetasol. Along with, I will go for calcipotriol or tacrolimus for maintenance therapy because it's a progressive disease.
Yes, with 1 or 2 nails only involved, I will go for topical treatment only. But
will you go for intralesionals?
Yeah, intralesional we can go, we can try because it has a good result.
Ma'am, how do you approach?
If the nails are less than 3 in involvement, then we can go for topical. If it is more than 3, and then in that case we can go with oral treatments like methotrexate and all. And acitretin has very good results with pustular psoriasis, so that can also be given for nail psoriasis.
So all we know is psoriasis affects around 2 to 3% of the population. Of it, 40% have a chance of developing nail psoriasis, but the chances are higher if the person has a psoriatic arthritis. If we are talking about the topical therapies, we can go for topical corticosteroid, vitamin D analogs, topical tazarotene, as sir has already mentioned. Topical tacrolimus can be used, but the efficacy has been very variable. Keratolytics can be used, can be incorporated. And intralesional steroid, Shirupa, please can you tell me, if you use intralesional steroid, how many sessions do you expect it to show results, and when do you leave it, or when do you start incorporating a systemic therapy with it?
When there is no improvement, even after 3 injections, I usually start with the systemic treatment, and the injections can be spaced at an interval of 4 to 6 weeks, and the involvement of nail should be less than 3.
As she has already said, usually by 3 to 4 sessions we are supposed to see improvement. If we don't, then we can think of an alternative therapy. Mechanical clipping or thinning of the onycholicotic plate can again increase the penetration of topicals if you are using, and again here we can start the combination therapy as well. So talking about systemic agents, as ma'am had said, acitretin is something. Any other thing that you use, like methotrexate or anything?
Methotrexate also has good results, so we can go with that as well.
My panelists, can you just tell me any role of other intralesionals? Sir, other intralesionals, what do you think, except for intralesional steroids?
I have no experience with other interlesional, but literature says we can go for interlesional cyclosporine or interlesional fipronil, but fipronil is very toxic agent. It can lead to loss of nail also.
Sir, anyone have tried intralesional methotrexate? Something I came across.
No,
I have no experience. So yes, this talks about, this is the study which compared intralesional steroid methotrexate and cyclosporine. Cyclosporine had the least result, and methotrexate had good results, but without the side effects of intralesional steroids. Again, other studies are there which uses the systemic drugs like methotrexate, cyclosporine, acitretin, and even apremilast was an option. Again, biologics, anyone has any experience with it, just for nails? Or you have used it in a patient of psoriasis?
We have used JAK inhibitors like in...
What have you used? Like in a patient of psoriasis?
Nail psoriasis?
No, I am saying the patient has a systemic psoriasis. Have you used, with nail involvement, have you used and seen any improvement in the nail psoriasis as well? I don't think anyone have done it isolated for nail psoriasis.
Infliximab have little bit role. Infliximab, yeah.
Yes, infliximab.
We saw. About infliximab, there is some result.
I think I have just used Adali in PMCH, and some amount of nail improvement was there with time. That's it. That's my only experience. So another study, like, have you ever used lasers for... So this is just a study where fractional CO2 was used, and topical tofacitinib showed a better penetration, and it can be tried in refractory nail psoriasis. So nail psoriasis treatment approach, if less than 3 nails, like ma'am has already pointed out, then we just go for intralesional steroids or topical. If more than 3 nails, we can start with the systemic therapy. Coming to the third case, is a 35 years old with an isolated longitudinal ridging and malonychia for last 2 years. There is no skin lesion. So how will you approach the case, sir?
If a lesion is isolated, we always think about melanoma or benign tumor like melanocytic nevus, and other differential is lichen planus nail. First thing is a clinical one. There is a Hutchinson side for differentiating, and other features of nail lichen planus we can differentiate. Dermoscopy is of course is a good diagnostic clue. And if any confusion, then surely go for nail matrix biopsy. Because melanoma is so dangerous disease.
There are also so many conditions in which we can get the melanoma, like the trauma, there may be a family history, there are also some inflammatory conditions, like you can also get psoriasis, lichen planus, chronic paronychia. It's a, melanoma is dangerous, we should keep in mind, but there are also so many conditions.
Yes, yes. Ma'am, what are the first clinical signs that suspects it's a nail lichen planus? Like, if we don't have a direct pterygium, what are the first signs that you expect to start?
Nail splitting, that is the first.
Will you use dermoscopy to expedite your this? Do you use it?
I don't use dermoscopy, it's quite difficult in this case. Nail biopsy we should do
Nail
to
biopsy.
differentiate, because there we can see a Hutchinson sign, it towards extending towards the proximal nail fold.
As ma'am has already said, for nail lichen planus, the earliest sign would be longitudinal ridging and thinning due to matrix involvement. Other signs that we can see is onychorexis, longitudinal melanonychia. Onychoscopy or whatever dermoscopy actually helps because it helps us differentiate it from the other causes. So, coming to differentiation, if it were sir has said, if it were a male LP melanonychia, we will have longitudinal ridges, thinning, and increased melanin at the basal keratinocytes is the cause. So, dermoscopy will have this regular longitudinal lines with proximal fading. Whereas it was a nevus, we will have regular parallel lines and uniform spacing. But in case of a melanoma, the color would be variegated, the borders would be irregular, and Hutchinson sign is something that will definitely tell us that yes, it is a melanoma. So, clinical criteria, do you use any for LP, like saying it's a severe disease or something like that? When will you call it a severe disease?
If pterygium is present, then the disease is severe.
If anonychia is present or scarring is present, then also.
Then. And when do you start the systemic therapy for it? Starting when the patient comes, do you start with topical or you go for a systemic directly?
We start with topical, and if the matrix is involved, then we should go for systemic therapy.
Which topical do you prefer, ma'am?
Tazarotene, topical steroids, tacrolimus.
All the same. Anything you would like to add, Shruba? If the patient comes, do you start with intralesional or you try with topicals first?
I would, if the involvement of less is, if the involvement of nail is less than 3, then I will start with topical as well as intralesional steroid. And if it is more than 3, then we should start systemic treatment for the nail LP.
Like if a single nail is there, but you see prominent matrix involvement or pterygium development, you won't go for systemic.
Then if there is a pterygium involvement and if the nail plate thinning is quite more, then we can start with systemic therapy, oral corticosteroids.
Oral mini-pulse, oral corticosteroid. Sir, what is your take on intramuscular steroid versus intralesional?
In some reported, in case of childhood lichen planus, there are reports that they use intramuscular corticosteroid for 6 months, monthly dose of corticosteroid, but we have no experience about that.
They say that when you stop treatment for lichen planus, it again recurs. So, how long do you put the patient on treatment? Like there is.
You have to counsel the patient that it will take a long time, at least 6 months to, depending if it is a fingernail or toenail. So, fingernails will take at least 3 to 6 months and toenails will take 6 to 9 months for improvement. So, we have to counsel the patient regarding it. And also the treatment will be longer duration.
Ma'am, if there is a pterygium, will you treat the pterygium? Any modalities that you think can be effective in treating a pterygium? Surgical excision, anything that you do for a pterygium?
Then we can go for surgical treatment.
Lasers or anything that you think can be incorporated, Shirupa?
Lasers, not in pterygium. If the pterygium has developed, then we have to go for a surgical treatment only. But before that, lasers, fractional CO2 laser can be used to increase the absorption of the topicals we give for the nail lichen planus. But the sessions have to be frequent.
Yes.
In short course of steroid, in the starting short course of steroid in form of oral mini pulse along with intralesional, that's going to good result, as I found.
Oral corticosteroids?
Yeah, oral mini pulse for short duration and then for intralesional. In case of lichen planus nail, we got good result, satisfactory result.
So this is something I could find, that if there was less than 3 nail involvement, they started with an intralesional triamcinolone, and again ma'am has said oral or AIIMS steroid was used. Later JAK inhibitors were added. If more than 3, then we directly start with oral steroids or systemic therapy. So systemic therapies like systemic corticosteroids are there. Acitretin, ma'am, any response with it? You have experience with it? Not tried. Sir?
Acetretin, if nail bed involvement is there, I will go for acetretin, and if nail matrix involvement, then I will go for methotrexate.
Sir, any experience do you have with the new molecule tofacitinib?
No. I will rely on the older molecule only.
Cyclosporine, have you tried?
If a patient wants early disease resolution, then sometimes we can go for cyclosporine.
Because it is lichen planus, again
also, methotrexate also gives in some cases.
Definitely.
In some cases.
Our OG, go-to.
Yeah, in some cases, in lichen planus.
Yes. So, chloroquine, hydroxychloroquine, any one of you prefer it? Because we use it in lichen planus, so in nail. Okay. So, yes, these were other I could find. Rofumilast 3% cream. And another was CO2 laser along with the topicals, which enhance the penetration. So pterygium again, Botox was something I could find as a study, was used in pterygium, just mentioning, and others were surgical excision, as has been already told. Coming to our last case. So we have a patient of atopic dermatitis. What are the nail changes that we can expect, ma'am? What are the common nail changes that an atopic child comes to you with?
In atopics, due to continuous scratching and itching, the patient has shiny nails. And especially in children, but in young adults we can see bruise line, then transverse ridges, which is commonly seen in atopics. There will be loss of cuticle and like separation of proximal nail plate, that is commonly seen in atopics.
Sir, do you think this nail changes are because of the disease, or this is because of the chronic inflammation, scratching and everything going on?
No, nail change is because of disease also. There is chances.
Yeah, inflammation do contribute. Do you want to add to it? What do you think, your take on it? Like, is it more of because the scratching and everything, the barrier disruption, or is it because of the disease?
Both actually. Barrier disruption is also there along with the disease.
Shirupa, do you think the nail changes can actually be related to the systemic disease severity? By seeing the nails, can you say that how bad the systemic disease?
Yes, it correlates with the systemic disease severity, the nail changes. As the sir has already told, that it can, in atopic dermatitis, nail involvement is changes can be there, and also because of the secondary mechanism of itching. If the itching will be more, the nails will be more affected.
Definitely. So, yes, the commonest signs would be bruise line and onychomediasis. Chronic paronychia can be present. Trachonychia is again can be present. Mostly the changes are secondary, but again an autoimmune thing is also there. So, it's a combination of both. And this study shows that there is no much of association between the nail involvement and the disease severity. But in this study they have said that if there were lesions on the leg, then the chances of nails involvement is more. So chronic paronychia, if you see in an atopic patient, do you think to treat is as an inflammatory thing, or you treat it more as an infective thing? Ma'am.
For these patients will have to give lots of moisturizer and then treat with antifungal antibiotics.
Sir, sometimes we use these bleaches and everything for oozing things. So, do you think that can be used in atopic, or it just disrupts the barrier more and can increase the problems?
No, I don't use that type of skin because it disrupts the barrier things. Good moisturizer is always better.
will you start topicals just for the nails, or you incorporate it as a part of the treatment?
I will just advise emollients first.
Just
and then,
emollients first.
Just see the results after 1 month. And
JAK inhibitors are the one which has been now being used in a topic. Do you think they have effect in the nail as well? Or will you prefer them in an atopic child over corticosteroid? So chronic paronychia can be present, and yes, ma'am has said emollient is something that comes to a play here. More than steroids or anything, emollient is what will help to repair the barrier and help with the findings of the nail as well. Bleach baths and everything, they actually disrupts the barrier and should be avoided. Treatment again, topicals are the one that help. Antifungals can be added at a short course. And these are the new things that are being used. Dupilumab, I don't know if you guys are trying any biologics in it. So yeah, thank you for this awesome discussion. Thank you all.
Thank you so much, Sripanna ma'am, for such a lucid presentation, and fellow panelists for sharing their experience. I would now request the panelists and the speaker to kindly receive their memento. Now for the next session, I would like to invite respected Dr. Om Prakash sir and respected Dr. Vikash Sankar sir for chairing the session.
Good morning all. It's really a privilege to chair a session with a speaker of such a great stature, Dr. Archana Singhal ma'am. And Dr. Archana Singhal ma'am is Director Professor in HOD, UCMS Medical College, New Delhi. And she has a postgraduate teaching experience more than 30 years in dermatology, and total experience in dermatology is 38 years. And H-index publication is 37, more than 250 publication in PubMed, editor in 4 books, 50 chapters in textbooks, and many more, and national and international presentation more than 400. And she has been proud top 2% scientist list published by Stanford Elsevier for 23 and 24 year 2023 and 2024. And she was keynote speaker in International Congress of Dermatology 2023, Rome. Yeah. She is our editor-in-chief of IADVL and associate section editor in British Journal of Dermatology, IJDVL, right. And mentor Glowderm ILDS 23-24. Teacher, she has received Teacher Pass Excellence Award in 2018. And past president IIDVL Delhi State Branch, founder president of Nail Society, and Professor T. C. Sakia, Oration Northeast, Delhi State Branch Oration, keynote speaker in ONYCHOCON in 2023, Cystopic Oration she has received in IIDVL 2013, and Sundarlal Memorial Award for Academic Excellence in IIDVL 2010 of Delhi State Branch. So we are really privileged, ma'am, to have you here. Thank you so much, ma'am. Please, ma'am. And ma'am is going to speak on onychomycosis, clinical approach, diagnosis and treatment. Yes, ma'am.
So thank you very much, Dr. Vikas, for your kind introduction. And I'm really happy to be here after a gap of 14 years in Patna. I am absolutely thrilled to be here. I bring greetings from Nail Society of India. And as the previous panel discussion was on inflammatory nail disorder, and they were discussing, you know, how to differentiate from the infective conditions, mostly onychomycosis. So I'll be dealing with the approach to a case, suspected case of onychomycosis. So these are the common, nail conditions or nail presentations that you come across. And most of the time, a single diagnosis is given, onychomycosis. Because we generally don't think of other inflammatory nail disorders, and that's the most common. Though this is psoriasis, this is onychomycosis, this is nail lichen planus, and ये वाला ये ठीक है. So this is nail psoriasis, this is onychomycosis, this is nail lichen planus, and this is a tumor. Okay, so all things can be missed for onychomycosis. So there are, naturally it's a very challenging, though it's a very common condition, so common that I prefer to divide all the nail dystrophic cases into two conditions, KOH negative and KOH positive. But it's not so simple. There are many challenges in the management of onychomycosis which can be beginning with the clinical diagnosis. All cases, most common cause of dystrophic nail is onychomycosis, but all cases are not dystrophy or onychomycosis. There are different clinical presentation and differential diagnosis which can be infective, inflammatory or tumors. And as the previous speakers also saying, they two conditions may coexist, mostly psoriasis and onychomycosis. For the lab diagnosis, there is not a single diagnostic test that is confirmatory, and then there are problems with the availability and affordability. Like sitting in a busy OPD, you cannot do KOH, it's not practical. And most of the results are time consuming, because the result of the culture report that comes after 3 to 4 weeks, and in the best of the mycology lab, culture is not positive in more than 60 to 70% of the cases. So you're again left with 30 to 40 cases of onychomycosis which cannot be proven with the lab support. And then do we find economical that carrying out tests and giving therapeutic trial? It's not, right? So we need to have a good clinical diagnosis. As far as the treatment is concerned, again there are treatment related challenges in the onychomycosis, because there is high rate of relapse in the best treatment possible, and it requires long courses of treatment, and the drugs are hepatotoxic. So we have, and there is a limited therapeutic armamentarium, we just have 2-3 drugs, we have terbinafine and we have itraconazole, and there are many contraindications, especially in elderly population. So I'll be navigating through these challenges and trying to make the approach as simple as possible. So who are at risk with onychomycosis? As I said, the prevalence is 50 to 70%. It's more common with increasing age. Males are more affected. Diabetics and patients with peripheral vascular disease are more affected. It is associated with hyperhidrosis, immunosuppression, and genetics plays a role. So what causes onychomycosis? It can be caused by dermatophytes in 60 to 80%, mostly Trichophyton rubrum. By non-dermatophytic mold in 15% cases, and mostly in diabetics, So like scapulary abscess brevicollis, fusarium, aspergillus. And in few percentage, in less than 10%, it's caused by candida, and where fingernails are more often involved than toenails, while for dermatophytic, toenails are more important. So the clinical presentation is variable and depends on where is the invasion of fungus, So DLSO or distal lateral subungual onychomycosis is the commonest presentation, and the fungus enters from the hyponychium, that is below the nail plate, and it goes into the nail bed, and then it affects the nail plate also. In endonyx, it's the nail plate that is involved. Nail bed is not involved. It's only the nail plate which is defective, so you will not have subungual hyperkeratosis, right? In superficial white onychomycosis, it's the upper layer of the nail plate that is involved. So it is often mistaken with keratin granulation. And then there is proximal subungual onychomycosis, which is reportedly characteristic of HIV infection. And then there is total dystrophic onychomycosis, which is the end result of all kind of onychomycosis, whether it is DLSO or endonyx or PWSO. So this is the classical presentation of distal lateral subungual onychomycosis. It is seen not only in adults but can be seen even in young children also, as seen in this case. This is 2 feet 1 hand syndrome caused by Trichophyton rubrum. You can see that there are 2 feet involved, and usually the dominant hand is involved along with tinea manuum. Onychomycosis can also be, so you should look for the corroboratory evidence in the skin, like it can be associated with tinea pedis, and then the diagnosis is easy, because you will not like to make a diagnosis of nail lichen planus or nail psoriasis when patient has tinea infection. Dermatophytoma is a very special case, and it is very important to recognize because this presents as a single or multiple nail bands, and these bands are composed of the compact ball of fungal hyphae, which are very difficult to penetrate by the systemic drugs because of the biofilm production. So the treatment is little different. It has to be a debridement along with systemic treatment. And then there can be pigmented onychomycosis. Every fungal melanonychia is not melanoma. So even Trichophyton rubrum and many dementitious fungi can lead to fungal melanonychia. And this is proximal subungual onychomycosis, which is, I told you, characteristic of HIV infection or immune suppression. Then this is superficial onychomycosis. Endonyx, as I said, is involve only the nail plate, not the nail bed. And this is mixed pattern. So a single patient can have various morphological presentation of onychomycosis. So in this patient you see distal lateral onychomycosis, and this is endonyx onychomycosis, where only the nail plate is involved. And this is total dystrophic onychomycosis. If you don't treat a case of DLSO for a long time, it's going to progress to total dystrophic onychomycosis. Another case. And this is candidal onychomycosis associated with paronychia. So if you see fingernails with dystrophic changes with paronychia, it's most likely to be candidal in etiology. So after seeing all these pictures, we come to a conclusion that to make a diagnosis of onychomycosis clinically, or to suspect a case of onychomycosis clinically, there should be a triad of onycholysis, subungual hyperkeratosis, and chromonychia, or the discoloration of the nail plate, which can be yellow or brown or yellowish brown. And there are many mimics of onychomycosis, that means KOH negative nail dystrophy. So this is nail psoriasis, this is nail lichen planus, and psoriasis is the most important contender for the diagnosis of onychomycosis because both present with subungual hyperkeratosis. But if you see the characteristic of the subungual hyperkeratosis, it is different. How it is different? So you can see corroboratory evidence or skin lesions of tinea or psoriasis in a patient of psoriasis. In onychomycosis, few number of nails are generally involved, while in psoriasis they are more number and they tend to be bilaterally symmetrical. The color of the subungual hyperkeratosis in onychomycosis is yellow brown, as you can see here, and it is friable. This subungual hyperkeratosis is friable, there is tunneling, while in case of psoriasis it is more of whitish and it is more of, this is more solid, right? So these are the difference you can see morphologically when you are looking at the difference of. And then there are differential diagnosis, pachyonychia congenita. Now you see in Pachyonychia congenita nail plate is normal. It's the nail bed keratin K16 which is defective. So the morphology, you have to see there is wedging of the nail plate, but the nail bed is hypertrophic. And then sometimes subungual wart can also be mistaken for, and then keratin granulation which can be mistaken for superficial white onychomycosis. It is more common, the keratin granulation is more common in women who tend to apply nail paint and remove the nail paint with alcohol, leading to precipitation of the keratin that gives whitish appearance. And then this is a case of yellow nail syndrome, which can be, because mostly the toenails are involved, then it can be mistaken for onychomycosis. And trachonychia is another differential diagnosis. So how do you diagnose when you clinically suspect because of the presence of the chromonychia, subungual hyperkeratosis and onycholysis? So there is no single diagnostic test which is confirmatory, and there are issues with the availability and affordability. So this is the long list of tests that can be undertaken, like KOH culture, HND pass 10, PCR, and other tests which are not even available to us in institutions also, like confocal, multi-DTOF, molecular diagnostic tests. Onychoscopy, as covered by Dr. Jha, is a very simple, non-invasive, reproducible, rapid and reliable test. And what do you see? You see jagged proximal edges and spikes. You see different colors which are named as aurora borealis, and you see irregular distal termination or ruinous appearance. So you see in this picture there are jagged proximal margins. This is irregular distal termination and the ruinous aspect. And this is a case of dermatophytoma, where you see proximal spikes. These are the ruin aspect and aurora borealis, and this is the white. In the endonyx you see this dendritic petal, but on a very, very high magnification, not on 10x, which we usually see. And these are few newer findings like the striate leukonychia, fluffy shadows, which can go with the diagnosis of onychomycosis. And you have to differentiate, because onycholysis is present in many conditions, especially psoriasis. But in psoriasis you see a proximal erythematous border, which is very characteristic. It is not seen in onychomycosis. And in traumatic onycholysis it is very bland. There is no erythema, there is no serration, there is no jagged proximal margin. So it's very easy to differentiate the three. KOH, is operator specific and available to us. It's an excellent tool if done properly, and you have to take the sample from. Thank you.
For the next presenter, I would call upon Dr. Jayashruti Singh. Dr. Komal Kumari, Dr. Avish Makkar,
Good afternoon, everyone. Today I am presenting a case report of chronic severe paronychia in a case of pemphigus vulgaris. Pemphigus vulgaris is an autoimmune blistering disorder characterized by autoantibodies against the desmoglein proteins. Nail apparatus involvement is uncommon but well documented. with chronic paronychia being a rare and atypical manifestation may precede classical disease features. Now a 24-year-old woman came to hospital with 5 months history of painful swelling, erythema and crusting of proximal nail folds in all fingernails. The condition was refractory to repeated course of topical and systemic antibiotics and antifungals. 1 month prior to presentation, she developed painful oral ulcers and flaccid blister over the trunk which spread periphery and had little tendency to heal on its own. Clinical examination revealed erythematous bogie periangle inflammation with erosion affecting all digits along with oral mucosal erosions. Histopathological examination of periangle skin revealed the suprabasal acantholytic cells, and with IgG and C3 deposition is a fishnet pattern, which is a characteristic feature of pemphigus vulgaris. And we started patient on oral prednisolone 1 mg per kg per day and MMF 500 mg BD, and resulting in gradual resolution of mucocutaneous lesions and chronic paronychia lesions. Nail involvement in pemphigus vulgaris is rare but well documented, with chronic paronychia being the most frequently reported nail manifestation. Now conclusion, chronic treatment resistant paronychia may present an early or concurrent manifestation of pemphigus vulgaris. A high index of clinical suspicion combined with timely histopathological examination and direct immunofluorescence is essential for early diagnosis and managing the condition.
To what extent was the recovery after the treatment?
Sorry, sir?
To what extent was the recovery after your treatment?
Sir, in the, after 1 month follow-up, patient is improved. Patient has improved. The inflammation has been reduced, and the bleeding is reduced, and patient was doing well after. And then patient lost to follow-up after 1 month.
Was the response parallel to the response to the involvement of skin other part of the body?
Yes, sir. Yes.
It was delayed.
Yes, sir. So skin blisters has been reduced and oral erosions was there after 1 month.
Okay, thank you.
Dr. Shivani Galod. Dr. Shikha Kumari. Dr. Jayant, I would like to request you to come in the front.
Good afternoon, everyone. I am Dr. Shikha Kumari. Today I am going to present a poster on the topic of study of efficacy of pulse therapy of itraconazole in the treatment of onychomycosis. Onychomycosis is a persistent infection of nails with worldwide distribution and approximately 20% to 40% of onychopathy. Long-term treatment with systemic antifungals often leads to poor patient compliance and adverse effects. Therefore, we have to search for newer treatments. Also, nowadays, non-pharmacological modalities like NDR laser and fractional carbon dioxide laser are also in the use. The aim of the study is to evaluate the efficacy of pulse therapy of oral itraconazole, 200 mg twice daily in the treatment of onychomycosis. A total of 10 patients clinically diagnosed onychomycosis, fulfilling inclusion and exclusion criteria, were included in the study. All the patients were advised to take oral itraconazole 200 mg twice daily for 7 days a month for 6 months, and they were advised for follow-up every month for that time. In a group of 10 patients, we had a total of 27 nails involved, and they were categorized on the basis of onychomycosis severity index. Post-treatment, 7 nails were cured, 14 nails showed improvement, and 3 showed no improvement. Therefore, on the basis of our findings, we suggest that pulse therapy of itraconazole is a promising and a well-tolerated option for treating onychomycosis. Most patients respond well, and several achieve complete cure. Thank you.
In your opinion, which is more efficacious, pulse therapy terbinafine versus pulse therapy itraconazole?
Sir, for this we have to do a comparative study, but in our college what we have seen, itraconazole is acting superior to terbinafine.
when do you start with oral pulse therapy with either of the drugs? When do you prefer? In what type of patient do you prefer?
Sorry ma'am, can you repeat?
In what type of patient do you prefer to start oral therapy? Topical is something we tell all patients.
Yes ma'am. Ma'am, in patients where there is proximal involvement because they are immunocompromised, in patients in which more than 3 nails are involved because it consists of severe onychomycosis, and in patients which are recalcitrant to topical treatment, we start the systemic treatment.
All right. Thank you, doctor.
Thank you, ma'am.
Dr. Jayan Tadani.
So a very warm good afternoon to one and all present here. Myself Dr. Jayan Tandi from AIIMS Nagpur, and I'll be presenting a poster on nail being a canvas, case report highlighting cytarabine-induced nail changes, leukomelanonicia. So as we know that cytarabine is a pyrimidine analog, it is a chemotherapeutic agent which has got a central role in management of AML, acute myelocytic leukemia. It has got wide range of systemic side effects, but the cutaneous side effects are very few, and amongst that also the mucocutaneous side effects, the nail changes are rare to see. So in our case we got to have a 25-year-old male who was a known case of AML, acute myelocytic leukemia. We got to the investigation, it was investigation proven with flow cytometry showing T821 translation, and gene mutations are also there, highlighting mutations in RUNX1, TERT and JAK2 mutations. He was on high-dec protocol therapy, means high-dose cytarabine therapy, and he was being referred to us for the nail changes which were there since last 2.5 months. So he was on high-dec therapy for 3 months, and nail changes were there since 2.5 months. So this were the nail changes. Yeah. So these were the nail changes which highlighted that all the fingernails and toenails showed proximal normal nail. There was a transverse melanonic band was there, and a distal part showed leukonychia. So when we have a detailed examine, we called it a dam sign. We call it dam sign because there was a melanonic band which was separating the proximal normal lane and distal leukonychia. And WHO causality Uppsala scale showed a category of certain category was there, and post 3 months of stopping the treatment, his AML resolved, so cytarabine therapy was stopped, and the nail changes reversed. So coming to the discussion part. Here we could see that this case report has the special thing that is there about this case report is that it highlights the oncological adverse effect of cytarabine. Apart from it, it gives new insight on how cytarabine as a drug also. Like pharmacologically we know that it has got role in cellular growth arrest by affecting DNA synthesis. On the other hand, the nail changes that we are able to see, that is because of abnormal differentiation process. So in future we can have further researches which could highlight how cytarabine can affect the keratinization process. And lastly, to conclude, nail is a canvas in which the different external and internal factors leave their own imprints. The with ongoing interest in the new therapeutic agents that we are getting to see, it is very important that we are observant about the adverse oncological effect that will unfold, and we also have to be vigilant about the possible mechanism for it, and that will unfold new insights about the active drug. Thank you so much. These are my references.
So doctor, how did you come to this diagnosis? Was it only the history or was there any specific investigations that also had to do?
Okay, ma'am, we didn't did any investigation on the basis of history only with the temporal correlation of drug. He was on ceteribine therapy for last 3 months, and since 2.5 months, nail changes were there. So temporal correlation and Uppsala scoring, the UMC scoring system that is there, in that it was having certain categories. So through history and relevant clinical scenario only we came to this conclusion.
So for what reason was he put on the drug originally?
Ma'am, he was a known case of AML, acute myelocytic leukemia. Right. So for that, ceteribine was given as a high-dec protocol. High dose ceteribine therapy was given to him.
So what was the alternative treatment that the patient was put on once he was taken off?
Sorry, ma'am.
What was the alternative treatment the patient was put on once he was off ceteribine?
Okay, so ma'am, what happened because the nail changes were benign changes, so we didn't give the this thing that you need to stop the drug. So drug was continued, and as his AML resolved, the ceteribine was stopped for him, and the nail changes reversed.
Okay, so like only after the treatment of AML, once the course was done, the drug was stopped, then you have seen the resolution.
Ma'am, we followed the patient for next 6 months, and in that, like this drug was stopped, and after stopping of the drug, after 3 months, all the nail changes got reversed. Just because the patient was asymptomatic, and for him, ceteribine therapy was important. That like ceteribine high-dec protocol that is there for AML, it has got the best evidence for AML. So we advise for continuation of that.
Specifically for this patient, there was no active intervention taken for the nail
management, yeah. Just the highlighting part is that the nail changes that we are getting to see, because of different chemotherapeutic agents, with ceteribine also we get to see melanonic bands, but in this patient we get to see both the thing from the same drug, like a transverse melanonic band and a distal leukonychia. The combination of this thing, that the combination of nail changes, two different nail changes that are there, that is different about this case report.
Sure. Thank you, doctor.
Yeah, thank you, ma'am.
Dr. Anvesha Moharana. Please follow the time limit of 2 minutes.
Good afternoon. I will be presenting a case report on longitudinal melanonychia secondary to coexistent onychopapilloma and dermatophytoma. Our patient was a 63-year-old male with a 6-month history of progressively dark longitudinal band over the left ring finger. So longitudinal melanonychia in an older individual is always challenging because we have to rule out possible nail unit melanoma. Onychopapilloma is a benign tumor of distal matrix and nail bed, which classically presents as a longitudinal erythronychia, whereas dermatophytoma is a dense fungal mass within the nail plate, which is often resistant to routine antifungal therapy. In our case on examination, initially there was a single brown blank longitudinal band extending from the proximal nail fold to the free edge. There was a distal subungual hyperkeratosis and focal splitting. The Hutchinson sign was absent. On onychoscopy, the brown black band was regular and the margins were also regular. There was a subungual hyperkeratotic material along the band, and gradually the patient developed a yellowish white heterogeneous keratotic mass along the band, as well as with longitudinal splitting. A V-shaped notch was present at the distal end. On high resolution ultrasound, there was an echogenic nodule with shadowing present on the nail bed, and we did a partial proximal nail plate avulsion with longitudinal matrix biopsy and excision of the reddish pink papillary projection present on the nail bed. On histopathology, we can see on the nail matrix there was papillomatosis and acanthosis of the nail bed epithelium, which was, and there was an overlying compact orthokeratotic nail plate. We can see that the keratogenous zone is well formed. In the next figure, there is a fibrocollagenous stroma with scattered vascular channels, but no cytological atypia was seen. In nail plate, there was splitting of keratin layers with some basophilic foci which was suspicious for fungus, so we applied a PAS stain, which was positive for fungal hyphae. So in this case, we saw that onychopapilloma caused a distortion of the nail architecture, producing the longitudinal chromonychia and secondary fungal colonization, forming a dermatophytoma, which itself exaggerated the discoloration and caused a therapeutic resistance. Nail ultrasound did help in localizing the nail unit tumor, but histopathology is always the gold standard to confirm dual pathology and exclude melanoma in such cases. Thank you.
So how was the patient treated?
Ma'am,
If you can highlight
first
again,
to manage the primary pathology, we did a partial proximal nail plate avulsion, and we did a longitudinal matrix biopsy, and we excised the onychopapilloma visible, and post-op the patient was given pulsed itraconazole therapy for the dermatophytoma. With good post-operative care, there was good healing in the patient.
In how many days was the resolution seen?
Ma'am, we followed up the patient for 6 months. The dermatophytoma had cleared and there was no discoloration visible, even though scarring was present at the proximal aspect of the nail plate.
Thank you.
Dr. Soumya Kiran.
Good afternoon, everyone. I, Dr. Soumya Kiran, is going to present the poster on role of onychoscopy in nail disorders. The nail disorder often show overlapping clinical features, making diagnosis difficult on routine examination. But the onychoscopy enables non-invasive visualization of nail plate, bed, matrix, and periungual structures, providing characteristic patterns that aid accurate diagnosis and differentiation of the nail diseases. The objectives are to identify the onychoscopic patterns, to diagnose the utility of onychoscopy and clinical and onychoscopic finding. The materials and method which I have used is a descriptive observational study on the outpatient patients in the tertiary care hospitals. The procedure was detailed clinical examination followed by onychoscopic evaluation using a hand-lit dermoscope. The parameters assessed were nail plate surface, nail bed pigmentation, matrix change, proximal and lateral nail folds. The results in the photo we can see in onychomycosis, the jagged proximal edge, the longitudinal yellow-white stria, the subungual keratosis can be seen. In the nail psoriasis, the regular pitting, the erythematous onycholysis border, salmon patch, splinter hemorrhages can be seen. In melanonychia, we can see parallel longitudinal pigmented lines, and if it is a case of melanoma, then Hutchinson sign can also be seen. In nail lichen planus, the longitudinal ridging and fissuring, the nail plate thinning, trichonychia-like roughness, and dorsal pterygium can be seen. In chronic paronychia, the loss of cuticle periungual erythema and the dilated capillaries can be seen. The limitation of this study is that it is operator dependent and there is limited visualization in cases of thickened and dystrophic nail. The onychoscopic and it does not replace the histopathology. The conclusion is onychoscopy is a simple non-invasive tool that enhances diagnostic accuracy in nail disorder and aid early identification of the matrix involvement, thereby reducing the diagnostic uncertainty and unnecessary invasive procedure. Thank you so much.
Did you diagnose on the basis of onychoscopy findings or you did histopathology to confirm it?
Sir, I couldn't do the histopathology, but I did a KOH mount on various cases. In the onychomycosis case, the KOH mount was positive, and in other cases, it was negative.
For most of the other conditions, it was your onychoscopic diagnosis?
Yes, sir, mainly onychoscopic and the clinical presentation.
Would you recommend the use of onychoscope during routine practice for all nail cases?
Yes, ma'am. It really helps because in every case we can't do the histopathological examination. It is very painful and very very bad for the patient also. So we can do the onychoscopy and we can make the diagnosis, the provisional diagnosis at least we can make.
Okay. And what do you feel is the learning curve for using an onychoscope? Dermoscope. And use it. Of course, it depends on your number of patients that you observe, but what do you feel is the learning curve? How quickly can you identify the signs and symptoms?
Yes, ma'am. We can identify various signs by basically by eye training.
Sure. Okay. All right. Thank you, doctor.
Thank you.
Thank you. Dr. Nikhil Sharma.
Good afternoon, everyone. The topic for my poster is a feature-based approach to Pachyonychia congenita. Pachyonychia congenita is a rare genodermatitis which is caused by mutation in the keratin gene, leading to abnormal keratinization of skin and nail. It is classically characterized by palmoplantar keratoderma and nail dystrophy, though the clinical presentation can be highly variable in terms of association features. Due to its rarity and phenotypic overlap with other keratoderma, diagnosis can be challenging, particularly in settings where genetic testing is unavailable. So, a 21-year-old male remained asymptomatic until 3 years of age when he developed progressively worsening, painful hyperkeratosis of soles, which was accompanied by pruritus. At 4 years of age, similar hyperkeratotic lesions appeared on the palms. By the age of 5 years, the patient developed gradual thickening and dystrophy of multiple fingernails. There was no associated history of blistering, mucosal involvement, dental abnormalities, alopecia, hoarseness, or systemic illness. The family history was non-contributory with no similar complaints among relatives. Cutaneous examination revealed diffuse palmoplantar hyperkeratosis and markedly thickened dystrophic nails. Routine hematological or biochemical investigations were within normal limits. The patient declined both skin biopsy and genetic testing due to personal reason. So, discussion part. The early onset of painful palmoplantar thickening accompanied by progressive nail dystrophy is highly suggestive of Pachyonychia congenita. The manifestations often cause discomfort and affect daily functioning, particularly mobility. In present case, the absence of extracutaneous involvement and a negative family history favors a sporadic presentation or a milder phenotypic variation. When assessed, the genetic testing is limited. Diagnosis depends largely on clinical assessment, detailed history taking, and recognition of characteristic pattern. Accurate clinical diagnosis is important for symptomatic management, patient counseling, and long-term follow-up, ultimately helping to reduce disease burden and improve quality of life. This case emphasizes the importance of a feature-based clinical approach in diagnosis Pachyonychia congenita. Awareness of this is required. Thank you.
What was the primary complaint of the patient?
Primary complaint was palmoplantar keratoderma as well as thickening of nails.
Anything else? Only cosmetic?
Only two complaints
or
were there.
pain or something else?
No, sir. No
Difficulty
involvement of oral mucosa was there. No other complaints. No palmoplantar hyperhidrosis were there.
What did you offer to manage?
So management, where we ask the patient that it is a benign disease and the benign nature of this disease. Moreover, we ask patient to take care of nail to prevent trauma and not to over cutting of the nails. Also for the palmoplantar keratoderma, we use keratolytic agents like salicylic acid as well as lactic acid. Proper emollients were given to the patient.
Is there anything else specifically you want to counsel the patient?
That it is autosomal dominant disease and genetic counseling is much more important in this case, ma'am. Thank you.
Dr. Shumit Shah. Dr. Anukriti Kaushik.
Good afternoon all. I would like to present my poster on Beyond Leukonychia, an unusual presentation of nail myxoid cyst. We had a patient who was a 35-year-old female with a 1-year history of asymptomatic periungual swelling, which was lateral to the midline, and she also had a nail whitening over right thumb. All other nails were normal, and the findings were not associated with any pain, trauma, discharge, or any discoloration. There was just this mild periungual swelling associated with this white longitudinal band. We did an onychoscopy where we found homogeneous white longitudinal band which was not disappearing on the pressure, and there were no surface changes like scaling, debris, or any pigmentary changes, subungual hyperkeratosis or onycholysis. The transillumination was present clinically. We did an ultrasound of the lesion and we found an anechoic avascular cystic lesion which was located at intertendinous location on the dorsal aspect with deeper extent into the distal DIP joint. We also did an X-ray and there was no evidence of osteoarthritis at DIP joint in this patient. We confirmed our diagnosis of nail myxoid cyst on histopathology where we had myxomatous pseudocyst with fibrous capsule. So we also kept differentials of onychomatricoma, superficial acral fibromyxoma, and traumatic true leukonychia. We excluded some of the causes of acquired and pseudoleukonychia on onychoscopy and clinical history, and we excluded other differentials on histopathology. I would like to conclude by saying that myxoid nail tumors are rare but important differentials if we have a patient coming with a history of localized leukonychia, which is unresponsive to treatment, along with a periungual swelling. We have to recognize the lesion early so that we can manage the lesion timely if the surgery is needed. Thank you.
What was the presenting symptoms of the patient?
Ma'am, the patient presented with a white nail, which was a white longitudinal band on the nail, which was long standing from 1 year. She had no associated pain, no associated discoloration other than white color, and no other discharge or swelling. Discharge.
Okay. What was that the primary concern of the patient when she came to the
Yes,
OPD?
ma'am.
Okay. And
in your photograph, you have used the flash mode.
Yes, sir.
So the shine is confusing the actual leukonychia changes.
Sir, no, the photo is not taken in the flash, sir.
How long did you follow up the case?
Sir, we just observed the patient and we asked the patient to do compressions for the swelling.
Was there any effect on the nail plate regeneration post-operative?
Sir, can you repeat the question?
Was there any change in the morphology of nail plate that was regenerating following your treatment?
Sir, we couldn't follow up the patient for a
To that
long time.
extent?
Yes, sir.
Okay. Thank you.
Thank you, sir.
Dr. Shivani Kumari.
Good afternoon, everyone. My topic for today is nail changes in Porphyria cutanea tarda. As we know, Porphyria cutanea tarda is a most common type of porphyria and is characterized by photosensitivity, skin fragility, blistering over sun-exposed areas. All the cutaneous changes are well recognized. Nail involvement is infrequently highlighted, leading to misdiagnosis as fungal or inflammatory nail disorders. So nail changes in PCT result from the porphyria-mediated phototoxic damage as porphyrins, which gets accumulated as the fifth enzyme in this heme synthesis is not working, that is urode enzyme. And this porphyrin takes a UV radiation in the photo range of 400 nanometer to 410 nanometer and causes the phototoxic damage. So this patient was already a diagnosed case of Porphyria cutanea tarda. On detailed history, he revealed that he had a history of blistering over the sun-exposed areas, particularly after taking alcohol. He was a 40-year-old male and he developed the disease when he was 20 years of age. And when we did the KOH mounting, it was negative. Laboratory workup included complete blood count, complete metabolic profile, iron studies, hepatitis B, C screening, HIV screening, CRP, ANA, which were all negative. But the AST upon ELT ratio was 2:1 and elevated ferritin were found, transferrin saturation were increased. The patient had elevated corporoporphyrin and elevated uroporphyrin in the urine and complained of red urine. And this C282Y and H63D gene mutations for hemochromatosis were negative. The patient exhibited distal photoonycholysis involving the multiple fingernails and toenails, predominantly affecting the sun-exposed digits. Additional findings included the nail plate dystrophy with distal nail thickening, surface irregularity, and periungual hyperpigmentation with skin fragility. Associated cutaneous features included hyperpigmentation and photosensitivity upon the sun-exposed areas. The nail findings were consistent with the porphyrin-induced phototoxic damage. And the conclusion is nail changes, particularly photoonycholysis, represent an important yet recognized manifestation of Porphyria cutanea tarda. Recognition of these nail changes can aid in early diagnosis, prevent misdiagnosis, avoid unnecessary antifungal or invasive interventions. Thank you.
according to your reviews and references, what is the incidence of nail involvement in PCT?
Sir, it is an 1 in 50,000 cases. The porphyria cutaneous tarda is this porphyria is already a very rare condition. Among it, the porphyria cutaneous tarda is very common, ranging to 1 in 50,000 population.
Thank you, Dr. Shivani. Dr. Varsha Rani.
Thank you, ma'am.
Dr. Avinash Ashok Tadvi.
Good afternoon, everyone. The topic for my poster is onychogryphosis in a young adult, a rare case. Onychogryphosis is a nail disorder characterized by excessive thickening, elongation, and abnormal curvature of the nail plate. It commonly occurs in elderly individuals with limited mobility, chronic trauma, and underlying neuropathic and vascular disorder. Although often considered a benign condition, onychogryphosis can lead to pain, secondary infection, difficulty in walking, and significant impairment in quality of life if untreated. Case report: a 22-year-old male presented to dermatology outpatient department with complaint of abnormal thickening, deformity of toenails involving both feet for the past several months. The condition was gradual in onset and progressive in nature. The patient reported occasional discomfort while walking, but he denied pain, discharge, bleeding from the affected nail. On clinical examination, right foot fourth toe showed marked thickening, elongation, and curved nail plate. A diagnosis of onychogryphosis was made. Similar nail changes were seen in left foot. Second and fourth toe are affected. There was a positive history of prolonged use of tight-fitting footwear. There is no history of systemic illness, peripheral neuropathy, and vascular diseases, or similar complaint among the family members. To rule out fungal infection, nail scrapings were examined, which are negative. Discussion: onychogryphosis is typically seen in elderly individual but rarely occur in young adult due to prolonged predisposing factors. To conclude, onychogryphosis is an important nail disorder. Early recognition and treatment is important. Treatment includes conservative treatment and surgical approach as well.
For this particular patient, how did you counsel the patient and how did you treat?
Ma'am, we have counseled the patient for surgical, total nail avulsion and matrixectomy. We lost patient on follow-up.
But was the procedure done for the patient?
No, ma'am.
No, so patient didn't continue with
Yeah.
therapy at all. But if the patient does come back, would you still recommend total nail avulsion and matrixectomy?
Ma'am, yes, ma'am. Partial and total nail avulsion with chemical matrixectomy can be performed. Thank you.
This patient didn't turn up for operative management, then which conservative management modes did you offer to him?
Sir, mechanical debridement can be done.
Is there any roles of any topical applications?
Softening agent like urea can be applied.
All right. Thank you, doctor.
Thank you.
Thank you. Our last presenter, Dr. Saman Tanveer.
Good afternoon, everyone. Today I am going to be presenting on the topic dermoscopic approach to longitudinal melanonychia. Melanonychia refers to brown or black pigmentation of the nail plate resulting from melanin deposition. Longitudinal melanonychia is the most common pattern and may arise from benign melanocytic activation, nevus or malignant melanoma, making a dermoscopic evaluation a very helpful diagnostic tool. The patient was 30-year-old male. He noticed the pigmented longitudinal band over the nail plate. Since 5 years, initially it was faint and narrow, which has gradually increased in width and pigmentation over time. There was no associated bleeding, pain, nail splitting, discharge, itching, ulceration or nail fragility. There was no history of nail trauma, chemical exposure, systemic illness or prior nail surgery. There was no intake of drugs known to cause melanonychia. So the parameters that we were assessing on onychoscopy were color variations, bandwidth, border regularity, parallelism of lines, background color, micro-Hutchinson sign, which is periungual pigmentation, which is seen on dermoscopy. It is important to rule out subungual melanoma in this case. And we did ABCDEF evaluation for subungual melanoma, which is age, breadth, color, digits involved, extension of the pigmentation, which is Hutchinson sign, and family history of similar illness. We also did some clinical evaluation to rule out any systemic illness. The results on dermoscopy were as following. The pigmentation were regular, dark colored, parallel, longitudinal lines. It was homogeneous in color, spacing, thickness and orientation over the right index finger. The length was 10 mm and the breadth was 1 mm. And there was no periungual pigmentation seen, which is Hutchinson signs was negative. Based on dermoscopy, the findings are suggestive of benign melanocytic active lesion. So in conclusion, we can say that dermoscopy acts as an important tool, as a non-invasive tool for evaluation of such cases in which we can suspect melanoma, subungual melanoma. Thank you.
Was it your clinical and onoscopic diagnosis, or did you confirm histopathologically? How did you rule out actually melanoma?
So in this case, histopathology was not performed. First of all, the patient was also not willing to go under invasive procedure. He did not want to go under invasive procedure. And secondly, we were evaluating the patient based on dermoscopy. Every 6 months, we were doing evaluation based on dermoscopy, and dermoscopic findings, that is homogeneous pigmentation, parallel lines, no Hutchinson signs or micro Hutchinson signs were present. So we were suspecting a benign pathology only, and 6-month evaluation of this patient was done.
So when Hutchinson sign was not positive, why was the long-term follow-up offered?
Ma'am, just to see any color changes, any irregularity in color or any rapid progression of the disease.
As a safety precaution.
Yes, ma'am, just for safety precautions.
Thank you, doctor.
Thank you.
With this, we come to the end of poster presentation. Next, we will go for the oration in 5 to 10 minutes.
Good afternoon, everybody. Now I would like to request respected Dr. Abhishek Kumar Jha sir and respected Dr. P.K. Roy sir to please join us on the stage to chair the next session, which is NSI oration.
Thank you, NSI, for giving us this opportunity to chair the oration. And who else than Dr. Sujla, Secretary NSI, can introduce Dr. Sushil Tehlani, sir. Meanwhile, she introduces, I request all the audience present, I need a pin drop silence. If you have to talk, please go outside and talk. Even आप लोग भाई बात करनी है, आप लोग बाहर जाके बात करेंगे. मुझे कंप्लीट साइलेंस चाहिए. कोई भी यहाँ आपको बात करनी हो, कृपया बाहर जाके बात करें आप. So thank you so much. Now over to you, Sujla.
Thank you, sir. It's my honor and pleasure to introduce Dr. Sushil T. Tehlani, sir, to you all. He's been awarded the NSI Oration for 2025. So, it is a great honor and privilege to present the curriculum vitae of Dr. Sushil T. Tehlani, the esteemed NSI Orator for 2025. Dr. Sushil T. Tehlani was born on the 29th of August 1956 to Mrs. Leelavati Tehlani and Dr. Tikamdas Tehlani. His parents, whose resilience shaped the family's values, moved as refugees following the partition of India. His mother tongue is Sindhi, and the ethos of hard work, adaptability and perseverance has greatly and clearly guided his life and career. He was born in New Delhi and then he moved to Mumbai during his early childhood, where he has since been rooted and professionally established. Sir has completed his schooling at Navjeevan Vidyalay at Malad, Mumbai, followed by his junior college education at the Jai Hind College, Mumbai. He then began his medical journey at the prestigious Seth GS Medical College and followed by KM Hospital at Mumbai. He completed his MBBS, DVD and MD in dermatology at the same center. After completing his postgraduate training, Dr. Tehlani served as lecturer in the Department of Dermatovenerology under the Mumbai University for a period of 1 year. He contributed to undergraduate and postgraduate dermatology education, and eventually he established his clinical practice in the western suburbs of Mumbai. Over the decades, Sir has continually updated himself in clinical dermatology, dermatosurgery, aesthetic dermatology, lasers, injectables including botulinum toxin and fillers, and has also extensively participated in multiple national and international courses, workshops and conferences, adding on to his knowledge. He brings with him over 30 years of post-MD clinical experience and more than a decade of dedicated expertise in lasers and aesthetic procedures. Apart from holding memberships in IADVL, Nail Society of India and AXI, he has other memberships of various prestigious associations, including being a fellow of the American Academy of Dermatology and the European Academy of Dermatology and Venereology. He has also served as a reviewer for the Indian Journal of Dermatology, Venereology and Leprology and the Indian Journal of Dermatology. He has been a regular and much sought after faculty among multiple conferences for clinical dermatology, dermatosurgery and of course onecology. Sir has also been a chief faculty among various workshops. His academic contributions include chapter contributions in the AXI and IADVL textbooks, and he also has authorship in the textbook of nail diseases, which is a dear project of NSI. This reflects a sustained interest and scholarship in his subspecialties. His areas of special interest include clinical dermatology, nail disorders, lasers, and office-based dermatological surgeries. On the personal front, Dr. Tehlani is married to Dr. Nisha, an MBBS graduate. Their family reflects a strong legacy of medical excellence. Their daughter, Dr. Prerna Tehlani, is an oculoplasty and ocular oncology specialist who is in turn married to Dr. Adit and has the same super specialty. They are proud parents of Mr. Agastya, who is 6 years old. Their son, Dr. Harsh Tehlani, is a dermatologist, married to Dr. Manjit, who in turn is a dermatologist again, and they are blessed with a daughter, baby Mishika, aged about 9 months.
Dr. Sushil T. Tahilyani's life and career exemplify clinical excellence, academic commitment, ethical practice, and lifelong learning. His contributions to dermatology and nail science have inspired generations of dermatologists across the country. It is therefore most fitting that the Nail Society of India confers the NSI Oration 2025 upon Dr. Sushil T. Tahilyani. Congratulations, sir. May I kindly invite you to the dais, sir, to deliver your oration.
I am humbled. I always counted myself as an underachiever. And let me tell you, I was very reluctant, but this has been given to me, I didn't apply for it. So, where does onecology come into my life? As an undergraduate student, as an intern, the examination of nails was only taught in the medicine to look for pallor, cyanosis, koilonychia, clubbing, and I thought I knew enough. And when during internship we were taught how to do total nail avulsion by giving a ring block, which I talk about as a contraindication. Ring block is not to be done. That is how it began. During the PG training, we all learned a little more about how nails are affected by psoriasis, onychomycosis, lichen planus, ingrown nails, pyronychia. Little more interest came because I was in a department with I saw a handbook on onychology by Dr. Peter Saman. But all said and done, procedures wise, I didn't do a single nail biopsy till I did my MD. Though we had a laboratory dedicated to mycologic studies, which was established by late Dr. Sharad Desai. If you know Dr. Rekha Sheth, her father was Dr. Sharad Desai. He had a lot of interest in mycology. The Department of Mycologic Lab was attached to our skin department. But after he retired, it went into, it did not develop well. And I had to travel to Grant Medical College by catching a bus in the afternoon and learn from late Dr. Avtar Kishan Miskin. He was a PhD in mycology. He was very good in his work. So this is a Peter Saman's book which I read. Then I was, as you heard, appointed as a lecturer, so that's a teacher's post. I worked for 18 months in 2 different colleges. But I realized I was spending more time in administrative work, and the salaries were quite pittance, very poor. So I decided to start private practice. Initial investment was a deposit and rent per month in the polyclinic and a spark gap radio frequency electrosurgery apparatus which is outdated. And with this I moved from place to place. Working on the nail disease was still not on the horizon. But standalone clinic, I realized after having worked as a full-timer that I had less time needed for administrative work. And then if you have to grow, you don't need any project reports and return on investment to be made. You just have funds and you buy it, and there's no retirement age. But then you miss the colleagues with whom you could discuss difficult cases. There's a lesser scope for interspecialty interaction. In those days, I had to refer patients, and many of them would not reach the clinic where I referred them. You have to struggle more for growth. For each new step, you need more space. And in Mumbai, the phototherapy unit I have in Bandra Clinic is in a room which, going by the per square foot rate, is 1 crore rupees, only for phototherapy. And there's less time for work on rare diseases. You know, we are busy with number of cases, lesser time for documenting and publishing. By the time you think of working more, next day you've got another lot of patients and there's no retirement pension. You have to provide for your own pension. So what I realized, I always believe, I'll give a few slogans. I believe comfort zone is stagnation. So there's a chart that you should remember. If you don't want to come out of comfort zone, you have fear. But if you decide to cross the fear zone, then there's a learning zone, and then you grow more. That's been my funda. So I attended a dermatosurgery workshop organized by Dr. Satish Sawant, who was my senior in KMGS Medical College. And he saw how he managed ingrown nails. And I started doing surgeries for ingrown nails because I was in a polyclinic and I was not very sure how to do it in a polyclinic. I used to book the theatre in a hospital or nursing home where I was attached and do under local anesthesia, but the growth was slow and arduous. I started with the nail plate biopsies. I removed a couple of Cohen's tumors, and then membership of a group which was quite well known in those days fell upon me, thanks to my teacher, Dr. Uri Fernandez, and he encouraged me. And I realized this is because you're in Bihar. I believe I have studied Sanskrit. I translated in Hindi. The knowledge is the wealth, which is the best wealth. It cannot be stolen from you. No king can snatch it from you. It cannot be divided by your brothers and sisters, and you cannot carry it, and it does not need much load on the shoulders. And more you give it to others, more it grows on you. So then I started with the appointment of fellows in my standalone clinic, and now I have realized that more than 100 people post MD or diploma have worked with me 1 year each. More than 100 have gone through. But these fellows, I used to start my day at 8:30 in the morning clinic. It would go on first till 12:30, then 1:30, ultimately till 4 o'clock. I had enough time to eat in the car and reach the other clinic, and 6 to sometimes 11:30 at night. So then if I had to do surgeries, I had to start before 8:30. So I used to start at 7 in the morning so that I would not be late for my clinic. One of the fellows decided that she should shadow me even during the surgeries. And she had been an observer at Hinduja Hospital under Dr. Nina Bandani, and she saw me doing 2 ingrown nerve cases with matrixectomy in one day. And Dr. Nina Bandani became the scientific chairperson for pre-conference CMA during the Democon 2004 in Mumbai. She told me to speak on management of ugly nails. Now, to speak without any big institutional attachment, always I had the fear that I should not be labeled as an underperformer. So I worked very hard. So mycologic cases I used to take to Dr. Miskin's lab, which was very far from my clinic. Medical photography was a big challenge in those days. And I came across this book and I bought it and actually read it. There's a book on nails by Sher. And actually, because in photography, Dr. ONYCHOCON helped me, I bought a copy for their department also. Then I also believe, after I've read this book by Walter Shelley, Study of Orphan and Unique Patients. So I believe that we have a lot of nail patients or orphan patients. Not many people work well on those. So I decided, and Dr. Shelley believes that you should adopt some orphan diseases and patients. So I decided that I should grow a little more in nails. Then AXI decided to have a book on dermatosurgery. Dr. Venkatara Mesur, editor-in-chief, he told me to write a chapter on nail unit surgeries. Then I had to do more advanced surgery. How do I contribute to the book? I had to justify the invitation. This is a book that came. Then was the birth of Nail Society of India. You know the 2 grand dames, ladies of Nail Society who are there with you. And there are some more people here who are also founders. With them, I got involved and I had more responsibilities on me. The work on nail disease picked up. I got to know the international stalwarts in the subject thanks to these people. And I got a chance to hone my skills to organize conferences. I was told to organize ONYCHOCON, which I did in 2014 and 2019. Some of the pictures from 2014 ONYCHOCON workshop. The tall man is a speaker from Poland. Then the highlight of the ONYCHOCON 2019 was that we were able to rope in Dr. Robert Baran and Dr. Bertrand Richer as international faculty. For all of you, some of you who do not know Dr. Robert Baran, he is now 96 years, active in practice, and he visited us when he was 90 years old. He sat through the full day conference and he picked up 2 factual mistakes in the last speaker's presentation. That's the type of dedication you should have. And then he wanted to visit the caves around Mumbai. I sent him to caves around Mumbai and asked him, I hope you enjoyed it. It must have been tiring. He said, I must admit it was tiring, but I thoroughly enjoyed it. That was his answer. So that should be zest. So these are the 2 people doing the 2019 conference. And then the stalwarts pushed me to contribute on books. I told you, I stand alone clinic. I don't have any original work on nails which I have published anywhere, but I have been able to write chapters in the books. First such invitation came from Dr. Professor Sachiranan. Then Dr. Archana Singhal Madam wrote a book which you saw about. I had got a chance to write in that. And then came the textbook of Onecology by NSI. With this, I would like all of you, if you started liking the subject and if you want to learn more, first step is to become members of Nail Society of India. All of you. Then I believe you have to work hard, dream big and never give up. And I believe in Eklavya model of learning. I am sure you will agree that Eklavya was the first student of distance education. And now because of internet and international conferences, we have more Dronacharyas. And if you plan it well, you don't have to give, Guru Dakshina, and the Dronacharyas are not as rigid and as mean as the original Dronacharyas. So they will not ask for your right thumb. You learn from them. So I have been in touch with these stalwarts, Dr. Robert Baran, Dr. Eckhart Haneke, Dr. Bertrand Richer. Difficult cases I sent to my mentors in Delhi and sometimes to these guys, and they are very happy to guide me. So from being Eklavya, they sometimes think that you're worthy of being a faculty. So I was a AIDV Nail Masterclass faculty in a session they had in Mumbai, and virtual 2 sessions that they had for AIDV members in Europe. That was a humbling experience. And then you get closer to them. So Dr. Bertrand Richer, I had the fortune of hosting him in my house, where he stayed one night. It was a photograph that he had with my family. And this is when 2023 American Academy of Dermatology, I'm with Dr. Robert Baran. He was a faculty at the age of 94, faculty. And Dr. Bertrand Richer, he is a stepson, by the way. Then some other responsibilities came on the shoulders, President of Nail Society of India for 2 years. Maybe I was underperforming there because it was during the COVID time, so we had some virtual meetings. And have been conducting certificate course in mastering nail surgery for dermatologists under the auspices of AIIMS. It's an Institute of Medical and Minimal Access Surgery Training. We have done 2 one-day sessions so far. And first session I had Dr. Vinit Relan, second session done last week. We had luckily Dr. Chandra Grover as a faculty with me. And I will always believe that if your life moves fast, you will get into the last compartment of the train and you will chase that bus, but you should not miss the bus. Otherwise you will be left by the way. A lot of people my age told me, why lasers? Why aesthetic dermatology? Why dermatosurgery? Why biologics? But if you do that, then you get a chance to learn about new science. So I believe that maybe I will be in the last compartment where I should not miss the bus. Otherwise, you have to follow this karma guzar gaya gubar dekhte rahe. Then I believe that for being able to do well, you have to upgrade my skills. Diagnosis skills are upgraded in onychoscopy. Of course, I learned from these people, so we know the end on onychoscopy and ruinous appearance in a single nail dystrophy. You pick up fungus. When you do longitudinal melanonychia, origin of the thing can be judged by looking at this image. It should tell you whether proximal or distal matrix is affected. Ultrasound, all of you should pay attention here. Whenever you pick up a glomus tumor, MRI is not a good standard. Dr. Archana Singhal has yesterday told you, if you have access to high resolution ultrasound, you can pick up 0.3 millimeter size glomus tumor, which is more sensitive than MRI and the patient's phobia of entering a tunnel and less expensive. Not only that, you can use the same machine for color Doppler and find out the nature of the growth. Then you learn a little more of histopathology. And again, a tip you heard yesterday from Dr. Archana Singhal. One thing I'll tell you here, whenever the nail is destroyed, think of malignancy. And whenever you see a wart-like picture, people have treated but it's gone to the proximal part of the nail bed and up to the nail matrix. Human papillomavirus in a benign wart will not invade the nail matrix. So any patient who is 40 years plus, this patient was 55 and has a long-lasting lesion, HPV is oncogenic virus, and this will, as you see, a biopsy done by me showed a well-differentiated squamous cell carcinoma. So you have to learn a little more, and we were lucky that we had Dr. Rajiv Joshi and Uday Khopkar, and for oncology, for malignancies, we had from Dr. Anita Borges. I believe that she passed away during a meeting in Bihar only, a month ago. During the ONYCHOCON 2014, which was done by me at Asian Heart Institute Auditorium, your Bihar Chief Minister of that time, Lalu Prasad Yadav, was admitted for his bypass surgery, and full floor of hospital was booked by his family and his followers. The caterer refused to do catering for a conference, so I had to plead with him. He said he is too busy looking after the VIPs. Connection with Bihar. So surgical skills, I just showed you, so I'll rush through this. I learned how to go beyond the partial nail plate avulsion and chemical matrixectomy. So this is seen by you, so let's not show this again. Then the nail fold surgery. As you see here, sometimes the ingrown nail is because of onychocryptosis, where the nail fold is at fault. If you, in this patient, do partial nail plate avulsion, the nail which is already short will get shorter and the nail fold will come further onto it. So in such cases, you have to touch not the nail plate and the matrix, but the nail fold. So this is a patient whose lesion is, area of incision is marked, and you have to take, after proper hemostasis, incision along these lines, which goes up to the bone. So anyway, got the idea. So this is how you expose it up to the bone, and then you close it. And the patient, you follow them up to document. And if you see the patient before he saw me and 90 days after the surgery, so you realize that you've done a good job by not touching the nail plate. So this was next upgradation. Then the third thing on the wish list was to do a total nail unit excision. But I was not confident enough, because we know that as the dermatologist I may damage the extensor tendon, and I have to be sure that I am fast enough so that I don't have to release the tourniquet every 15 minutes. So I involved a plastic surgeon, hand plastic surgeon. This is a patient, total nail unit excision and full thickness graft. But then I realized that they are not sensitive to our requirements. So now next thing on the bucket wish list is to attend nail surgery course on EADV and learn a little more focus from the nail surgeons who do all those surgeries. And one more thing I have realized is we have to try and create a footwear-induced nail dystrophy clinic. That's on my wish list. Because footwear-induced nail dystrophies are as common as onychomycosis, and they are missed. You have to take help of a podiatrist, a foot surgeon, and footwear manufacturer. As I told you, these are often missed, and varied number of nail lesions can be induced by footwear, and dermatologic literature is extremely sparse on the topic. Thank you very much. These are two images from my visit yesterday morning to Harmandir Sahib, Patna, and to the Mahabali Hanumanji's Mandir, Mahavir temple.
Thank you, Dr. Sushil. As a teacher, I never expected that nail could be a part of the Nail Society of India National Congress, because we never thought about this, never was taught about this, and never taught about this. Nail as a part of psoriasis, part of this and all. But last 2 days, we have been speaking about nails so much that I think this will be a major this event. And thank you, Sushil, for such a thing. And now I can't start now, but I'll learn something from you people by attending the congresses. And now to present the oration, Dr.
I will like to invite, sir, kindly. I would like to join us, the President of NSI, Dr. S. Sachidanand sir, the Founder President, Dr. Archana ma'am, Dr. Chanda Grover ma'am, Secretary NSI, Dr. Sujala, Joint Secretary Dr. Vishal Gaurav, Dr. P.K. Roy sir, Dr. Vikas Shankarji, Dr. Swatlina Pradhan,
Vice President Dr. Shikha Bansal.
Vice President Dr. Shikha.
All of you will agree with me that Dr. Sushil Tailani, in his long journey with the interaction with nail diseases, he has nailed the nail diseases, and in turn he has got nailed to nail. Now he's wedded to nail, so he deserves to be, the fit person to deliver this NSA oration. I request all of you to give him a standing ovation, please. A standing ovation.
I would like to invite Dr. Tulika Rai ma'am and Dr. M.K. Sinha sir on the dais for the next session, for chairing the next session. Thank you.
सर मैं हो गया इंट्रोडक्शन, so I will start.
Welcome, Dr. Archana Singhal.
Thank you, sir.
So, I need not read her these, details, credentials. Okay. So everybody know you. So you need no introduction.
Thank you, sir. Thank you.
So you please start your presentation.
Thank you. So, on behalf of the NSI, I congratulate Dr. Sushil Taliani once more for the NSI oration. And whenever there is, ONYCHOCON, it's a very, very overwhelming moment for all of us because we founded it 13 years ago, and to see it at this stage is very, emotional moment for all of us. So thank you. And thank you, Dr. Svetlina, for changing the, scientific session, because of I have to rush to catch the flight. I'll be speaking about the management of glomus tumor. I bring greetings from Nail Society of India and I have no financial disclosures to make. So glomus tumor are considered rare. They are the benign neoplasm arising from the glomus body. We all know that glomus bodies are AV anastomosis, which are involved in thermoregulation. They're mostly found in the subungual region of the finger, though they can be found even on the palm or rest of the body, but that's extremely rare. And they account for 2% of the all hand tumors. In fact, majority of the plastic surgeons and other people, they do not know actually that glomus tumor or the subungual glomus tumor falls in the domain of the dermatologists. They're more common in women in 20 to 40 years of age group, and finger is the most common site. Very often, like out of 30-35 cases, I've come across only one case of big toenail glomus tumor. That was bilateral. So it arises from the modified smooth muscle cells of the glomus body. This is the diagrammatic representation of the glomus body. As you can see, you must have read it. And this is the AV anastomosis. And so it is composed of the glomus cells, which are the modified smooth muscle cells, which contract on exposure to cold, and that's why these tumors are very, very painful. They have smooth muscle cells and blood vessels, which are arranged in the form of nest or called zelbulan. So they present with triad of symptoms, that is intense localized pain, which can be spontaneous or on minor trauma or cold, and point tenderness. Sometimes they present with bluish discoloration, which is round to oval in size on the nail plate, because they are in the nail bed. So the overlying nail plate show discoloration, and when they are present in the matrix, they press on the matrix, and that lead to nail deformity, ridging or split. I'll show you how they look like. And Loewe's sign is when you press the lesion, suspected lesion, with the blunt end of the pin, it causes sudden excruciating pain. And Hildreth test is positive that when you raise the BP apparatus and then when you bring down the mercury, you lose the pressure, it suddenly gives rise to the pain relief. So the diagnosis is can be done on the onychoscopy, but it is which shows reddish or pinkish hue under the nail plate, or discrete linear vessels in the form of telangiectasias. The most important diagnostic tool is high resolution ultrasonography with color Doppler and MRI also in certain cases. So this is how the tumor will present on the finger. This is like the blue This is like the bluish, red-blue discoloration on the finger, and on onychoscopy you can see there is a reddish-blue patch which gets intensified on the onychoscopy, and you have to use it because you are using it for nail bed, so you have to use it some contact point and the polarizing mode, right? Because you are looking for the lesion in the nail bed. While in the nail matrix, the lesion is here, but it is pressing onto the nail matrix, and that's why there is a split in the nail. So patient will come to you with intense pain and split in the nail, or there can be and this is the onychoscopic view of the lesion, and you can again see intense red or erythema which gets magnified on onychoscopy. And this is another presentation, another patient where the lesion is present extending onto the lunula, which is the visible part of the matrix. So the lesion was very big and it was involving both the distal and the proximal matrix, and this again is leading to the split. This is our ultrasonography. You can see this, margins. It can easily delineate the margin even when it is less than 3 mm in size, while on MRI it shows as a radio opaque or radio dense shadow which is well circumscribed, and sometimes there can be a scalloping of the underlying bone because of the prolonged pressure. And on color Doppler you can see the blood flow which confirms the vascular nature of the lesion. So you can see this is the nail matrix tumor, and this is so big, involving both the and in fact this can also be given, that this tumor is about 8 mm in size, which is involving both the distal and the proximal matrix on MRI. So surgical excision is the treatment of choice and curative in majority. I had shown the videos last evening. And if the excision, it's an encapsulated tumor, so it is usually, excised in toto. So unless and until there is a sister tumor which is missed and it cannot be picked up on MRI or on ultrasonography, there can be recurrence. But that particular tumor which has been completely excised is not likely to recur. Recurrence rate is 5 to 10% due to incomplete removal or sister glomus tumors missed to be picked up on MRI, and there is very low risk of malignant transformation to glomeangiosarcoma. So we, like long ago, probably 5 years ago, we published a clinico-epidemiological profile and management of subungual digital tumor in 15 patients. There were total of 16 tumors with female predominance, and most common site was the thumb. So when the glomus tumor is on the nail plate, just for the sake of those who did not attend the surgery, there are still pictures. The principle of nail surgery remains that to save as much as nail plate as possible. So this was the glomus tumor. We are removing the nail plate from the underlying nail bed, and we sacrifice the distal half of the nail plate beyond the tumor, and we made a vertical incision. I emphasized it again and again that in the nail bed the ridges are perpendicular and the blood vessels are also perpendicular, so the incision is always vertical, while in matrix the incision is always horizontal. So I made a nick, vertical nick in the nail bed, and you do blunt dissection to expose the tumor, which like pops out because it's very encapsulated. So you do blunt dissection with the forceps and the tumor comes out. It can be removed in toto, and you can see the underlying bone here, right? So if the defect is 3 mm or more than that, then you have to do little undermining and you suture the nail bed lesion in vertically, right? Vertically. So this is 2 points are suture nail bed lesion vertically and suture nail matrix lesion horizontally, and save nail plate as much as possible. And this was the tumor which was 5 mm, and this was after 1 month. And this, the new nail will cover the nail bed, right? So that again emphasizing this is a very important carry home point. So another case, 27-year-old working woman which had been presented with pain to surgeons, orthopedic surgeons, and both time the nail plate was avulsed, but it was not done. So if the glomus tumor is in matrix, you have to retract the proximal nail fold to expose the matrix region, and for that retraction of the proximal nail fold to expose the nail matrix with the help of the nail plate elevator, on the proximal nail fold. Then you place the stay suture after giving 2 lateral incisions at the junction of the proximal and the lateral nail fold. The matrix has been exposed. Then you have to, open up the nail matrix. Nail plate has to be removed, but its attachment on one side has to be retained because it can be replaced, and it acts as a wonderful biological dressing. So I have taken out the nail plate, but it is attached on one side. Then you again do the blunt dissection after horizontal incision because the lesion is in the matrix, right? And this is the tumor that was there in the matrix. This is the space after the excision of the tumor, and this tumor is again 5 mm in size. And then you suture the matrix defect in horizontal fashion, put the nail plate back and suture the side lateral incisions on both sides, and then you cover with the dressing. You change the dressing after 2 days, give painkiller, antibiotics, and all excised. And this is a very interesting case where we saw that the tumor is in the distal part of the nail. The MRI showed that the tumor is in the distal part of the phalanx. Patient was complaining that the pain is there on the distal part of the nail bed, but when we did ultrasonography, high resolution ultrasonography, we realized that it is very close to the hyponychium. So instead of going through the nail plate, we went through the hyponychium. You can see this is the intact nail plate, this is hyponychium, and we made just a incision, like I call it fish mouth incision, and you could see that a big glomus tumor was lying distally on the digit. So ultrasonography, if you are present there, fortunately I was there when the ultrasonography high resolution Doppler was being done, so we could see that it's very close to the hyponychium, and we can take a distal approach rather than a complicated approach. And this was the easiest glomus tumor removal I have ever done. So every excised sample, whether it is glomus tumor or anything else, has to be sent for histopathological examination. And you can see these are it's a lobulated tumor with a fibrous capsule, and these are the endothelial cells lined. These are the blood vessels lined by endothelial cells, and you see glomus tumor here, glomus cells in the myxoid stroma. So the carry home point is that glomus tumor is rare, but actually they're uncommon, I should say. I should not say rare, because we see every month or 2 months, and they are the leading cause of treatable severe nail pain. There is high index of suspicion is necessary. High resolution ultrasonography with color Doppler or MRI is the investigation of choice, and surgical excision is curative in majority of the cases. It's an extremely rewarding surgery because patient leads a very difficult life. His quality of life is very low who have glomus tumor. Thank you very much for your kind attention. This is my very learned cat actually.
Thank you, Archana ma'am. Though it's a very rare condition, it's a benign.
It's not a rare condition, sir. I think it's not being that, or patient don't know where to come actually.
Okay. So, we know it's a benign condition.
Yes, sir.
How far it is, you think that it can be turned into a malignant one? Is there any case if it turns a malignant type of tumor?
No. The malignant transformation to
glomus tumor,
glomangiosarcoma is very rare. Never seen actually. The chances are 0.03 sometime, like that. So it's a benign tumor, but it's very painful. That's why it has to be excised.
There are no chances of turning it to a malignant one.
It's very little. I said 0.03%.
For the treatment part of it, you follow this rule of 10 of glomus tumor or what?
Pardon, sir?
Rule of 10.
Rule of 10?
Yeah.
Yes, sir, I
So rule of 10 means 10% in pediatric cases, 10% it is familial, 10% is other, due to some other reason associated with neurofibromatosis and all. No.
Sorry, my apologies, I am not aware.
Okay.
Thank you, ma'am, for such an informative
Thank
talk.
you.
I have seen just 3 or 4 cases and I've gone for MRI. So next time, that's a new learning point.
Yeah, everyone must started doing because it's a very rewarding thing for the patient and for the physician. Thank you.
Sushil sir.
No, so just to comment, for MRI, ask for a high resolution machine, which should be at least 15 megahertz, ideally 24 megahertz, and the probe should be linear, hockey stick probe, not round probe.
Even 15 to 18 megahertz should be okay because that's available in almost all the institutions.
Thank you so much, ma'am, for such a wonderful session. I would request the chairpersons and speaker to please receive their memento.
डिस्चार्ज हमको लैपटॉप डिस्चार्ज हो गया था इसमें स्कैन मत करो ना विदाउट स्कैनिंग विदाउट स्कैन विंडो मेरा पैन पेन ड्राइव तो निकालो हाँ तो लग जाएगा वही तो पूछ रही थी मैं तेरे हिसाब से
I would like to request respected Dr. Chandra Grover ma'am and Dr. Shikha Bansal ma'am to please come on the dais to chair the next session.
Now I invite Dr. Swetalina Pradhan to talk on a very important topic of nails as window to internal organs.
Ma'am, just 1 minute.
Good afternoon again. So I'll be speaking on nail is window to internal organs. So nail, I mean to say, when we say ourselves a dermatologist, so there is a misconception it is only to the skin. So the skin dermatology includes skin, hair, nail, mucosa, everything. So as I use, because skin is the mirror to your internal organs, so nail is as a part of skin also mirror to the internal organs. So they are very small surface, but there can be a very good diagnostic clue and for bedside examination clue for different systemic diseases. So nail matrix and nail bed are biological records of systemic health. They reflect chronic illness, metabolic health, nutritional deficiency, or any vascular insult. So the nail changes in systemic diseases could be simply classified into 3 types, that is less specifically associated. There are some specific findings of systemic diseases and then associated with some disease of each organ system. So in less specified changes, there are splinter hemorrhage. Less specified means they are not pertaining to any specific disease. They can be in more than one diseases. Splinter hemorrhage, fused line, koilonychia, onycholysis, fitting. In specific to systemic disease like Mees line, Muirk lines, half and half nails, teres nails, and to the organ system like cardiopulmonary system, GI, renal, connective tissue disease, nail being an important point, the clue to the CTD, hematological, endocrine, metabolic, and specific syndromes. So we'll be briefly summarizing each of them with some interesting cases. So coming to the koilonychia, it is nobody in the MBBS only we learn what is koilonychia. We are being taught it is seen in iron deficiency anemia. So it can be seen in coronary artery disease, malignancy, splinter hemorrhages, that is extravasation of blood from longitudinally oriented vessels in nail bed. Ma'am was saying vessels are arranged in longitudinally in the nail blade. So they are seen in mostly infective endocarditis, rheumatic heart disease, APLA, SLE. Views lines, they are temporary suggestion in the nail growth causing a band-like depression in the nail plate. So when there is a transient arrest in the nail growth leading in a severe illness, acute illness, systemic infection, coronary artery disease, psychological stress, then onycholysis is separation of the distal separation of the nail plate from the nail bed, seen in many diseases like pertaining to dermatology, psoriasis, in other systemic diseases like Sézary syndrome, bronchiectasis, thyroid disorders. So nail pitting, so your nail pitting, this is a very good question for our the postgraduates, how you different type of nail pitting in alopecia areata, psoriasis, LP, how you differentiate. So this is then lichen planus. Onychocysia, that is horizontal splitting of the nail towards the distal portion. It is mostly traumatic, but sometimes with other findings in the skin, you can diagnose, suspect polycythemia vera also. So then coming to the leukonychia, so it is true, apparent and pseudo leukonychia. I am not going into the specific pathogenesis. So apparent leukonychia is, that is Muirk line, it's seen in hypoalbuminemia, teres nails in mostly liver diseases, half and half nail, that is white, half proximally, half and white half is proximally is white. So it is seen in mostly chronic kidney disease. And true leukonychia, mostly in our belt, this part of the Bihar, we see a lot of chronic arsenic toxicity patient who present with this true leukonychia. So nail and specific organ. So specific findings. So this is my area of interest, that is connective tissue disease. So mostly we see SLE, systemic sclerosis and dermatomyositis, where nail fold changes are very important clue to diagnose CTD. So coming to SLE, nail fold erythema, edema, that can be classical common manifestation of SLE. Sometimes there can be in fact splinter hemorrhages. Then you can, so capillaroscopy is a very good tool nowadays, but your eye should be tuned enough clinically to see CTD, so that only capillaroscopy will help you not diagnosing CTD. You should diagnose clinically also looking at the nails. So coming to systemic sclerosis, so you know what is the binding down of skin, shiny, taut skin, and there will be Raynaud's, findings of Raynaud's leading to digital ulcer, digital pitted scar, that round finger pad sign, and medutan, that is called medutan sign, and parrot beak nails. can be found in systemic sclerosis. And if you see in onychoscopy, the next speaker is going to specific on the CTD, so I am not going to discuss onychoscopy. So, I mean, dermatomyositis, so same SLE, dermatomyositis, both will have a nail fold erythema, edema can be there, but ragged cuticle, that is me sign, is more specific towards the dermatomyositis. Then rheumatoid arthritis can have also red lunula. Then periungual erythema can also be found, splinter hemorrhages can be found in rheumatoid arthritis. Musculoskeletal disease, reactive arthritis was discussed in detail in the morning, so I am skipping. Then psoriatic arthritis, so there will be all, you know, psoriasis, nail changes, oil drop sign, views line, salmon patch, etc. Then coming to endocrine and metabolic disorders, plumber nails. So penless distal onycholysis related to thyroid acropathy, seen in mostly hyperthyroidism. Brittle, slow growing nails, it's seen in hypothyroidism. Then yellow nails in diabetes. Then cardiopulmonary disease, we see in MBBS read clubbing is a feature of cardiopulmonary disorder, cyanosis, clubbing, heart disorder. Then infective endocarditis, splinter hemorrhages, red lunula. Then GI diseases, can see, you know, already discussed in liver disorder, you see various Terry's nail, then true leukonychia, Muir nails, hepatobiliary diseases. Then leukonychia, that is half and half nails in kidney disease. Then hematological anemia, iron deficiency, already have discussed. Then gray and blue nails, that is seen in splinter hemorrhages, in fact. So syndromic association, some specific syndromes, they have also some nail changes, that is yellow nail syndrome. So they have a cutaneous manifestations, all finger and toenails will be yellow and dystrophic. Then there will be respiratory involvement, lymphatic involvement, so this all comes under yellow nail syndrome. Then nail patella syndrome, that is there will be nail dysplasia, patellar hypoplasia, elbow dysplasia and iliac horns. So this is the picture of nail patella syndrome. Then in our case we will commonly see in tuberous sclerosis, kidney tumors. So there will be a fleshy color growth, pink papules or nodules underneath the nail or from proximal lateral aspect of the nail fold. So this is seen in tuberous sclerosis. Then Osler Ober-Rendu syndrome, also known as hereditary hemorrhagic telangiectasia. You can see periungual telangiectasia, nail fold telangiectasia. Patient will give history of recurrent mucocutaneous bleeding. So there will be this one recurrent visceral AIIMS. So this in short I told you various specific, less specific nail changes in various systemic diseases. So I will discuss two case scenario. So this first known case of SLE, who patient was diagnosed 2 months back. Patient was on treatment with 30 to 40 milligram of steroid, prednisolone and hydroxychloroquine 200 BD. And she suddenly presented to us with sudden appearance of erythematous macules, patches over face, trunk and extremities associated with fever, joint pain and oral ulcer. Patient had a background of SLE and she landed up in suddenly with this type of skin lesion. So erythematous macules and patches. So straight away patient was having fever and anybody will diagnose as SJS or TN. So it is not going to SJS, now leading to TN overlap. So patient was SLE, she was on SCQ. For joint pain she has taken indomethacin, some painkillers, many drugs because they have a lot of problems. So in between also they homeopathic. So now, so this patient you see, known case of SLE and this is the finding of skin. So this is how how you diagnose, differentiate it is whether it is a drug induced TN or it is SLE TN, TN-LE. So patient investigations were like there was anemia, Coombs test was positive, proteinuria, LFT was deranged. So look at her palm and soles, you can see pointer is not working. You look at her nail fold, so they are so red. Erythema is specifically confined towards the toe and fingernails. This is the same patient. So YTN will confine to the nail fold erythema in a background of SLE. This is a very clue towards maybe the patient is having 10 LE. So mucosa involvement was less severe, and the nail fold erythema was a clue towards patient is having. This is not drug induced, this is the SLE manifestation only which the patient has presented to us, and so we diagnosed provisionally as 10 LE. So patient was already on 40 milligram prednisolone when she presented to us, it's a 10 LE. So patient was febrile, joint pain was persisting. So prednisolone continued, but on day 3rd you see total 10. So total detachment of the skin occurred, more than 90% body surface area. So there by the time ANA, 4-floss, everything came, reports came by the time. So final diagnosis of 10 LE, patient was already on 40 milligram prednisolone, so we gave him a dexamethasone pulse therapy. So and with this, patient improved, and then patient was tapered to, after pulse therapy, 60 milligram prednisolone. Then the report came, there was a finding of LE in the histopathology. So patient luckily survived and was discharged on 21st day of admission. So how you differentiate TN, drug-induced TN and 10 LE? Patient was having a background of CTD, and there are less severe oral mucosa involvement, but in this patient periungual and nail erythema, and there was a, if we do a dermoscopy, you can see a better finding, a nail fold capillaryscopy. So then will guide towards this is a manifestation of LE, this is not a drug induced thing. So adequate amount of steroids should be given because patient was already on 40 milligram prednisolone, so to arrest the disease in the 10 LE. Coming to a second case, this is a 1.5-year-old child. So the boy presented with this kind of erosions. You can see there is a perioral erosions, reticulate type of erosions over the face, and there was a peeling of the skin from the palm and sole. Nails were very brittle nails. So there is perianal, and there was perianal, so there was alopecia, fresher alopecia, ulceration of the scalp. So patient was, you can see, very lethargic. Patient was not having eye contact, lethargic patient, bacha. So anybody, perianal, perioral erosion will think of zinc deficiency. But patient is lethargy. Always zinc deficiency patients are very irritable. So if you give zinc, first thing to go is irritability. So patient is sleeping, lethargy, nothing responding, and you see it is called zinc deficiency mimicker skin lesions. And you see the alopecia, there is a nail changes, there is a skin changes. So which is the vitamin or molecule which connects all these? This is the biotin. So we suspected why this patient is lethargy. Patient was having a seizure. There was a movement disorder. Patient was admitted to pediatric neurology department. So we suspected biotinase deficiency. Patient was already on zinc therapy. And you know, any patient goes to pediatrician, they start iron, zinc, everything. Patient was already on zinc. So it was not improving. So we stopped the zinc, we gave her biotin. And by the time we sent a genetic testing, you see with biotin, the erosions, dramatic improvement started improving. And so this is how the patient was having other biotinase deficiency, presence with seizure, developmental delay, skin rash, alopecia. You can see other hearing and respiratory problems, which if you will not treat, will subsequently develop. Because the child was small, so if you will not diagnose early from the clues, so here clues, skin is both in the zinc, but hair, nail, skin, and the zinc deficiency mimicker manifestation guided towards so biotinase deficiency. So mimicker of zinc deficiency, so zinc deficiency, same manifestation, but periacular, more involvement in biotinase deficiency, and child will be mostly irritable in zinc, lethargic in biotinase deficiency. So this is the bacha now with biotin only, smiling, so lethargy is improved, now skin lesions, there is no recurrence. So to summarize, skin doesn't only mean skin, it includes mucosa, hair and nail. So it is a window and or mirror to internal organs. What mind doesn't know, eye cannot see. Hence, sensitize your brain with various changes in skin, and here it is the nail, which will guide you early diagnosis of systemic diseases and avoid unnecessary investigations. I hope this presentation has sensitized your brain to nail being a part of being window to systemic organs. Thank you.
Thank you. Thank you, Dr. Svetlina. This was indeed a very engaging presentation with such interesting cases. Like the last one was really a bummer. And beyond the routine points that we discuss of nail manifestations in systemic disease, you've taken us to the practical aspects. So thank you so much. If there are any questions? Thank you.
नहीं टूटा नहीं है, वो निकल गया है, वो लग जाएगा, लाई लगा दो, लगा दो।
Thank you so much, ma'am, for such a comprehensive and insightful session. I would request the speakers and the chairpersons to please receive their memento. For the next session, I would like to invite on stage Dr. M. Mukhtar sir and Dr. Dheeraj Kumar sir to chair the next event. Sirs, kindly come on the dais.
Connective tissue disease will be continued in nail as a window of connective tissue disease. And the discussion will be done mainly on the capillaroscopy. So the speaker is Dr. Vishal Gaurav. So over to you, Vishal.
So good afternoon, everyone. At the outset, I would like to thank the organizers for inviting me to give a talk on nail fold capillaroscopy. This topic has been very dear to me since my mentor has been Dr. Chandar Grover. So at UCMS, you cannot skip without knowing nails, right? And somehow this is an interface between microscopy and gross examination. So I got fascinated by it very early on. So let's start. Let's see, why do we even need to look for these nail changes in CTDs? So these are three major studies which I could find involving involving the nail changes in CTDs. And you can see in almost all of these studies, at least 60% of our patients do have nail manifestations, right? At least 60. It can go up as high as up to 90% in some studies. Okay, so let's see, why are the nails getting involved? In psoriasis, we know that they get involved in lichen planus, but why do they get involved in CTDs? They get involved, the central pathogenetic mechanism is the microvascular injury, right? That is what is leading to majority of the manifestation. At the same time, do remember that the histology in CTDs, especially when we talk about SLE and dermatomyositis, it shows interface dermatitis, which is similar to lichen planus, right? Where you have a lichenoid inflammation, but in CTDs, it is pauci-inflammatory, vis-a-vis lichen planus, where it is inflammation rich. but the changes are going to be the same. Therefore, you will have changes which will mimic nail lichen planus, right? So when this interface dermatitis occurs at the nail matrix, you are going to see all the changes which you see in lichen planus. So you see longitudinal ridging, you see nail plate thinning, you see the pigmentary changes, and you also can see red lunula, again which can be seen in lichen planus as well as psoriasis, right? Similarly, if we go on to the microvascular injury, that injury can lead to a lot of mechanisms which trigger so many things. For example, when it occurs at the nail fold, this microvascular injury will lead to periungual erythema and inflammation. And it will also lead to splinter hemorrhages in the nail bed. When this microvascular injury causes fibrosis, that will affect the this one. So here we can see, so when there is microvascular injury, we also know that this leads to fibrosis in systemic sclerosis. And when there is fibrosis, remember, we always forget that the nail gets its shape, as well as, in fact, we can say the mother of the nail in actually true sense is the bone. You will see in all the congenital disorders which lack a nail, essentially also lack a distal phalanx. So when there will be acroosteolysis, what will happen? You can guess, the nail will become obviously shorter, right? So you can see whenever there will be fibrosis, the shape of the nail is going to change. So you can have the beaking, you can have pseudo clubbing, and you can also have increased longitudinal as well as the transverse curvature of the nail. Similarly, matrix melanocyte, we already talked about, it's just like lichen planus, right? You have the residual PIH because of the melanophages. Similarly, when it is occurring at the matrix level, what you will have is pigmentary changes, right? And when, obviously, whenever there is chronic inflammation and all these which goes on, that leads to sort of tells the epidermis that you need to proliferate, right? And that leads to the ragged cuticle which you see. Okay, so everything has a basis to it. We just have to understand. So let's look at the nail fold changes which you can actually see in CTDs. I think ma'am, Shwetila ma'am already talked about all these changes, right? So I'm just going to skip through them. This is important for quiz, so all those who are sitting for quiz, you can take a picture. So what you see in rheumatoid vasculitis are these bywaters lesions. So they can be here as well, or they can be acral also. They are also known as pulp hemorrhages. So you can have hemorrhages on the finger pulps. In Samit sign, you can have a hyperkeratosis of the cuticle, right? So cuticular hyperkeratosis. And Koenig sign is something which is again debatable. Few people say it also refers to bleeding nail folds, but in most of the textbook, it's referred to as painful tender edematous nail folds, which you see in dermatomyositis, right? Okay, these could be the pigmentary changes which you can see. So in fact, there was one study which was published in JARD where they said that if you have multiple longitudinal melanonychia as well as nail fold erythema, then the chances of CTD is quite high. But remember that these pigmentary changes can also occur due to the drugs which you are using in CTD, especially hydroxychloroquine. They can permanently stain the nails as well as temporarily stain the nails. These could be the nail bed changes. There could be splinter hemorrhages in the nail bed, subungual hyperkeratosis, onycholysis. There could be just erythema or nail bed pigmentation as well. And these are the ones which I think this has already been covered. So we can have round finger pad sign, we can have these scars, we can have pitted scars, we can have ulcers, necrosis, as well as sclerodactyly related changes. Now let's come to the So what are the highly observed nail changes which are present in more than 25 to 30% of the patients are these nail changes. Others are less frequent. These include periungual erythema, ragged cuticle, longitudinal ridging, onycholysis, and nail fold telangiectasias. Others are less frequent. Now let's come to nail fold capillaroscopy. I think as a PG, I was always confused between USB dermatoscope and a nail fold video capillaroscope. I think you all would agree. Most of the times we are not sure what's the difference. There is a difference, and we'll talk about it. So this is in brief the history of NFC. Important thing to remember is that actually the foundation was laid much earlier, but it was Reynolds who was the first one who tried to study the NFC changes with ischemic changes, and it was actually his thesis work where he did this. And another name to remember is Cutolo, because his work in NFC has been quite significant. He was the one who actually tried to classify them into early, active, and late stages. So this is what the microvasculature of the skin looks like. So you can see why the nail folds, because you know that the vessels are generally oriented perpendicular. So right, when you take a cross section, what you are going to see are those dots, which you see in most of the conditions when they are dilated. Whereas on the nail folds, they are running parallel to the skin. That's why you are able to examine the capillaries at a length. So you can see a significant length of the capillaries, and you can make out the morphological as well as the architectural changes which is happening there. So what all can be used? We can use all of them to see nail changes. But when it's a quiz question, then the answer is always nail fold video capillaroscopy, because all the parameters are standardized for 200x. These can aid us in the OPD, but they will not aid you in MCQs, okay? Or for writing a short note. So you can use actually all of them, but the gold standard would be a video capillaroscope. So what is a video capillaroscope? This is the device. It looks very much like our USB. So what actually you can say is, when you have our USB dermoscope and you have a software which can give you whatever I'm going to tell you further, if it is able to give you those specific points, then you actually have a nail fold video capillaroscope. So let's look at it. So this is how you will look at the capillaries. They will look under the handheld microscope, and this is how they will look under the video capillaroscope. Always remember, when you write the NFC findings, there is a mnemonic to it. It's type 2 diabetes mellitus. Okay? So you see it's the technique, T. You have 2 Ds, density, dimension. You have 2 M's, morphology and microhemorrhages, and last is interpretation, which obviously you are going to do, right? So if you try to jot down these points whenever you are doing a nail fold video capillaroscope, it will likely be helpful rather than writing down everything what you see on the video capillaroscope. Okay, so important is to acclimatize the patient. Obviously the patient has to be rested, he should not be running. You allow the patient to settle down at least for 15 to 20 minutes. The patient should not have had a cigarette or anything. Then you choose the nail which does not show much of hyperpigmentation, and all these things have to be taken care. And the hand should be at the level of the heart, because if it's lower, there is going to be venous congestion, and if it's above the level of the heart, then there are chances to find false positive avascular areas. Okay, so this I have already told you. Let's look at this. This is very important. So how many fingers to examine? So there was a study which was conducted. Here you might ask me, what are these percentages? So these are the percentages compared to the Euler criteria. So patients have been diagnosed according to Euler criteria, and they did NFC, and they found out that if we do NFC in 8 fingers, the sensitivity is 74.6%. Whereas if you choose just 1 finger, it drops down to below 50%. Right? So that's why it's important. And practical, I would say, would be a 2-finger method, because in a busy OPD, you will not be able to see all the 8. But 4 and 2 are easily doable. Okay? So which one to choose? Actually, it should be the non-dominant hand. And you have to choose just one, use the ring finger. Okay? So these are the images which you should capture. Obviously, ideally it should be 4, but practical would be 2. The 2 medial ones are the ones which you should take. Now let's go on to what we should see. So these have been divided into 2 parameters. One is the quantitative and another is qualitative. Quantitative, the most important to remember, is the mean capillary density, which is the distal most row. So, and the standard is to take 7 to 14 is the standard. Anything which is less than 7, that is more than or equal to, less than or equal to 6 will be considered a lower density. Again, remember, it's lower density, it's not pathological. You just say that the density is lower. Right? So like for example, here we can count the distal most row, 1, 2, 3, 4, 5, 6, 7, 8, 9, right? And here you see 1, 2, 3, 4, 5, right? 5 capillaries. So obviously it's less than 6. You only calculate the distal most row. There has been classification which has been proposed based on this, based on the number of capillaries which you see and what percentage of reduction it likely denotes. And then we move on to the qualitative parameters. The first one is capillary dilation. And so this includes two terms. One is a dilated capillary and another is a giant capillary. A giant capillary is the one which has a diameter of more than 50 microns, whereas a dilated is the one between 20 to 50 microns, right? You may ask, it's actually a quantity which you are writing. Why is it a qualitative parameter? Because it has to be defined that the tips, when we are talking about, there should be no abnormality in the tips, because if there is any abnormality in the tip or the morphology, they will be classified as abnormal morphology and not as capillary dilation. Okay? So this is how a dilated capillary will look like. So this is a giant, this is a dilated capillary, and this is a normal capillary. Then these are microhemorrhages. Obviously they are brown because of hemosiderin. So this is another qualitative parameter which you see, right? Then you look at the dropouts. So if there is only one capillary which has dropped out, you will call it as a capillary dropout. Whereas if there are two consecutive ones which have dropped out, that will be known as the avascular area. So here you have a capillary dropout here, whereas here you have a avascular area. Okay, then there are other parameters like tortuous capillaries. So the afferent and the efferent limbs are tortuous. Generally they are present in less than 5% of the vessels, but when they are present in more than 10% of the vessels which you have visualized, then it will be known as increased tortuosity. Again, increased tortuosity does not mean pathological. Okay, for example, here you can see. Similarly, there are forms which are known as the crisscross forms, where the afferent and the efferent limbs or the afferent and the efferent limb of adjacent capillaries cross over. So this is known as a crisscross form. Again, if there are two crosses, then you call it as, then it is considered normal. When there are more than two crosses, then it becomes abnormal morphology. And similarly, there could be other. So these are all morphological variants. There could be bushy capillaries like this one, where there are buds and then there is branching. There could be ramified capillaries, there could be meandering, as this is a meandering capillary which has more than two crossovers, 1, 2 and 3. And then anything which does not fit into these morphologies is known as a bizarre capillary. Similarly, there is a term called dystrophic capillary which we don't use because many of the authorities don't advocate it. So these are ramified capillaries. Without branching, you see those buds. So after having learnt about so these are normal shapes which we just talked about, and these are the abnormal shapes, right? So there is just one slide after this. So these are the indications which I don't need to go through, but just one slide which I would like you to see. So this is the slide which is actually the summary of everything. So in the clinic, what do we do? So you just have to divide them into two patterns. One is the scleroderma pattern and another is the non-scleroderma pattern. So the rule is very easy. Let's go to this slide. This one. So if the density is more than 7, then what do? You look for a giant. If there are no giants and the density is more than 7, then your image belongs to category 1, which is non-scleroderma pattern. Whereas if the density is less than 3 or you have any giant, then your image belongs to category 2, that is you are looking at an image of a scleroderma pattern. right? So you may ask, and this is where I would like to end, but you may ask, why do I even need to do? I know a patient, when I see a CTD patient or a systemic sclerosis patient, I know that this is a patient of systemic sclerosis. Why should I even do it? Because at dermats, we are very good at picking patients of DM, systemic sclerosis, SLE. Remember, this can be used there, but this is primarily for cases where you are not sure. MCTD, you don't know, you are not able to fulfill those criteria. MCTD again belongs to the scleroderma pattern, right? You have unexplained Raynaud's. You want to rule out whether it's primary or secondary. That is where you want to use it. And in fact, doing serial nail fold capillaroscopy, and in subsequently, if you see that there are reduced capillaries, you can predict end organ damage. It is now validated, and we have enough data that if you sequentially do NFC and you see that the morphology is deteriorating, the density is decreasing, the patient is likely to land up in, digital ulcers, ILD, pulmonary arterial hypertension, even cardiac, involvement, as well as GI involvement, because all these are ultimately related to microvascular damage, right? So start doing NFC, and I'm sure you're going to love it now. You can use those two, algorithms. All these papers are from Cutolo and by Dr. Chanda ma'am. So you can go through these papers. These three are have been my primary sources. The first one by Cutolo, where he actually gave a sort of review. The second one is a review which was published in IGDVL, and another is also by Cutolo. So go read these articles and you will be able to go, and do onychoscopy in your patients. Thank you.
Thank you, Dr. Vishal, and this is such a wonderful presentation. If you any question from the audience?
Thank you so much, sir, for such a wonderful session. I would now request the chairpersons and speakers to kindly receive their memento. Now I would like to request Dr. Gaurav Das sir and Dr. Nazan Shagufta ma'am to please come on the dais and chair the next session.
Good afternoon, everyone. After many enlightening talks, I would like to call upon Dr. Debapriya Paul. He was a resident in our, senior resident in our hospital, AIIMS Patna. Now currently he is the faculty at AIIMS Guwahati, assistant professor. I would like to ask him.
Good afternoon, everyone. Respected dignitaries on the dais, respected senior faculties and colleagues. I will be talking on 20-nail dystrophy. So my scope of discussion will include what is the entity called 20-nail dystrophy, what are the different types, causes, how to evaluate a patient, and including the common differentials we'll see, and also the treatment options and some recent advances. So what is 20-nail dystrophy? 20-nail dystrophy is also known as tracheonychia. It is characterized by roughness of the nail plate associated with longitudinal regions, giving a sandpaper-like appearance. So the tracheonychia term derived from two words. One is trachos, meaning rough, and onychia means nails. And this 20-nail dystrophy term can be sometimes misleading, as this condition not necessarily always involve all the 20 nails. Sometimes some normal nails can also be there. And also just mere involvement of all fingernails and toenails does not make a diagnosis of 20-nail dystrophy. We have to look at the morphology of the lesion. So it is common in children, and the most commonly affected age group is 3 to 12 years. Males are more frequently affected in children. In adult onset, there is a slight female predominance. And also some case reports of genetic predisposition with autosomal dominant pattern has been reported. Now coming to the different types. So Barron in 1982, as Dr. Robert Barron, it was already discussed, he classified it into two subtypes. One is the opaque variant and one is the shiny. So the opaque variant is the classical one where it presents with thickened nails with longitudinal ridges. While the shiny variant, it presents with uniform shiny nails and with some fine stipple pits will be present. And pathogenesis wise, the opaque tracheonychia occurs as a result of persistent inflammation to the nail matrix, while the shiny variant is secondary to mild, intermittent and focal insult to the nail matrix. So this is a figure of opaque variant where we can see thickened nail with longitudinal ridges, and the shiny variant will have a shiny nails and very fine stipple pits. Next is causes. So we should always remember that the most common cause is the idiopathic, and after idiopathic there is alopecia areata, vitiligo, atopic dermatitis, and also onychomycosis, psoriasis can be associated with tracheonychia, and rare causes like juvenile dermatomyositis, PRP has been reported in some cases. Also there is report of drug association, and also there are many miscellaneous causes. So this is a case report showing 20 nail dystrophy in a patient of leprosy, where there is brownish black discoloration and crumbling of all the fingernails and toenails, and biopsy has proven presence of histiocytes and virchow cells. And there is another case report secondary to acitretin, secondary to drug, that is acitretin, where patient after taking of 2 months of acitretin has started developing tracheonychia, and after around 5 months patient has developed significant tracheonychia in all the fingernails. So now how to evaluate a patient if the patient presents with tracheonychia? First thing is the age at presentation. This is very important for the prognosis part and to explain the disease course and prognosis to the patient. As we know that in children most of the cases are idiopathic and will have a spontaneous resolution. However, in adults usually there will be a longer disease course and it is usually associated with some secondary causes. So that part is has to be seen at presentation, and after that we have to evaluate whether it is idiopathic or whether it is associated with some secondary cutaneous or systemic conditions. So for that personal history and family history has to be taken in detail regarding atopy, whether any past history of alopecia or currently present has to be examined, and followed by that meticulous examination of skin, mucosa, hair and nail has to be done to look for any systemic associations. In suspected cases of onychomycosis, nail clipping can be sent for KOH examination. And we should always remember that it is a clinical diagnosis and there is very less role of biopsy. And biopsy is ideally advised not to be done because tracheonychia is a non-scarring condition and it will resolve spontaneously without any scarring. If we are going to do biopsy in these patients, then it will ultimately result into some form of scarring. And biopsy should be preserved only for recalcitrant cases and those cases which are not responding to treatment or not spontaneously resolving after longer time. So there is a now alternative of onychoscopy, biopsy in a idiopathic middle-aged female of psoriasis who was given weekly methotrexate therapy and tazarotene gel, and we have in the follow-up we have seen good improvement around 6 months after 6 months of therapy. So this is another patient of lichen planus who was given weekly methotrexate with OMP, and significant improvement in the nail findings were seen after around 3 to 4 months of therapy. So apart from this systemic therapies, we can also give low dose acitretin, but again acitretin has been reported to cause tracheonychia in a case report. Apart from that, oral biotin has been tried, hydroxychloroquine also has been tried. In recent advances, tofacitinib has been reported to improve significantly. One case where 5 mg BD was given, followed by which there was gradual tapering, and significant improvement was seen. In another case, fractional CO2 laser was combined with topical therapy, where 2 sessions of fractional CO2 laser was done, and these were the parameters used, along with a topical mixture of tacrolimus, urea, salicylic acid was given for daily application, once daily. So this was the pre and post photos. And another case report, there is reported combination of flucinonide and bifonazole cream, which is, this is a case series which reported significant improvement with this combination. So thank you. I would like to thank Dr. Swajalina Pradhan ma'am for guiding me, and also Dr. Rashid sir for the clinical pictures.
Nicely presented by Dr. Debopriya. Is there anybody having any queries related to this topic? Okay. Thank you.
Thank you so much, Dr. Debopriya sir, for such an insightful session. I would request the speaker and panels to please receive their memento at the dais. I would now like to call Dr. Ghazal Ahmed ma'am and Dr. Smita Prasad ma'am on the dais to chair the next session.
Professor Dr. Chandar Grover ma'am needs no introduction. It's all on the board. So over to you, ma'am.
Thank you. Thank you so much. The next topic that I'm supposed to speak on is an approach to melanonychia. This one is tempered with as per the age groups where it is manifesting. At the end of this session, we expect that you understand the etiopathogenesis of melanonychia, recognizing various clinical patterns, utilize onychoscopy to evaluate it better, take appropriate biopsy wherever and whenever it is indicated, so that all of us can manage the condition effectively while ensuring that not a single potential malignancy is missed. So first we'll talk about what is melanonychia, then melanonychia manifesting across different age groups, the clinical features of the different types of melanonychia, and in the end we'll discuss a management approach. So any brown black discoloration of the nail is called melanonychia. Mostly it is the nail plate, but uncommonly it could be the bed also. Etiology is commonly melanin, but uncommonly other chromogens may also be responsible. You know of the different patterns. It can be longitudinal, transverse, total, diffuse, or even irregular patterns. It's the most common pattern is longitudinal melanonychia, most commonly affecting the thumb and the great toes. It's largely a benign pattern, especially in our skins, the skin of color, and it's almost universal in the black population after 50 years of age. How does melanonychia occur? How does melanin enter the nail unit? We have had this morning session on the dermatopathology. Melanin in the nail unit is derived from the nail unit melanocytes, which are in fact numerous. It's just that they are not active. Melanin is composed of granules derived from the matrix melanocytes, which produce the pattern of longitudinal melanonychia. So anything running through the nail plate means it's originating from the matrix. The melanocytes are
located in a higher density in the matrix as compared to the nail bed. They are normally absent in the nail plate, which is just composed of the keratinocytes, onychocytes, which have lost their nuclei. The melanocytes are present generally in the lower 3 layers of the nail matrix epithelium, and they are physiologically dormant and inactive, and only half of them are activable. Why do they start producing melanin? It can be because they get activated, which is the cause responsible for most cases of longitudinal melanonychia. At times they may be proliferating also. When they are proliferating, the proliferation may be benign or malignant. So in that proportion, the proportion keeps on reducing. Then you could have melanin of extra melanocyte origin, that is fungi, the phaeoid fungi producing melanin. At times drug deposits may also be simulating the same process. We know that the nail plate is formed from top to bottom, that is the proximal most part of the matrix is giving rise to the top layer of the nail plate, and the distal matrix giving rise to the bottom layer. So the location of melanonychia within the nail plate can roughly guide you towards its potential source of origin within the nail plate, within the nail matrix. So there are varying patterns of melanonychia, as I said, longitudinal, transverse, diffuse or melanocytic lesion of the nail bed, that is a nail bed melanonychia, not matrix melanonychia. It can be of varying colors. It can be varying number of bands. All this will keep on giving you clues towards what is the cause of this particular melanonychia that you are dealing with. There can be varying origin of the pigment, that is melanocytic melanin, extra melanocytic melanin or non-melanin pigment. The melanocytic melanin can either be reactivational, activated melanocytes or proliferated melanocytes, and the last category in proliferation is of malignant proliferation, which is further subdivided into these histopathological categories, which is the basic reason for taking a biopsy. Now let's talk about how it varies across age groups, because that is the point of interest today for this talk. In children and adolescents, it is often a benign melanonychia. It is rare for a melanoma to be present in children, even with an alarming pattern of longitudinal melanonychia, less than 20 cases reported worldwide. It can be congenital or acquired, that is a congenital melanocytic nevus or lentigo, and the acquired variety can be result of melanocyte activation, which can be trauma, friction or constitutional. The zigzag pattern is specifically reported in childhood melanonychia. I'm not sure how clear this is, but the whole band does not have regular edges. It has zigzag edges, and those zigzag edges conventionally may make you think that there is something abnormal with this melanin, but this is a normal pattern when seen in children. Longitudinal or this particular study of melanonychia in children had included 40 patients, 40 children less than 16 years of age who had presented either with longitudinal and total melanonychia, and they found that it was a nevus. It was a nevus. This particular slide is not showing up. Okay, I'm not sure. I'll just, it is a study by Gottman et al. Published in 1999, which is the basis of this thing, in which they found 19 cases to have nevus, lentigo 12 cases, and functional melanonychia in 9 cases, that is the activational. And that is what, this was a white skin study, so proportionately the proportions will differ in our kind of skin. In adults, that is young adults to middle age group, melanonychia can be more sinister. So here, trauma, friction, infections remain the common causes, especially in our types of skin, and systemic diseases should also be ruled out, including Addison's disease, hemochromatosis. But a new onset band should always be, and especially if it is single, should be looked at with suspicion. In older adults, melanonychia, that is beyond 50 years of age, it is more likely to be related to malignancy, which could be a melanocyte origin malignancy or even the non-melanoma skin cancers, which again give rise to melanonychia. Drugs is another common cause because of the possibility of polypharmacy in these patients. Benign causes like seborrheic keratosis and other nail tumors, including a pigmented onychomatricoma, may also be there. So how do you approach once you see a melanonychia? First point is to confirm that this is melanin. This is a melanonychia. For that, onychoscopy is very helpful. Once you're sure that this is melanin, then you have to think in terms of whether it's a melanocyte activation or a melanocyte proliferation. And activation is benign, but a proliferation can be benign or malignant, and these are the three different causes of proliferation. For this differentiation, right from step 1 to the last step, for this differentiation, onychoscopy is very useful, because if you follow the scheme of examination of the surface color, the free edge of the plate, and the proximal nail fold, you can decipher answers to almost all these things. For example, this particular melanonychia seen under the dermatoscope, it's a gray-brown color, not very well-defined margins and very light color. This is generally melanocyte activation as compared to a black band which is showing the presence of small pigment granules on the side. This is a proliferation. This is a marker of melanocyte proliferation. You have to look at the distal end, which tells you probable origin in the matrix. So like in this particular case, melanin is present over the lower aspect, the ventral aspect of the nail plate. That means the origin of this particular pigment lies somewhere in the distal matrix. You also have to look at the proximal nail fold to look for different clues here. So the top arrow shows you a pigment granule. Granules appear when it is a proliferation happening, and the bottom arrow shows you what? I'm sure you all know. What is this bottom arrow pointing at? Pseudo-Hutchinson sign. Very good. This is Hutchinson sign. This is pseudo-Hutchinson sign, the band being seen only through a transparent nail fold or a transparent cuticle, while this is micro-Hutchinson sign, a band, a spread of pigments seen only with the help of onychoscope, may not be visible to naked eye. So once you start distinguishing the features of longitudinal melanonychia due to these four causes, the melanonychia here is going to be polydactylous, relatively pale, light brown, ill-defined borders, grayish background, not very discrete but regular parallel lines, no crisscrossing, and these are the various causes. So causes can be numerous, especially in our skin, and since morning we have discussed many of these causes which may give rise to melanonychia. It can be called the racial, ethnic or the functional melanonychia seen in almost all our nails. Local traumatic causes, that is friction, the type of footwear that you are wearing, all this is important contribution. Various dermatologic disease like psoriasis, especially lichen planus, which is associated with melanonychia, all are responsible. Nutritional causes like B12 deficiency. Endocrine causes like Addison's disease, Cushing's disease. Drug-induced causes, especially the chemotherapeutic drugs and anti-malarial drugs. These are the various drugs which can potentially cause melanonychia. Transverse melanonychia, as a rule of thumb, is generally drug-associated as compared to longitudinal melanonychia. You can see the various shades of color in this particular child who is on chemotherapy. Tumors, as I told, the non-melanoma tumors are also responsible for melanonychia. This includes Bowen's disease, onychopapilloma, pigmented onychometricoma. Biopsy is rarely needed when you are thinking in terms of a activational cause. It's rarely indicated. So your onychoscopy can give you the clean chit and you can follow up. But if you do a biopsy, you will be seeing no increase in melanocyte number, but increase in melanin and at time even pigment incontinence. Melanocyte proliferation is suggested when the melanonychia is mostly monodactylous. It can still be polydactylous if syndromic. For example, syndromes associated with multiple lentigenes like Lozier-Hunziker syndrome. The band characteristics, that is the dark color and the sharp edges, point towards a proliferating cause. Syndromic melanonychia is the proliferative one associated with multiple lentigenes, especially Peutz-Jeghers, Lozier-Hunziker syndromes, etc. Onychoscopy in this case is going to show you a brown to black background with multiple lines in between, but all of them are parallel. And histopathology is going to show you actual nests of melanocytes in the location from the origin. Management here is nothing. In case the patient is much disturbed, the whole excision can be done. We had discussed, we had a case yesterday and we have done that, and that patient can be followed up further. The nevus is the most common cause of longitudinal melanonychia in children. These tend to regress over a period of time and are mostly junctional nevi. They tend to be monodactylic, similar to a lentigo. Onychoscopy will show you this brown band with lines in between, very regular lines, but here you see the pigment granules which have been pointed out for you. Histology will show you well-defined nests. Such lines tend to be very stable, may also evolve during childhood and evolve very fast, enough to cause concern to the parents. For example, this triangle sign that you see, the melanonychia band being broad at the base and tapering towards the end. This raises suspicion that this might be a malignant proliferation. But in children, as I said, because numerous studies have shown that this is a rare possibility, even triangle sign is not much of a cause of worry in small children. In children, the approach is watchful neglect as compared to adults where you need to excise a proliferation. Subungual melanoma, contrary to popular belief, it occurs equally in all racial groups. So we may not be having that much of cutaneous melanoma, but we have equal incidence of subungual melanoma. Our issue of John's, which we are releasing today in the inauguration, focuses on melanonychia and melanoma as a cause for these bands. The peak incidence is seen in 5th to 7th decade, though even childhood cases are known, 20 to 23 reported only. And LM, longitudinal melanonychia, is often the first sign in two-thirds of these patients with subungual melanoma. We have the ABCDEF criteria for that, which is slightly different from the ABCDE criteria for cutaneous melanoma. Monodactylic with lichenoid alterations of the nail plate surface in the form of splitting, thinning, even destruction of the nail plate are seen in these cases. Of course, these are advanced features. We should be detecting them much before that. Onychoscopy will show you the pigment lines, will show you the pigment granules, but these lines are not parallel. They tend to have a zigzag pattern, and it's up to us to pick up the Hutchinson and the micro-Hutchinson sign. Onychoscopy intraoperatively can also be done to characterize this band in this location. This outcome is something which we should avoid at every cost. This is years of neglect and not being able to diagnose the cause of nail pigmentation. Histopathology is very important. Next, coming to extramelanocytic origin of melanin, which is fungal melanonychia. Pheoid fungi, pheoid agents are the ones which are capable of producing melanin. Why is it a cause of worry? Because now it is associated with poorer response to your antifungals. So the response to antifungal enhancement, that is how your lasers work in this location. Non-melanin pigment is often known as the pseudomelanonychia, and we all of us have seen these patients coming to us with a subungual hematoma who are worried about a melanoma and the band is evolving, and onychoscopy is very useful for us in these cases. Bacterial melanonychia or chloronychia, as we had discussed in the morning. If it is dark enough, at times the patient may be afraid because of the blackish appearance. I'm just finishing. Approach to a management in these different age groups has been outlined in textbook of onychology, where in children you generally have a watchful neglect policy, but in adults you should be keen on doing the histopathology and diagnosis relatively early. If not possible, it's better to excise the origin. Relevant investigations depend on the clinical scenario that you have been testing. So history and examination are going to play a role here. Matrix biopsy is the gold standard investigation for evaluation of longitudinal melanonychia. No amount of onychoscopy will give you the information what histopathology has to give you. But the biopsy is not to be done from the band, it is to be done from the origin. And this is the follow-up after the closure. The histopathologic diagnostic criteria for LM are defined on the basis of the histopathology of the specimen. Nail clipping histopathology, if you're not able to do a nail matrix biopsy, at least a nail clipping histopathology should be done for your cases with melanonychia. It's effective, non-invasive initial diagnostic test, because in melanoma it will show you the presence of melanocytes or melanocyte remnants, And special stains will help you rule out the infections as a cause for these disorders or even nail psoriasis. So this is the histopathological information only from nail clippings that you can get without doing an invasive biopsy. Management is dependent on the thickness, and it's different for the in situ, invasive and stage 3 or 4 nail apparatus melanomas. So to conclude, trauma is the most common cause of of longitudinal melanonychia, but melanoma always remains at the back of our mind. We should always have a complete thorough history and examination to rule out systemic disorders, drugs, and even aging as a cause of melanonychia. And this could be your approach based on the age of the patient that you are seeing. Thank you so much for your kind attention. Please become members of NSI. Please contribute to Journal of ONYCHOLOGY and Nail Surgery, a flagship journal by NSI, the only nail-devoted journal in the world. Thank you so much.
Thank you very much, ma'am. I just have one question from my side. Ma'am, in children, most common cause is trauma. Is it one-time trauma or repetitive trauma?
So trauma to the nail is actually a very big umbrella term for repetitive types of trauma as well as one-time trauma. One-time trauma with subungual hematoma can give rise to melanonychia. As it progresses further, the nail grows further. Repetitive trauma, which we fail to recognize, the onychophagia, the onychotillomania, is also a common cause of melanonychia.
Ma'am, is it reversible if the child stops?
Yes.
It is reversible?
Yes, yes, yes. The functional type, the racial, ethnic, functional, constitutional, the big term is reversible to some extent. If it's friction is the cause, biting is the cause, it's reversible.
Thank you very much.
Thank you.
Thank you so much, ma'am, for such an enlightening session. I would request our chairperson and speakers to please receive their memento. Now I would like to invite on the dais Dr. P.C. Das sir and Dr. Sujala S. Aradhya ma'am for chairing the next session.
It's my honor and pleasure to invite the next speaker to the stage, Dr. Sachidanand. I'm sure you're all aware of him, and you can see his illustrious career on the board. Welcome, sir.
Thank you, chairpersons, for that introduction. Anyway, it's a privilege to be speaking in front of your daughter. Thank you. Nail diseases in psychotic disorders is what I have been asked to speak on. Nail as a unit, we all, feel proud to show off, especially women. They would like to keep their nails very clean. And if something happens to the nails, definitely it has a bearing on the mind. So psychosomatic influence is already there. That is nail changes bringing on some side changes in the mind. The other way I'm looking at, if there are psychotic disorders, what sort of nail changes can occur? So it is vice versa, both ways. Nail apparatus being affected, using influence on the mind, and actual psychotic disorders having a bearing on the nail. So nail abnormalities are common. You know that nail abnormalities are common but under-recognized in psychotic disorders. all the psychiatric disorders are divided into neurotic and psychotic disorders. While neurotic disorders are very mild, psychotic disorders are very severe type of mental illness. But there's a very thin line between neurotic disorders and psychotic disorders, right? But apparently more number of nail abnormalities are seen in psychotic disorders than in neurotic disorders. However, a simple stress in life can also induce a lot of changes in the nails. And most of these changes are due to secondary to behavior changes, neglect, delusions, or due to medications that they take for these psychotic disorders. And most importantly, nail acts as a visible marker of disease severity and self-care. So one can assess the improvement in the psychiatric disorders, disease severity, and also how much the patient is paying attention to for self-care. Why study nail changes in psychosis? Why is it important? It reflects poor insight and self-neglect. The moment you see a psychotic patient, you have to examine his nails, definitely there will be poor insight and a lot of self-neglect. They will not be taking care of the nails. Indicates compulsive and delusional behavior. There must be something wrong with the patient, is what the clue the nail is trying to give us. It helps identify adverse effects of psychotropic drugs. Maybe the patient is on medications and these drugs could have caused some changes in the nail. And assist in the holistic patient assessment. Healthy nails, healthy mind is what probably we can think of. What are the etiopathogenesis for the causes for the changes in the nails that happens? One is self-inflicted trauma. The individuals are so stressed or so overburdened with the psychotic illness, they can have self-inflicted trauma. Then poor hygiene and neglect is very well known in these patients. Delusional beliefs. Then psychotropic medication effects, and finally associated psychiatric comorbidities. All these contribute to nail changes in psychotic disorders. Now, there is a new terminology that is coined, it's called as self-inflicted nail disorders, SIND. And the prototype disease for that particular condition is, a particular process is onychotillomania. We all know about, you are very familiar with trichotillomania. So onychotillomania is also a very compulsive picking or tearing of nails. And it's common in schizophrenia and severe mood disorders with psychosis. The patients, they try to pick on their nails and keep tearing the nails so that they become very ragged and it's very visible, easy to make out as well. And usually it will have irregular, shortened nails with ragged cuticles. And of course, due to the trauma induced by the picking and tearing of the nails, there could be periangual erosions and bleeding as well. So this is a typical picture. I don't know. Yeah, you can see these irregular shortened nail plates with ragged cuticles and also periangual erosions. You can make out those erosions here with compulsive nail picking in psychotic disorders. The second most common self-inflicted nail disorder is onychophagia, where the patient tries to bite his nails. This is a very common condition even in normal individuals. A lot of people start biting their nails whenever they're stressed or whenever they're in overstressed. They do that as a matter of fact. But in on the psychotic disorders also, patients try to do this onychophagia. It leads to nail dystrophy and paranoia because of the trauma. Again, paranoia is induced, and nail dystrophy due to repeated trauma. Factitial nail disorders also can occur due to delusions. It may mimic sometimes psoriasis, lichen planus, or onychomycotic changes in the nails. You can see that the nail has been bitten away. It almost half the nail plate is half the size of the original size. And nail dystrophy and of course periangual inflammation is also seen because of the biting effect. Nail changes due to poor hygiene and neglect. Of course, it can lead to onychomycosis. We all know why onychomycosis occurs, because of poor hygiene and neglect. Subungular hyperkeratosis is noted. And the common condition is onychogryphosis, also called as ram's-horn nails, and chronic paranoia, long, thickened, discolored nails. All these are possible due to poor hygiene and neglect. And this is onychogryphosis or ram's horn because of the increased curvature, longitudinal curvature of the nails. So it's a presentation due to severe self-neglect of long duration. Delusional disorders affecting nails. Delusional parasitosis, also called as Ekbom syndrome, is one condition where nail changes are seen. The patient believes that some insects are causing the problem and eating away their nail. It's a fixed belief of infestation involving nails. Repeated manipulation causing trauma. The commonest are onycholysis, nail destruction, and secondary infection. This is a patient with traumatic onycholysis and nail plate destruction due to repeated manipulation in delusional parasitosis. These are the changes you see, almost resembling onychomycosis or tracheonychia. So one has to be very careful and take a good history to find out the cause for nail changes. Factitious nail disorders are deliberate nail damage. The patient is knowingly doing this factitious nail damage. It's caused by delusional beliefs mimicking inflammatory nail disorders. Here again you can see that traumatic nail progression of nail plate destruction. Of course, when the patient is put on drugs, one has to watch over a period of time because many a times these drugs are for long duration. They can cause, especially antipsychotic drugs, rare pigmentary changes, Bu's lines. What all was enumerated since morning could be present here. Photosensitivity related nail discoloration can occur. Lithium, which is commonly used in treating psychiatric disorders, may mimic nail psoriasis and onycholysis can be caused. Valproate, another drug which is commonly used, can cause brittle nails and rarely leukonychia. Nail changes that occurs in psychiatric comorbidities. In obsessive compulsive neurosis, onychotillomania is very common. In patients with depression, Bu's lines and brittle nails are common. In substance abuse, trauma and infections are more common. In catatonia, overgrown neglected nails are quite commonly seen. So this is disease-wise, commonly occurring conditions. So what is the clinical significance of these nail changes? They are objective indicators of self-care and insight, as I mentioned earlier. You would know what is the level of hygiene that the patient is maintaining or self-care that the patient is taking. It helps assess treatment adherence, whether the patient is adhering to treatment or not over a period of time. If the neglect continues, probably they are not taking the drugs properly. And if the care has improved and the nail changes are seen over a period of time, that means the patient is on medications and self-care is good. So that's how it differentiates between primary versus factitious nail disorders. Coming to this management principles, you have to treat the underlying psychotic disorder which is causing the nail changes. Behavioral therapy for compulsive picking is very important. Counseling is necessary. Basic nail care and hygiene education. Most probably the patient may not be very intelligent enough or rather aware of the changes that is happening. You have to educate the family members so that they take care of the basic nail care and hygiene. And of course treat the secondary infections whenever you find them. And overall it's a multidisciplinary approach. The key take-home messages are no nail disease is specific to psychosis. It can be different. I cannot pinpoint and say a particular type of nail change can occur in a particular psychotic disorder. So it is not specific. However, nail changes occur. Most nails are due to behavioral or neglect related, and nail mirrors mental health status. Routine nail examination is essential. Thank you.
Nail is a vestigial organ with lot of clinical significance, as we have come to know from the enlightening session by Dr. S. Sachidanand. Thank you, sir. Do we have any questions? Thank you, sir, once again.
Thank you.
Thank you so much, sir, for such an enlightful session. I would request the respected chairpersons and respected speaker to kindly receive their memento. I would now like to call on stage Dr. Aditi Snehal ma'am to conduct the next session, which is a case-based panel.
I would like to call upon the stage our esteemed panelist, Dr. Chandra Grover ma'am, Dr. Ghazal Ahmed ma'am, Dr. UK Pallavi ma'am, Dr. Niharika Kumari, and Dr. Sanya. I would like to thank Dr. Shwetlina Pradhan ma'am for giving me this opportunity to stand in front of such esteemed and big personalities, and let me ask questions to them and clear all my doubts which I get with nail. So moving on to my first case. So I would like to discuss, as very brilliantly discussed by Shwetlina ma'am, all the CTD features, and after that the nail capillaroscopy was also very nicely discussed. But I would, on the clinical basis, day to day for our PGs, if a systemic sclerosis patient comes, what nail changes do we expect, and how do we counsel the patient about the same? Like, what changes will you get in the whole prognosis or the course of the disease? And how can we control and how can we arrest the most common features of the systemic sclerosis as per nails? So this is a typical systemic sclerosis hand. So any panelist would like to take up the question?
If systemic sclerosis, you don't see anything else and you just see the fingers. It is also called Madonna fingers, very thin, elongated fingers.
Yes, ma'am.
With shiny nails, and there will be like the pad of the fat on the proximal nail tip will be lost.
Yes,
like
round
it will be
finger pad
thickened.
sign, yes ma'am.
Sclerosis, even there will be pterygium. We always see in lichen planus, that is dorsal. We can see here ventral pterygium, and the cuticle will be erythematous. And when you do capillaroscopy, we have such a good session on capillaroscopy.
Yes,
He told
yes,
everything
yes.
about that. Those are the, you can see rat bite ulcers,
Yes.
pitted ulcers.
Pitted, yes ma'am. So ma'am, the patient mostly are females. They are concerned that their hands are looking like that, mostly the nails are looking like that. So how will you counsel, how will you approach about that thing? Because in systemic sclerosis as well as SLE, in SLE we also see that most of the clinical features inside, they are concerned about the pigmentation over the face. Same as over the hands, which is very clinically significant in systemic sclerosis. So Chandra Grover ma'am, how do we arrest all those things as soon as possible, and how do we treat the nail symptoms if possible?
So all the changes that you see in the nail are basically a result of peripheral ischemia. Dr. Vishal had this beautiful diagram.
Yes, ma'am.
So most of our treatment is going to be towards vasodilation as far as possible, and that will only help to improve. Though I have not seen any reversal of the changes which the patient presents to us with, but further progression can be to some extent controlled by being liberal with your vasodilators. So we start the patients on ecosprin, dual antiplatelet in case it is required, and calcium channel blockers to ensure good peripheral blood supply. We ask them to keep the extremities warm, which is the best single advice to be given to these patients. Avoid smoking, avoid any other causes of peripheral ischemia, and hope for some changes. But we all know that this particular disorder cannot be halted. It can only be changed to some extent.
And ma'am, what about the periangular erythema? With course of time, it becomes dusky, darkened. So how about counseling the patient about that?
So periangular erythema or even the microhemorrhages, all these are markers of disease activity in patients with systemic sclerosis. So you need to control the disease activity by various measures. You have the possibility of using methotrexate, you have the possibility of using pulse therapy or rituximab, whatever you are doing at your center. And the classification of early, active and late systemic sclerosis, NFC, is going to be helpful in this regard. So if you control the disease activity and you slow down its progression,
the erythema and the microhemorrhages and the infarcts are less likely to happen, and even the digital tip ulceration, which is the dreaded outcome in these cases.
Yes, ma'am. In dermatomyositis also the ragged edges is very prominent and they are very concerned about it. So ma'am, counseling about this tapered fingers and the half finger pad sign, that also, like how to describe to the patient that it is never gonna be okay now.
So I would not say never going to be okay. I would encourage them to keep the extremities warm. I would encourage them to use emollients a lot, wear gloves, avoid prolonged exposure, especially to cold water, and look at their tips, fingers, and a good amount of moisturization is going to help them detect the changes early as well as bring them down to some extent.
Okay, ma'am. UK Pallavi, ma'am. What about the cosmetic approach, like for the patient?
First thing, we have to counsel the patient, very important part of this, because it's not going to be reversed back. So female patients who are mostly unmarried, they are very much
concerned, yes. Even I have seen male patients also of SLE and systemic sclerosis. They are also concerned about their hands, like will they be like this only, the tight
shape
and
will
thing.
be, my shape
And
of
plus the functionality also loses because of the
good.
Yes. So Niharika, how much nail capillaroscopy has helped you for the diagnosis and prognosis of the disease?
Yes, ma'am. It's help in diagnosis of nail capillaroscopic changes in early disease, in active disease, and in
when we are dialma is there, that is
yes,
it a yes?
Yes, ma'am.
Yes, as Vishal sir has already discussed very nicely, like what not only the diagnosis of, like we can catch a typical disease, but when it's dialma and when it's we have to see the prognosis. So
it will be helpful, ma'am. In early changes, it will be there is no density loss over the nail capillaroscopy, but there will be 1 to 2 mega capillary and 1 to 2 hemorrhages.
Yes.
But in active disease, there will be more hemorrhages and more mega capillary, and density is moderately decreased. And in later stage, there will be capillary loss, capillary dropouts will be seen.
Yes. So I would like to ask all the panelists, how much do we use this in our OPD basis? Like in every patient in which suspect, or in only dialmatic patients? What is the approach in your OPD?
It should use in every patient.
It should, I'm not about should, I'm talking about what you do.
Ma'am, I used to do nail capillaroscopy.
Okay, ma'am.
I usually don't do. I usually don't do. I do other, when we need to like document our observations.
Yes.
That is the time when I usually do it. And there are patients that are referred from even general medicine. They refer to dermatology
only
for
this,
capillaroscopy.
Yes, ma'am. So
okay.
it
so
is there.
Then I do it. I like to know about ma'am.
We do it for all the baseline, the first interaction base. It's a part of the baseline investigation treatment chart for the patient, where the mean capillary density as well as the presence of hemorrhages and the other typical changes is going to be accounted for. And thereafter, depending on what specific treatment we have started and how often we want to repeat it, it is done. But baseline, every patient is going to get. The nail fold capillary changes are the ones which are markers of even internal organ involvement. So they are going to guide you towards specific types of antibodies and help you mentally design your treatment plan for that particular patient. So there is the age, there is the disease stage that you have to take into account. You have to take into account what internal organs are involved. So all this adds up as evidence towards that.
Ma'am, so like should we do in every patient nail, like you are advising for it?
Yes, we should, we should.
Okay, thank you, ma'am.
Nail, your NFC carries a score in your EULAR criteria towards the diagnosis of systemic sclerosis. If not for anything else, at least for making your firm diagnosis, it should be there. Baseline is the bare minimum. Thereafter, if you want to evaluate your treatment response, so we've had patients on follow-up, especially in thesis or studies, definitely we'll do. Rest, it depends on how the patient goes forward.
Okay, thank you, ma'am. Everything has been discussed. Moving on to the next case. So this is not a patient of mine, but it was taken from online discussion forum, where the question was asked, like a 26 years female with 2 years history of progressive brittle nail dystrophy, confined to only one finger, that was right fifth finger, and associated with longitudinal blanchable erythema also, and mild pain since 1 month. For that she came, otherwise she was having for 2 years, and there was no skin lesions, there was no other nails involvement. So what other diagnosis, DDs we can think and we can approach? Because it was tagged to ma'am only, and I saw it, and ma'am answered on that forum. So I wanted to discuss, because after seeing this, I also had many DDs, but after ma'am confirmation, I was like, okay, so this is the answer. So
what we can see in the picture, there is ridging, there is distal splitting, and some erythema.
Yes, ma'am.
So if there is nothing else involved in the body, and the patient presents only with this, then there is something in the nail unit.
Okay.
Okay. So and we have to then examine the subungual hyperkeratosis and all, everything. Some tumor, nail bed tumor, nail matrix tumor can be there, even glomus tumor can be there. But glomus is very painful, very painful.
Since the beginning, yes.
So that we have to take the history, we can do the cold test, then we can do the pen test, what we say, that it will be very painful. That red line, erythronychia, with a distal splitting, will be more towards onychopapilloma.
Okay, okay.
And nail matrix tumor, if it is there. So in onychopapilloma, since it is the nail bed tumor, so the lunula will not have the red thing. If you do a dermoscopy, the lunula will not. Distal from lunula, because lunula is matrix.
Okay.
This is, that is the intermediate matrix. This is a nail bed is a distal matrix, what we say. So that will be from lunula to the distal part of the nail, and there will be like keratosis at the end of the splitting, the V splitting. Okay, so that is the clinical clue. If it is onychomatricoma, that is the matrix, intermediate matrix, the main matrix is involved, it will be more of like yellow discoloration of the nail.
Okay.
And it will be more curved. I haven't seen, I've seen one case when I now think it should have been papilloma on clinical grounds than matricoma. At that time I thought as a PG, okay, matricoma, onychomatricoma, and I was happy. Okay, I gave a differential. But now
see a single line, then you have to keep in mind the tumors that she just mentioned, Dr. Ghazal. The onychopapilloma is a distinct possibility, though in this case do not see a subungual papilloma. Where we have to see it from the end. But in onychopapilloma, generally the nail plate is growing normal. The papilloma is lying underneath. The nail plate is splitting here, which points towards a more proximal origin in the matrix, a space occupying lesion, which is causing significant thinning of the nail plate, that it is thinning. It is that thinned out that it is splitting towards, by the time it grows towards the end. So I ask for an ultrasound and look for what kind of tumor it is. Matricoma, as she just mentioned, is on the other hand, that's a pachyonychia. It's a matricoma. It is a matrix producing tumor. So matrix produces nail plate. So that is pachyxanthonychia. That causes a thickness of the nail plate, not thinning like which is happening here.
Okay.
So papilloma, glomus tumor, even a myxoid cyst in this location can produce pressure enough and produce like this. So ultrasound would be your go-to investigation here. Okay. A high frequency ultrasound.
Okay, ma'am. Any panelists would like to add something? If your PGs will ask, why is it not?
I just want to ask ma'am, she's an expert here. Ma'am, USG or should we do MRI?
Dr. Taliani sir had also talked about it. USG is a very sensitive investigation,
in the sense that it tends to pick up smaller, even smaller lesions than MRI, and gives you a fair enough idea of the tissue composition of the lesion that it is picking up. But you need a special probe. The high frequency ultrasound is something which is useful here because you want to do a superficial examination. So all in all, with the evolving level of knowledge that we have, HF-USG scores above MRI. USG can't see beyond the bone, it will stop at the cortex. So if you are thinking of something below that, you need a CT or you need maybe an MRI to see the whole tissue composition. But anything above the bone, USG.
USG. High frequency.
Non-invasive, less cost, more modulable. You can see all the three sections, the coronal section, the sagittal section, and make out the exact extent as well as distance from the matrix, from the DIP joint, from the enthesis. It gives you all this information.
As ma'am also said that they approached with a hypo-NICAM because of the USG. It was so suggestive.
It will tell you a cystic lesion versus a solid lesion. MRI will show a lesion, may not be able to tell you that,
Yes,
may or
sure.
may not.
So everything discussed. Now coming for a PG perspective, a patient comes with only 2 fingers of pitting, very coarse pitting, irregular. Dr. Niharika, would you like to take up?
Yes, ma'am. In this image, there is showing coarse pitting along with distal onycholysis. It seems like psoriasis, nail changes.
Yes, but on a PG level, like the PG sitting over here, what all things will you see in a nail pitting patient? Only 2 fingers, no other systemic features. How will you manage the patient, like approach the patient like that?
Ma'am, nail pitting suggests
Or
its involvement of nail matrix. Ma'am, want to say?
Dr. Sania, please.
Ma'am, psoriasis, alopecia, and planus, and some chronic eczema, we can think of that.
Sure. So, how will you differentiate? How will you approach the patient? Like if this patient comes to you, how will you?
We will first see in the pattern of the
Sure. Yes.
pitting. It's
Yes,
a regular pattern, and geometric pattern is usually seen in alopecia areata, and irregular and more deeper in psoriasis.
Of course, yes. Anything new in nail pitting, ma'am?
Pitting is something which you are seeing, but don't miss the other changes. The onycholysis which is present with a regular margin with an erythematous border.
Yes,
This is in favor of nail psoriasis.
Nail psoriasis,
So
yes,
pitting is the predominant feature here,
Yes,
but
ma'am.
there are other changes also which are helping you towards the diagnosis. In nail, it's always pattern recognition.
Ma'am, would you like to add some?
PG basis, we always go for the psoriasis, then alopecia, we look for the other site also, then eczema, in children atopic dermatitis
Atopic
also we have
dermatitis.
to look for then lichen planus, the last one. We'll go for that.
Okay, ma'am. So moving on to a growth on a finger nail, so toenail, sorry. So this patient came to us and we made a verrucous tumor diagnosis, but the biopsy came to be Cohen tumor, which was very it was not very comprehensive and confirmative. So I wanted to ask the panelists what are their DDs and how will they approach the patient and what all things can be done to make a definitive diagnosis, clinically and as per the investigation.
Conan's tumor, if it is there, then TS should be ruled out. We have to examine the patient if other skin changes
Other
are
skin
there.
changes were not
Only
there.
one finger was present in
Yes, ma'am.
Conan's.
Yes.
Kenan's, usually it is multiple finger in
Yes,
Kenan's. And if it's one finger only and the duration, how long it was, and then I would also have thought of SCC, truly speaking. It's only single tumor, single nail affected. And let's see what ma'am has to say.
Single nail tumor which is filament, which is verrucous, causing destruction of the nail plate, I will think of malignancy. Is there ulceration also here? Not very clear on the
no
image.
ulceration, ma'am. Only this
So
growth was
I will
there.
also think of malignancy only, and do the histopathology accordingly. Keenan's tumors is a fibroma, is an angual fibroma.
Yes, ma'am. Yes,
Fibromas can occur in isolation also. So histopathologists cannot tell us whether it is Keenan's, or they can only tell us that it's a fibroma, and you have to fit it into the clinical picture to derive that this is a Keenan's tumor. So evidently the setting doesn't suggest that. If it's a fibroma, I would here want to know the duration, want to know the patient's symptomatology. I would get an X-ray also done, and I would repeat the biopsy, including HPV typing if possible. All these things I would do for this patient. If it is a patient's age is high, it's a long-standing lesion which is causing destruction of the nail plate architecture completely.
Yes, ma'am. It was like a long-standing tumor with a 35.
Then I would still think of malignancy and choose a different site of biopsy, which could be onychoscopy guided, to take you towards the proper site from where biopsy has. Onychoscopy is going to help you rule out a wart. In this case, warts can be this exuberant. But if it's long-standing, then even a wart is possibly progressing towards an SCC. So that possibility should be kept in mind. I would do a DPC and a repeat biopsy if needed.
Okay. Ma'am, would you like to add something? Or any panelist would like to add something?
First, we have to look for other skin changes.
Okay.
Like if you go for the Quinone tumor, we have to look for other skin signs also. The repeat biopsy is must. We can rule out dermoscopy also.
And you would like to approach, as ma'am said, with the same way. And what should be the treatment, Niharika? Like if this patient comes, we did investigation, it came out to be SCC. So how will you approach the patient? How will you counsel the patient?
Ma'am, first we look for invasion, how much invasive this lesion, and repeat biopsy. First repeat biopsy. If it will come SCC, then look for the progression and the involvement and the local invasion. Along with that, we'll move forward for plan for excision.
Excision.
So I want to know
is this a kid?
No, ma'am.
Child?
No, ma'am.
Looks very vascular also. You have to look for a patchy, what we call the revised terminology, the acquired peripheral angiokeratomas basically in this location, because they will be acral, not specifically the nail, but acral location, the feet. If this is a child, that is one possibility.
No, it was not
looks very, and no history of bleeding.
No, ma'am, no history of bleeding.
I would do a repeat biopsy. First discuss the previous one and do a repeat biopsy.
So moving on to next case, as ma'am had such an explanatory and such a vast discussion on the same topic, I would like to know, like on OPD basis, what all things can be done and how would we suspect a benign, racial or malignant, like how will we progress if a patient comes to us with single nail, single line longitudinal melanoconicia? With like the progression, it is progressive, like with the ma'am for the PGs.
History, examination, onychoscopy, biopsy. In this order. So every time you are basically eliminating one or the other cause and arriving towards the final thing. You have to first of all take history, duration, number of nails involved. If number of nails involved is more, then look for the systemic causes. And if it is a single nail, then you have to know the duration, the age. After that, examination findings, complete examination from the distal end, from the proximal end, complete onychoscopy. And from there you decide between activation versus proliferation, proliferation benign versus malignant, and decide. If the patient can be kept on follow-up, I'm talking about the proliferations, if the patient can be kept on follow-up, fine. Please do a 3 to 6 monthly follow-up. If it can't be kept, it's an adult who will not come for follow-up, it's better to excise the band.
Okay.
Excise the origin, not the band.
If it's progressive, it's more than 5, like if it's all the criterias are for malignant, then we better excise rather than waiting for a follow-up. Any panelists would like to add? Because most commonly we see if a patient comes with single nail, they are normal है ये ठीक है आप खुद ठीक हो जाएगा या नहीं ठीक भी होगा तो इससे कोई दिक्कत नहीं है, and we send the patient. So when do we need to draw, like what are the red flags for this?
Like I'll tell you one recent case. We had a very abnormal looking pigmentation on nail. We suspected melanoma. We sent the biopsy and they told that there is no such changes of melanoma. So what can be is proliferation. But then we can't say exactly whether it is proliferation or melanoma. Then we have to even go for IHC markers. We sent the block for IHC markers. We gave the patient, sent him to a higher center for IHC markers, and we are still awaiting the result. Because melanoma, if clinically you have suspected once, then it should be ruled out.
Yes.
Because it is very aggressive and it will like metastasize to anywhere. So IHC markers if there is suspicion even on biopsy.
Any panelists? Yes,
so no particular marker which is diagnostic, but it is going to give you definite clue towards the diagnosis. And just wanted to repeat what Dr. Aniki says. Better to have small scars than large tombstones.
Sure, ma'am. Noted. Any panelists would like to add any experience of theirs for the same? It's a very common case. Okay. So moving on, this is a very normal scenario which comes for our referral to the skin department, where a patient is hospitalized for a longer period of time and they start to get nail changes with some horizontal lines. Here many things can be seen, but we are mostly concerned about the bruise line. How will we counsel? How do we do a management? What do we do? Dr. Sanya, would you like to take up?
We will suspect bruise line, and for management we can't do anything. Like we can say just wait and watch, reassure the patient, since it's like mainly occur after a chronic or systemic illness. So we have to counsel the patient to just be reassured.
And for the other findings, what can be done, the management?
Transfers.
No, yeah, we can see other findings of the nail and the nail fold.
The cuticle is damaged, and there are multiple transverse lines which we can see.
Discoloration of nail plate, yellowish discoloration, dirty nail. It seems like there might be onychomycosis also, along with nail plate growth restriction, along with superimposed fungal infection. Might be onychomycosis.
In this patient, counseling is most important, and we should give placebo treatment to the patient, and we should wait and watch and get some super added infection antifungal and with antibiotic, and topical antifungal and antibiotic also.
So on my basis also, I want to, my PGs usually ask me, ma'am, 1 year treatment, ma'am, 6 months treatment. So what is your approach? Do we go for all the patients for 6 months and the treatment? Or how do we approach for onychomycosis?
We we will give 3 months, then we'll wait and watch again. If it required, then we'll again start the treatment, and we'll also look for the pocket of the patient also.
Ghazal ma'am, what do we look after 3 months?
In this finger, like ma'am was also telling, I can appreciate more of koilonychia than bruise line.
Yes, koilonychia is also there.
There is this fever of unknown origin.
Yes.
If it is in Indian scenario, anemia should be ruled out.
Yes,
okay, anemia is one clue that should be ruled out. And if it is bruise lines and nail changes due to one episode of some fever or that, we have to counsel that it will outgrow. The nail will outgrow, it will take time, but it will outgrow. If the cause is treated, if the systemic cause is dealt with nicely, then this will heal in round about 6 months. That's all.
Sure, ma'am. Ma'am, for the onychomycosis part, ma'am.
Onychomycosis, this case?
No, not this case. Like I want to ask how the management do we approach in normal OPD scenarios? do we give a weekly treatment for 6 months if there is?
No, not 6 months. It's 2 to 3 pulses for the fingernails and 3 to 4 for the toenails. So you decide accordingly. It's not 6 months. You add the topical therapy also. That continues even after the apparent clinical cure has been achieved. The baseline diagnosis should be mycology positive. Subsequent follow-up mycology can also be done. And what I talked about in the morning also, there is no point in going on prolonging your terbinafine or itraconazole pulses. It's not going to help. By design, these drugs are going to be retained for up to 6 to 9 months within the nail plate. So if you perceive that by that time, the nail is not growing at an optimum speed, that is the point of periodic checkup. If it is not growing, the rate of nail growth is slow, you may give a booster or supplemental therapy at 6 to 9 months.
Okay, ma'am. Okay.
From day 0,
Day
6 to 9 months, not before that. Otherwise, you give your pulses and stop. The optimum time schedules has been worked out as per the rate of growth of nail and the pharmacodynamics of these drugs, which are retained in the keratin.
Okay. Thank you, ma'am. Thank you so much for clearing that. So we have all discussed the last case. This patient, very traumatic. He came, 45 years old, female, came to us with 6-month history of painful pustules around the nails, and after that it was the crusted plaques which was present. She came to us, ma'am. How do we approach this kind of a patient?
So this is multiple nails which are affected.
Yes.
There was another image, I think, with 2 nails. So
Yeah,
if
it
there are
started
so
with 2
many
nails. Yes, ma'am. Started
if there
with 2
are
nails,
so
but
many
now
nails affected,
Yes,
I
ma'am.
would think in terms of a paraneoplastic process also, the
Okay.
basic syndrome. Toenails were also affected?
No, ma'am, only
so
hand nails.
that's basically associated with malignancies of the upper aerodigestive tract. You look at the oral cavity, look at the possible piriform foci, the esophagus, even the lungs. And there was, I suppose, another image that you had sent that showed the presence of pustules.
This one.
Yes, this one.
Yes, ma'am.
This is a single nail, or at the most 1 or 2 nails, is in favor of acrodermatitis continua of Halupi. But the previous one with so much, you should think in terms of basic syndrome, because ACD of Halupi generally doesn't affect multiple nails. It can, but it doesn't generally, that is not the normal pattern for it. And of course, histopathology will be helpful here. Dermoscopy, and that is onychoscopy, followed by histopathology.
Okay, ma'am. Would you say any panelist would like to add something? Okay, then it was a very informative discussion.
Thank
and
you.
I'm always, thank you so much, such elite panelist, for answering me up and clearing my doubts. Thank you so much.
Thank you so much to our esteemed panelists and our moderator, Dr. Aditi ma'am, for transforming these questions into clarity and discussions into learning. We now move forward to the next segment of our program, for which I would like to request respected Dr. Sushil Tahiliani sir and Dr. Vishal Gaurav sir to please come on the dais to chair the next session.
Good evening to all. The topic of my talk is nail aesthetics, in which I'll be covering 2 topics, nail peel and gel nails. I'll try to keep it simple and very practical, something which you can incorporate in your clinical practice if you wish to, and then use it in your clinic. This is the one. So nail peels, it is not a commonly done procedure, but I'll discuss it in brief for you to understand what are the indications of the nail peel, how is it different from the skin peeling, and how can you use it in your clinical practice. In your clinic, you might already be having whatever it takes to do peeling of the nail. So why to even consider nail peels? They are used in nail rejuvenation, it's a relatively newer concept, and the equipment needed for nail peel is already available in the clinical setup, and it's inexpensive. It is an office-based procedure, and there is absolutely no need for a special setup. And most dermatologists are well versed with the technique and associated adverse reactions. So a very brief word about how the nail peel is different from the skin peel. In the nail peel, the difference is that nail plate, it shields the whole of the nail unit from the surrounding bow, and it is inaccessible to the peeling agent. We need to use stronger peels if we are targeting nail peels. Prior hydration. In my talk on ingrown, I have also discussed prior hydration before any surgical procedure of the nail, say the punch biopsy of the nail plate, it is important. And lipid component of nail plate is lesser in comparison to the skin. So we use alpha hydroxy acids. They are little less effective because the penetration in nail plate is lesser. So these are the basic differences between nail peel and skin peel. So this is an important slide for the topic because we have to understand where you need to do a nail peel. Nail peel is done in dry, rough, lusterless, discolored nails, which is due to cosmetic overuse. Many a times patients come, my nails are very dry and rough. So that time, apart from prescribing emollients, you can consider offering the person a nail peel as well. Already your clinic staff knows it, so what's the harm in doing it? For superficial nail anomalies like pitting, onychorexis, lamellar splitting, rough sandpaper nails, melanonychia not really effective. It was just to complete the list. Contraindications are it is avoided if any local infection is there, and it should be avoided, please mind you, in a very thin nail plate. Do not do it. Like if the nails are really brittle and thin, in pregnancy, lactation, do not do. Onychomycosis, now there is use of black peel, but otherwise infections are a relative contraindication. So the materials required are very simple. Imagine only this much: Vaseline, peeling agent and the earbud. But if we go more theoretically, sterile gauze, petrolatum jelly, cotton buds, thin nylon brush, not a big brush mind you, then it is better to use a earbud only. Peeling agent of choice, but as I said that higher concentration of alpha hydroxy acid, for example 70% glycolic acid, and stopwatch. Now imagine all this is already present in the clinic. So choice of peeling agent, just a brief touch upon. Nail plate is thick, glycolic acid is alpha hydroxy acid with low molecular weight, hence a deeper penetration. That is why there are no data on salicylic acid use in nail peel. Phenol. Now pre-procedure requisites, patient selection, I have already discussed patient selection. Any active bacterial or viral infection, for example periungual wart. Nail unit photography, we all are very well versed with photography now. Now the peel application. Pre-peel cleanser, please clean. Apply the petrolatum jelly surrounding the cuticle. This is an important step because nail plate is thick and surrounding skin is thin. You preferably clean the nail with water. This is important. Do not try to use alcohol or acetone because it will further dry the nail plate, which is already lacking sebum and is a dry structure. Take a small nylon brush or earbud. Now with the peel application, it is as simple as that. You protect the cuticle, you apply it. If the peeling is done for pathological condition, then use 2 through 3 coats. Water-based peels are to be kept for 10 minutes and gel-based peels can be kept for 30 minutes. Removal of peel can be done with a cotton tipped in water, and gap between sessions ideally should be 4 weeks. Post-peel instructions: liberal moisturization of nail and surrounding skin. Precautions during nail peel: proper history examination, narrow brush, I have already told, and proper selection of the peeling agent. So complications include periungual irritation, dryness and peeling in periungual area. Data is very limited and there is lot of variation in available literature. So peels One important part of an aesthetically pleasing nail is that it is a translucent structure, but peels do not improve the translucency of the nail, which is considered to be important, but overall they give a smoother appearance, and need for repeated session makes the management prolonged, making it time consuming procedure with limited efficacy. Hence, a judicious patient selection is a must. People who are happy to come once a month for minimum 3 to 4 sessions. So, conclusion regarding usage of peels. Peels are useful modality for nail surface irregularities. Many factors still need to be clarified with regard to choosing peeling agent, number of sessions and gap. But despite the lack of standardized protocols, they can be safely recommended in cases where conventional therapies cannot be used or patient is needing only aesthetic improvement for dry and rough nails, but not very thin nails, mind you. So conditions that have been treated are nail pitting, onychorexis, nail psoriasis, trichonychia, and for cosmetic enhancement. These photographs my senior and friend Dr. Soni Nanda ma'am has shared. So these are ma'am's result with nail pitting with glycolic acid. Ma'am has done monthly sessions and you can see a decent improvement and patients are marginally happy with this. These are the surface irregularities with 70% GA, again good improvement. These are monthly photographs. These are onychorexis improvement, not great improvement. This is phenol 80 and this is poor improvement with phenol. So not that it always works, you might have treatment failures as well. So unique features of nail peels are medium depth peels are preferred, safety profile is higher and there is no risk of post-inflammatory hyperpigmentation. So improving the texture and look of the nail, that is where we use the nail peels. Coming to the next important part of my talk, which are gel nails. Again, a simple procedure. I'll try to focus on the practical aspect of the gel nails and show you the videos how to do it. So, gel nails are used with superficial nail conditions like pitting, onychorexis, onychoschisia. These are all nail disease which necessarily do not require any injectable or systemic treatment. In these cases, the aesthetic procedures become important. So see, this is a normal nail. This is good, this is bad, and this is ugly. So how important it is to have a pleasing nail. I don't think it is vain, but a basic human requirement. See, this is brachynychia and on the side is a normal nail. So how significantly different the hands are. So we can't undermine the importance of an aesthetically pleasing nail. Rationale of gel nails is it imparts shininess and smoothness to the nail plate surface. It makes the nail polish last longer and is an excellent tool for improving cosmetic appearance. Sachets are stocked on nails in psychocutaneous disorders. So in such cases or in self-induced nail disorders, gel nails really work very well. I'll be showing you the photograph of a case in which I had done gel nails and the patient was very happy. Advantages of gel nails include they look more natural and glossy, curing time is faster, they are safer, more eco-friendly and no fumes are produced. So they can be combined with medical treatment. I am doing it in my medical college wherein patients of nail lichen planus or nail psoriasis comes. Mind you, diseased nails grow slower. So in those cases if you do gel nails, they last for a longer period of time. So utilized for the management of brittle nails and for breaking the habit of onychotelomania, as I was discussing. In cases of self-induced nail disorders, they can be used. And in profession wherein there is a regular trauma to the nail, for example in guitarists, gel nails strengthen nail plate and improve the appearance of damaged nail plate. And in certain cases, pterygium, the sari gets stuck in the pterygium, so you can make a coating of the gel nails. Distinct advantage of using gel nail in a diseased nail in comparison to normal nail is that the rate of growth of diseased nail is slower, hence gel nails last longer. Contraindications remain the same. One important one is suspicious cases of melanonychia. Please do not do gel nails, rather do a biopsy as we have discussed before. So these are the requirements. So as you can see, this is gauze, this is a nail buff, the first one, second is a brush, third is Vaseline, then a skin cleanser, see the width of the applicator brush, it is so thin. This is ideal for a nail, any gel nail or nail peel, then a nail primer, and then last is the gel. And in the second part of the photograph is the UV lamp. So this is the simple thing. If you order this kit, it is hardly for 4,000 or 5,000 and it lasts you for a very long time. So all of you can pay attention now because I'll be showing the clinical photographs and videos of the procedure. These are the pre-procedure requisites. Any history of allergy, patient is explained regarding the procedure, and the baseline clinical photographs are taken. So we had discussed this with regard to the tourniquet for the nail, and generally also this is a very effective way of having your field of work visible. You cut the tip of the fingernail, and once you're putting the hand in the UV lamp, then also that glove comes handy. You will know what I'm talking once I show the photograph. So you clean the area with the Euro cleanser. You protect the cuticle with the help of Vaseline. I hope my videos are playing. It's not playing, but as you can see, I'm buffing the nail surface. And with it, after buffing, you remove the surface of any debris which has come out with the help of a brush. Now, after buffing, use primer. Primer can be caustic to skin and can cause nail thinning. So we apply carefully in minimum quantity after protecting the surrounding skin before its application. So this is a primer application. It is like a nail polish only. First you clean, then you buff with the help of a instrument, and then you put the sticking tape. It is a nail polish application only. This is the gel application. It is again like a simple nail polish. You put the gel. This is nail hardening. This is a very important step. So this is a portable UV lamp. You put the hand which has got the gel nail inside the lamp for it to harden, and after that the patient can be advised to use regular sunscreen on hands. Post-procedure instructions include liberal moisturization of nail and nail folds, and they can continue with normal daily activities. Removal of gel nails, this is important. So you take a acetone dipped cotton and then you move it, you put it around the nail, and with the help of that the gel nail comes out. This is a very important step. Apply nail polish soaked cotton, cover with foil for 5 to 7 minutes. Do not scrape it out, and apply liberal moisturizer. Whole procedure should be conducted in a well ventilated room with exhaust fan. Operator should be wearing mask at all times, and a minimum gap of 1 week is recommended between 2 gel nail applications. So outcomes are use of gel nails cosmetically improves the appearance of nail, and the psychological impact it has is very high. As you can see, this is gel nail on a simple nail, but the aesthetic appearance improves so much. And this is the gel nail in a self-induced nail disorder I was talking previously. So there's a remarkable improvement, and the patient once sees this, then they stop handling the nail so much, you know. So it can really make a difference. Complications, there are hardly any complication, though there is a theoretical risk of cutaneous malignancy which has still disproved now, and then you can always make the patient wear gloves, so there is no risk of malignancy or ocular toxicity. Disadvantages are they don't last long, they are less durable, they cost more, and they require UV light for curing, so which is harder to do at home. Limitations are it cannot be used for anonychia, and we need a nail plate for the application of gel nails. So where to use gel nails? Gel nails work well as adjunctive treatments. Patients who want instant results, like I showed in self-induced nail disorder, they work very well for thick nails. They are good option for dry, rough, lusterless nails. And it's a good camouflage which stays for long. But please don't promote it as therapy. And any nails except onychomycosis, melanonychia, paronychia or allergy, you can do gel nails. Thank you so much. This is the official website for Nail Society of India. This is the textbook Tailiani sir has already shown. Thank you so much.
Thank you, Dr. Shikha Bansal. Any questions from the delegates here? Any comments or questions? I have one suggestion. When we see a lot of exogenous pigmentation because of potassium permanganate or henna, and they want to get rid of it, can the peel be done to clear it faster?
No, sir, it cannot be.
The exogenous on the surface of the nail, it won't go?
No, sir.
Thank you.
Hello? Fevikwik can be used as a gel nail, as an alternative of gel nail. You put one or two drops and keep it downward. So extra gel Fevikwik will be down.
Okay, the extra gel will get removed.
As an alternative.
Sir, it will not get removed because it is not water soluble. Yes, sir, but it needs a longer soaking, maybe 5 to 7 minutes, then only it will come out. So we ourselves will remove, or we'll instruct the patient to soak the cotton in acetone, put it around for 7 minutes and then remove.
Thank you.
Thank you so much, Dr. Shikha ma'am, for such a comprehensive and insightful session. And thank you for the chairpersons for chairing this session. Now I would like to call upon stage respected Dr. Anil Kumar Soni sir and Dr. Abhishek Kumar Sinha sir to chair the next session.
Now we will have the last session of the day. Dr. Sivangi will be presenting on NDA laser on the onychomycosis.
Good evening, everyone. So I'll be presenting my topic on NDAG lasers and onychomycosis. So why do we need laser in onychomycosis? So we all know that onychomycosis is a chronic and relapsing disease, and it has significant cosmetic and functional comorbidity. Systemic antifungal sometimes we don't give in hepatotoxicity cases, or there are some drug interactions, especially in patients who are on polypharmacy. And again, there is monitoring burden if we have to give for a longer period of time. So there has been increasing interest in non-systemic modalities like lasers. So the learning objective would be, we'll review the pathogenesis and classification and understand the laser-fungus interaction. We'll discuss the NDAG laser parameters, we'll critically analyze clinical evidence and define appropriate role in practice. So we all know that onychomycosis is a fungal infection of nail plate, nail bed and nail matrix. Majority has been caused by dermatophytes followed by candidal infection and non-dermatophytic molds. Slow nail growth is responsible for prolonged treatment duration. So depending upon the laser outcome, The DLSO variety is most common and best laser responsive variety, followed by SWO, that is superficial white onychomycosis, followed by total dystrophic onychomycosis and onychomycosis where there is matrix involvement. There is reduced efficacy with the help of lasers. So what are the limitations of conventional therapy? Topical agents which we use, they have a poor penetration through nail plate. And so why lasers? So it's a non-pharmacological treatment modality and it avoids systemic toxicity. And there is high patient acceptance also because of the increase in the chance of cosmetic appearance of the nail. And these are suitable for elderly persons, patients having liver disease, patient on polypharmacy. The cosmetic improvement is valued by patient. So laser which is approved in onychomycosis is FDA approved Nd:YAG with 1064 nanometer of wavelength. The goal of the treatment with the help of lasers is temporary increase in clear nail, not labeled as cure. So we all know the physics of Nd:YAG laser with the wavelength of 1064 nanometer. It has a deeper penetration and it has minimal epidermal melanin absorption, thereby reducing the chances of side effects in the form of erythema or burning, and is safe for all Fitzpatrick skin types. So we all know that nail plate is a hard structure, and how does laser help in treating onychomycosis? So 1064 nanometer of wavelength helps in penetrating the nail plate, nail bed, and thereby targeting the subungual fungal element. So does laser kill the fungus? The treatment protocol is we have to assess the nail, we have to confirm the diagnosis sometimes with the help of fungal culture, and we have to take the photographic evaluation at every follow-up. The treatment sessions has to be at least 4 to 8 sessions at an interval of 2 to 4 weeks, and each session should last for at least 10 to 15 or 30 minutes depending upon the number of affected nails. So combination therapy is advocated where the laser has been paired with topical antifungals such as chlorotrimazole or topical nail lacquers. Or urea based preparation to accelerate the fungal clearance. Follow-up is scheduled at an interval of 3, 6 and 12 months post treatment to assess nail regrowth quality, confirm the sustained mycological cure and detect any early recurrence. So procedure technique, we have to clean the nail and debride the nail if required, and we have to set our machine on the required parameters, and then we have to give the multiple passes. We'll start with the least number of passes, say 1 or 2 in both the direction, longitudinal or transverse. The end point is the tolerability of the heat by the patient, and analgesia is rarely required post procedure. So patient selection, the good candidates are those who are having mild to moderate DLSO with less than 50% nail involvement and no matrix involvement. We had tried in patients with total dystrophic nails also, but the response is slower as compared to other type of onychomycosis. Combination therapy, the significance of combination therapy, if we combine laser with topical antifungals, it is seen that there is increase in clearance and reduce in recurrence rate. And if we combine it with short course oral antifungals, it gives synergistic effect and it reduces the systemic exposure of long-term oral antifungal. So these are, it's a case of onychomycosis which has been treated with laser only. So there are various studies which demonstrate the use of and the effect of Nd:YAG laser in onychomycosis, which says that mycological cure is achieved only in 50 to 60% of patients, but the cosmetic benefit has been seen in 80% up to 80% of patients. So it is advocated that laser has to be used as an adjunctive therapy to oral or systemic antifungals. So before and after result, we have to emphasize on the cosmetic improvement. Partial clearance is common in earlier stages, earlier sessions, and relapse is possible. What is the safety profile? The common problem which occurs is pain and burning during initial stage of the laser shots. It is followed by mild erythema, and rarely nail plate damage and subungual hemorrhage occurs, and there is no systemic adverse effect. Advantage of using laser is it is non-invasive, it is drug-free, minimal downtime, suitable in comorbid patients, and it gives a high patient satisfaction. Limitation is the cost, multiple sittings. It is operator dependent and lack of long-term cure data, and is not being considered as first-line monotherapy. So guidelines and consensus says that it should be used as an adjunct or alternative option, and FDA has approved it for temporary clear nail growth and has not labeled it as a definitive cure. So practical role to be practiced is it has to be used as an adjunctive to the other antifungal treatment. It is contraindicated in patient with having pain or severe dystrophic disease. It can be used in a patient who have contraindication to systemic therapy, and it is suitable for patient who needs early cosmetic improvement. These are the references. Thank you for your patience hearing.
Thank you, Dr. Sivan Singh, for a good talk on NDA glazier in onychomycosis.
Thank you, sir.
Any questions?
Thank you, ma'am, for delivering such a wonderful session. I would now request respected chairpersons and speaker to kindly receive their memento. With this, we come to an end of today's scientific sessions. I would now like to hand over the mic to Dr. Sujala, ma'am, for the annual body general meeting session. Sorry.
Good evening, everybody. We will proceed with the business meeting, annual general body meeting of the National Society of India, Nail Society of India. I would request all the life members to stay back in the hall, and the meeting wouldn't last more than 40 minutes, so kindly be available. All the life members be seated in the hall.
It's not just about learning and about sharing experiences, but it was a day that we gave so much importance to the little structure which actually gives such a great image to whatever is going on inside. With this spirit, we start our inauguration ceremony. To start, I will like to call upon the stage our chief guest, Brigadier Professor Dr. Raju Agarwal, Executive Director and CEO, AIIMS Patna.
Mithila, sir. This is from Mithila.
Next, I would like to call upon the stage our guest of honor, patron, Dr. Professor P.K. Roy, sir.
गेस्ट ऑफ ऑनर हो गया बिहार का।
Next, I will call upon the stage President NSI, Dr. Professor S. Sachidanand, sir. Next, I would call upon the stage our organizing chairperson, Dr. M.K. Sinha, sir. Next, I would call upon our organizing secretary, Dr. Abhishek Kumar Jha, sir. Next, I would call upon stage Secretary NSI, Dr. Sujala S. Aradhya, ma'am. Next, I would call upon Executive Committee Member and immediate past President NSI, Dr. Vineet Rehlan, sir. Next, I'll call upon the stage our scientific chairperson, Dr. Vikas Shankar, sir. Next, I will call upon our very own scientific co-chairperson, Dr. Shwetalina Pradhan, ma'am. Next, I would call upon the stage Joint Secretary NSI, Dr. Vishal Gaurav. Next, I would call upon the stage our Treasurer, Dr. Punkesh Kumar, sir. Next, I would call upon the stage Vice President NSI, Dr. Shikha Bansal, ma'am. And Joint Secretary, Dr. Rajneesh Kumar, sir.
Now I request Dr. Sriparna Dev, Joint Scientific Secretary, ONYCHOCON 2025.
Now I would request our respected faculties to kindly proceed for lamp lighting.
गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि।
May I now invite Dr. M.K. Sinha sir, our organizing chairperson, to kindly deliver the welcome address.
Thank you so much for calling me. Ladies and gentlemen, as you all know, we are organizing ONYCHOCON 25. This is the 17th National Conference of Nail Society of India, being organized by Dr. Abhishek Kumar Jha, me, Sriparna, Vikash, and all committee members. Particularly, I would like to thank, Dr. Svetlina Pradhan. She took all pains to organize this workshop of the nail surgeries, and so that all PGs and junior doctors, senior residents, they all were there to learn the new techniques of nail surgery. As we all know, nail is a very vital organ for us and is a reflection of so many internal diseases. So it was till now very neglected portion, and very seldom we had nail conferences in particular. But now, as Nail Society of India is promoting the all possible efforts to treat such vital and difficult nail diseases. So I would like to thank the Nail Society of India EC members, particularly Sachidanand sir, Grover sir, Mansal ma'am, all Binit Relhan ji. They all came to Patna for this nail conference. So Nail Society of India is doing a very tremendous work to let us know about the nail diseases and how to treat them. So I would like to thank all delegates, They have come all over from Bihar, and PGs particularly. They all have come from different medical colleges to grace this occasion and learn something about nail. So thank you all for coming, all delegates, and particularly I would like to thank Director of AIIMS, Dr. Agarwal sir. He, despite his busy schedule, he spared some time to greet us and greet this occasion with his presence. Thank you so much, Dr. Agarwal sir, for coming. Thank you so much. With these words I finish. Thank you so much.
Thank you so much, sir. May I now request Joint Secretary NSI, Dr. Vishal Gaurav, to say a few words.
So we would like to thank the organizing team as well as the scientific team at AIIMS Patna for organizing this exceptionally well. In the very morning we had an audience, a packed hall with so many audience. The topics were selected from a diverse array of areas, including all the spectrum which we see in nail disorders, ranging from basic anatomy up to the recent advances and the latest guidelines. So, and it was a very well organized as well as attended conferences. One of the very, I think, few conferences, especially which is focused on nail, gets to see so many participants. So we are extremely happy that they accepted it, and we are so happy to be here. Okay.
Now may I request our scientific chairperson, Dr. Shwetlina Pradhan, to say a few words.
Thank you, Shripanna. So I was the scientific secretary, co-chairperson, changed to chairperson. So it is always happening to work in team with, so we as a team never run behind the post. So we work as a team, and we have a very great team, Dr. Abhishek Jha, Dr. Vikas Shankar, me, Shripanna, and other young brigades. So the post doesn't matter. So it is heartening to hear that everybody is appreciating the workshop and scientific program, which it is very in short time we have made the program, and it is very surprising to see the PG students from FMC Pune, UCMS from Bangalore, AIIMS Nagpur, and all the local teams. 14 teams participated in PG quiz, and we have a lot of participants in posters and our papers. It's great that people this 14th doing a 14 conferences. You have created some interest in young DOMATs so that they are opting on ONYCHOCON conference and coming and participating here. So thank you, our director sir, for accepting our request. So from AIIMS Patna, I am giving you thank you sir, accepting as a chief guest. So thank you everyone. So we have one day more left, so I hope you will enjoy all the scientific program and attend tomorrow also. Thank you.
Next, I would request our scientific co-chairperson, Dr. Vikas Shankar sir, to deliver a few words.
Thank you, Shripanna. Adarniya Director Brigadier Raju Agarwal sir, हमारे पैटर्न प्रोफेसर पी.के. रॉय सर, राजीव गांधी यूनिवर्सिटी के फॉर्मर वाइस चांसलर और नील सोसाइटी ऑफ इंडिया के प्रेसिडेंट डॉक्टर सच्चिदानंद सर, सेक्रेटरी डॉक्टर सुजला, विनीत सर, हमारी टीम डॉक्टर विशाल और बिहार की टीम, कर्मण्य व अधिकारस्ते माफ लेसु कदा चला। मैं इसलिए कह रहा हूँ कि तुम्हारा अधिकार केवल कर्म के लिए है और उसके फल के लिए कभी नहीं। 4 महीना पहले सच्चिदानंद सर का मेरे पास फ़ोन आया था कि डॉक्टर विकास, हम लोग चाहते हैं कि नील सोसाइटी ऑफ इंडिया का जो ओनाइकोकॉन है, 14th ओनाइकोकॉन, ये पटना में हो, बिहार की धरती पे हो, बुध की धरती पे हो, और मैंने सर को बोला कि सर हम अपनी टीम से बात करते हैं और उसके बाद मैं आपको खबर करता हूँ। इस 4 महीने में हमारे पास हमारा अपना बिहार स्टेट का जो क्यूटीकॉन था वो भी करना था हमें, और साथ साथ ओनाइकोकॉन को भी करना था। और हमने इसे एक चैलेंज के रूप में लिया, क्योंकि नेल का जो कॉन्फ्रेंस एक फोकस कॉन्फ्रेंस है और बिहार में कभी नहीं हुआ था। फिर हमने डिसाइड किया, हमारी टीम ने डिसाइड किया कि इसको करते हैं। हमारे बिहार के जो पीजीज़ हैं, जो यहाँ के जो डर्मेटोलॉजिस्ट हैं, उनके लिए बहुत ही फ़ायदेमंद रहेगा। और मैं खास करके धन्यवाद देना चाहूँगा अपनी साइंटिफिक टीम को, डॉक्टर श्वेतलीना प्रधान और सारे लोग जो उनके साथ एम्स पटना की टीम जो वर्कशॉप कराई। और हमने ये कोशिश की है कि हमारे जो यहाँ के फैकल्टीज़ हैं और जो पीजीज़ हैं उनको काफ़ी इससे काफ़ी फोकस एरिया में, एक नेल एक छोटी सी चीज़ है बट इसका महत्व बहुत ज़्यादा है। खासकर जब नेल रहेगा ही नहीं तो हम खुजली भी नहीं कर पाएंगे। तो एक ऐसा छोटा चीज़ इसका महत्व हमारे इंटरनल डिजीज़ से लेकर के कॉस्मेटिक तक है। तो हमने ये डिसाइड किया कि नहीं, हम इसे करेंगे, इस चैलेंज को हम लेते हैं। और हमने ये 14 जो ओनाइकोकॉन है इसको लिया, और डॉक्टर श्वेतलीना के लीडरशिप में हमने कोशिश किया कि सारे जो भी टॉपिक्स इम्पॉर्टेंट हैं उसको हम इसमें रखें। और डॉक्टर शिपर्णा, डॉक्टर पंकेश, डॉक्टर रजनीश, इन्होंने बहुत ही लगन के साथ इसको सफल बनाने का हमने प्रयास किया। और स्पेशल थैंक्स टू डॉक्टर अभिषेक कुमार झा, जिसने सारा प्रयास को, वो हमारी रीढ़ की हड्डी हैं, जो हम चाहते हैं, जो हम बोलते हैं उसको वो पूरा करके कोशिश करते हैं। सो स्पेशल थैंक टू अभिषेक कुमार झा सर और हमारी टीम को, खास करके नेल सोसाइटी ऑफ इंडिया को, कि उन्होंने हमें ये अपॉर्चुनिटी दी कि हम इसको यहाँ पे बिहार की धरती पे अच्छे से कर पाएँ। अगर साइंटिफिक और कॉन्फ्रेंस में कोई त्रुटि रह जाती है तो हम उसके लिए अभी से क्षमा मांगते हैं और आशा करते हैं कि आप सभी को ये काफ़ी प्रेरणादायक और ज्ञानवर्धक रहे। धन्यवाद।
May I now invite Executive Committee Member and immediate past President NSI, Dr. Vineet Rehlan sir, to say a few words.
Thank you so much. Nail Society of India was formed in 2012, so this is the 14th year. और मुझे याद है जब हमने नेल सोसाइटी बनाई थी तो हम 4 लोग थे, डॉक्टर चंदर, डॉक्टर अर्चना, मैं और डॉक्टर सोनी। तो हम लोगों ने ये आइडिया बनाया बनाने का। तो वी वर मॉक्ड बाय मैनी पीपल कि ये लिप सोसाइटी भी होगी, ईयर सोसाइटी भी होगी, कई सारी चीज़ें बनेगी। बट ड्यूरिंग दिस 14 years we have now 478 members, maybe much more be added. We have a journal, a dedicated journal to nail diseases, Journal of Onychology and Nail Surgery. We have a textbook which has, many copies have been sold. Every year we are organizing an annual conference on ONYCHOCON, so this happens to be the 14th one. And we have generated a lot of interest, all our CMEs, and we have become one of the largest societies of nail disorders in the world. And we had organized one international conference, ISND, in 2015. So we've done quite a lot, and I would like to thank the Bihar team, my dear friends Vikas Shankar, Abhishek, Dr. Shwetalena, Sinha sir, Roy sir, and the team. They have done a wonderful job at a very short notice. 4 महीने पहले हमने इनको बोला था, and they have done a wonderful job. Thank you so much, and long live NSA.
I would like to request President NSI, Dr. S. Sachidanand sir, to say a few words.
Good evening to one and all. Adaraniya Sri Brigadier Raj Agarwal ji, Sri P.K. Roy, Vikas Shankar, Abhishek Jha, Vineet Rehlan, Shwetalena Pradhan, Sri Parna, then Mishra ji, and Pankesh, and my team, Dr. Sujala Sujala Saradhya, Shikha Bansal, then Gaurav, and who else? I think I've taken all the names. And my dear audience, people in the audience, it's such a heartening and pride moment, a moment of happiness that this conference has shaped up very well. When I took over as president, I had apprehension as to how to run the organization, because it's a very small organization with 500 members, around 500 members, and it's a difficult task to run such an organization, and we should keep it active so that more and more get attracted to this particular association. Way back in 2005, I organized the first TrichoCon. TrichoCon is about trichology. In 2005, Bangalore, I organized the first TrichoCon. People laughed at me. They said, "What is there in hair?" I held 2.5 days conference with 1 day workshop on hair transplantation and hair surgeries, and 1.5 days conference. This was in 2005. That was the first conference on hair in India. So people laughed. And today what has happened? The whole trichology industry has opened up. Pharma people got a lot of opportunities to bring out products related to hair. And hair industry is now a multi-crore industry. I'm sure all the pharma people will agree with me. And we have started trichology fellowship programs. We have started trichology observership programs. And it's become an established subspecialty of dermatology. Similarly, the first CME on ONYCHOCON was conducted at MAMC by Dr. Archana, Dr. Chandar, and Dr. Vinit. At the same time, very close to that period, in Bangalore, I also had thought of nail conference, because I was always called as con man. Con man because I used to conduct a lot of conferences. I was in a medical college, so I had the opportunity of, my colleagues who were very cooperative, and I had a team of postgraduates, so that gave me an opportunity to organize many conferences. Just to enumerate, I have conducted Cuticons, I conducted Dermazone, I conducted Dermacons. The 4th Dermacon I am conducting in Bangalore next month. Cosmecon on cruise, Photocon, PHOTO photo and FOTO photo, both I have done. Then ONYCHOCON, and it goes on, Vitilicon, so it goes on. So that way, the first conference on nail was conducted by me again. It coincided with the CME program. I attended it in Delhi, and then immediately we organized this ONYCHOCON. And the first book on nail disorders was also brought out during that period. That was in 2013. And after that, many textbooks and other things have been added. It has enriched the science of nail disorders. So we did the hair splitting first. Now we are doing the nail splitting. Nail splitting is happening, but I'm sure this society in the years to come will definitely grow like what the other societies have grown. Dermatology is a very ever expanding and dynamic branch, and lots of youngsters are joining this association. Every year, now at least from this year onwards, 2,000 young dermatologists will be added every year to our association. We are now almost 20,000 strong across the country. Though Nail Society has got only around 500 members, I'm sure it will grow. And this is the capacity of the growth, that potential that the society has got. I'm thankful to all the presidents, all the office bearers of Nail Society of India for having continued the efforts from the last 14 years. We have visited 14 places, sir, for your information, and each time it will be a new state, so that the practicing dermatologists and also postgraduates in that particular area, they get the benefit. And then the subject becomes popular in that area. Once it starts, it goes on. That's how we want to light a fire, small fire, some spark somewhere, and that has to, turn into a Jnana Jyoti. That's what is the idea, and we have been successful so far in doing that. 10 years from now, all the youngsters in the audience, please mark my words, it will be one of the much sought after association, much sought after conference. Though the topics may be limited, but there is always something new to learn. There is always something new to learn, either in the diagnostic field or in the treatment or management field or in the therapeutics and research field. So a lot of things you can learn, and knowledge can come from any corner. It can let it come from any corner, and that's what we are in the pursuit of spreading knowledge. This association has taken baby steps. Now it has become a teenage, and sure it will grow into a good, healthy body. So with these words, I thank, as a president of Nail Society of India, the local organizing team, Dr. Sinha, Dr. P.K. Roy, Dr. Abhishek Kumar Jha, Dr. Vikas Shankar, Dr. Svetalina, and then Sriparna, Punkesh, and all others who are involved in organizing this conference. My salute to you, my heartfelt thanks to you for taking up this job in such a short notice. And I wish the conference, which is going to be held tomorrow also, all the success. Thank you so much from the NSI. Thank you.
Thank you, President, sir. Now I will request our guest of honor, Dr. Professor P.K. Roy, sir, and President NSI, Dr. S. Sachidanand, sir, to present memento to our chief guest, Brigadier Professor Dr. Raju Agrawal, sir. A big round of applause. Thank you so much. Now I request our chief guest, Brigadier Professor Dr. Raju Agrawal, sir, and our organizing chairperson, Dr. M.K. Sinha, sir, to present memento to our guest of honor, Professor Dr. P.K. Roy, sir. And request Dr. S. Sachidanand, sir, to join. M.K. Sinha, sir. S. Sachidanand, sir, ठीक है. May I request Professor Dr. P.K. Roy, sir, and Dr. M.K. Sinha, sir, to present memento to President NSI, Dr. S. Sachidanand, sir. I request Sujla to join. Dr. Sujla. For a family picture. I request our chief guest, Brigadier Professor Dr. Raju Agrawal, sir, and Dr. Professor P.K. Roy, sir, to present memento to Secretary NSI, Dr. Sujla S. Aradhya. M.K. Sinha, मैंने किसको बुलाया? सुजला वाला देखो. M.K. Sinha सर को बुला रहे. I request all of you to stay, please. Next memento to our organizing chairperson, Dr. M.K. Sinha, sir. Next leg ready. I request for the next felicitation, please stay, sir. Please stay, sir. Sir, please stay. And next moment too, I would like you to present to our executive committee member and immediate past president, Dr. Vineet Rehlan, sir. May I request Dr. M.K. Sinha, sir, to join? सर उधर से चले उस साइड से। विकास शंकर। May I request P.K. Roy sir and our chief guest Brigadier Professor Dr. Raju Raghulwala sir to present memento to our acting scientific chairperson Dr. Vikas Shankar. अभी तो दिया ना, हम दिलवा देते हैं सबको, दिलवा के लास्ट में। May I request you to present memento to our scientific co-chairperson Dr. Svetlana Pradhan. Dr. Svetlana Pradhan. Dr. Vishal Gaurav. अच्छा ये बोला हुआ तो चेंज करवा दीजिए तो नाम को ऐसे कर दो यहाँ पे to our NSI Joint Secretary Dr. Vishal Gaurav sir. उनका बना हुआ है शिखा अग्रवाल। I'm really sorry, Vice President Dr. Shikha Agarwal, we missed you that time also and now also. So next felicitation to Dr. Shikha Agarwal, Vice President NSI. Shikha Bansal, sorry, Shikha Bansal. May I request Dr. Punkesh Kumar, our Treasurer, ONYCHOCON 2025, to come forward and receive his memento. Sir, few more, do तीन और. May I request get all the join. Rajneesh. May I request Dr. Vineet Rehlan, immediate past president, and Dr. Sujla Aradhya, Secretary NSI, to present memento to Dr. Rajneesh Kumar. And to our Joint Scientific Secretary, Dr. Shriparna Dev. May I request Dr. Chandra Grover ma'am to join us for her contribution towards the Nail Society of India. We would like to felicitate her. May I request President Sir? May I request Dr. Aditi Snehal to come up for her contribution towards our conference. We like to appreciate. May I request Dr. Vikas Shankar and Dr. Sujla to present the memento to our own Dr. Aditi Snehal. कौन है इसमें? चारों ने. I will request our President, Dr. Sachi sir, to present few appreciation awards who have really worked hard for this conference. First, Mr. Shad Khan, Mr. Raja Adhikari, Mr. Raja Adhikari is the actually event manager. He has done everything, and he has been associated for us for last almost 10 years in most of our conferences. I will like to invite Mr. Farooq Azam, who works behind the scene always, but he is the actual backbone of our conference, Mr. Farooq Azam. And with him, always tirelessly standing, Mudassir Munir. And Mr. Shad Khan is coming. Thank you, Mr. Shad, for providing all the help. And really, this is the first conference we are hosting at your hotel, but we really, with your support, and it is possible that we are doing it. So thank you so much, Mr. Shad Khan. Mohammad Shad. हो गया ना?
Now I request Professor Dr. Rajagopal sir, Professor Dr. Sajidan sir, and Professor Dr. P.K. Roy sir to present memento to our pillar of BIHAR IDBL and organizing secretary of ONYCHOCON, Dr. Abhishek Jha sir.
Now I would request all the dignitaries on the dais to kindly go for journal inauguration. Release of the Journal of Nail Society of India. मैम हाँ हाँ मैम को दीजिए मैम को कोई बात Now I would request our guest of honor, patron, Dr. Professor P.K. Roy sir, to address the gathering with a few words.
आप सबों का नमस्कार। और बेडमना ये है कि मैं ये नहीं बता सकता हूँ कि मैं आपका स्वागत करूँ या आपका धन्यवाद दूँ। तो पहले स्वागत से शुरू करता हूँ। वेलकम डॉक्टर ब्रिगेडियर राजू अग्रवाल, आवर चीफ गेस्ट टुडे, ही इज़ द डायरेक्टर ऑफ एम्स। और हमारी मदद करने को बहुत बहुत शुक्रिया। आपने कल हमें अपना वर्कशॉप दिया करने को ओटी दिया। इनकी मदद हमेशा से रही है और आगे भी उम्मीद है कि आप हमारे हिस्से से मदद करते रहें। नेक्स्ट आई वेलकम डॉक्टर सचिदानंद टू बिहार। ये हमारे बहुत पुराने मित्र हैं। सचिदानंद तो मुझे पता भी नहीं मैंने कब इनको बोला होगा, हम लोग प्यार से इनको सची बोलते हैं। एंड लाइक ही सेड ही इज़ अ कॉन मैन। जितना कांग्रेस हुआ हो हमारे आईडीबीएल का, मतलब डर्मेटोलॉजिस्ट सब इन्होंने किया है, सबके कुछ न कुछ हमेशा से रहे हैं और हमारे बहुत प्रिय हैं। बिहार इनको बहुत प्रिय है, जब भी बुलाता हूँ चले आते हैं। इनकी बेटी अब इसी लाइन पे चल रही है, सुजाला हमारी भी बेटी है और अभी एनएल सोसाइटी की सेक्रेटरी है, जिसके प्रेसिडेंट डॉक्टर सची हैं। अब उनके बारे में वेरी अपकमिंग एंड ब्राइट लेडी, और मैं उनका स्वागत करता हूँ और धन्यवाद देता हूँ कि नेल सोसाइटी को अपने जिंदा रखें। विनीत, एन ओल्ड फ्रेंड ऑफ आवर्स, वन ऑफ द फाउंडर्स ऑफ द नेल सोसाइटी ऑफ इंडिया, डॉक्टर विनीत, आपका भी स्वागत है। और बाकी तो हमारी जाने पहचाने टीम ही है। अब इनको मैं स्वागत क्या करूँ, धन्यवाद देता हूँ कि मेरे नाम को इन्होंने ऊंचा किया है, बिहार आईआईएम को ऊंचा किया है, बिहार के धरती के नाम को ऊंचा किया है। इतना अच्छा कॉन्फ्रेंस इतने कम समय में लेना, ये बहुत हिम्मत की बात है। लेड बाय डॉक्टर M.K. सिन्हा, डॉक्टर अभिषेक, डॉक्टर विकास, डॉक्टर शिवपर्णा, डॉक्टर स्वेतलीना, मुकेश एंड ऑल, you have done a wonderful job and I'm very much thankful to you. 3 cheers for them. Give them a big hand to my team, I would say my team. और आप लोग का भी बहुत बहुत धन्यवाद कि आप हमारे कार्यक्रम में आए। कल आफ्टरनून से लेके अभी तक, और कल भी मैं उम्मीद करता हूँ कि इसी तरह प्रेजेंट रहेंगे। जब नेल सोसाइटी बनी थी तो अब ONYCHOCON होना, तो मैं सोचता था अब इतने छोटे से ऑर्गन का क्या करेंगे, बट ट्रस्ट सच्ची अब इससे भी छोटा कुछ लेके आएगा ONYCHOCON करने के लिए, पता नहीं उसका क्या नाम रखेगा। तो आप समूह का बहुत बहुत स्वागत है, बहुत बहुत धन्यवाद। कल सुबह से लेके दोपहर तक आप लोग का फिर ये कॉन्फ्रेंस चलता रहेगा। नेल के बारे में बहुत बड़ी बड़ी बातें होती रहेंगी। और मैंने चंदन का नाम ही नहीं लिया, the young bright lady over here was the founder of Nail Society of India, and she is the editor of this journal which we have released today. Welcome Chandan to Bihar and thank you very much. एक बार फिर आप सबका बहुत बहुत धन्यवाद। Thank you very much. इशारा हो रहा है कि ज़्यादा टाइम मत लीजिए, मैं नहीं लूँगा। Thank you so much.
Thank you, sir. I respectfully invite our esteemed chief guest, Brigadier Professor Dr. Raju Agarwal, sir, Executive Director and CEO AIIMS Patna, to kindly share a few words with us.
Thank you. Good evening, everyone. Professor Sachidanand, Professor Roy, dignitaries, organizing committee on the dais, and I can see a lot of delegates and young dermatologists in the crowd. So first of all, thank you for bestowing this honor on me to be calling me as a chief guest here. When they came for invitation, I asked them, what is this? They said, Nail Society of India. Never heard of it. I looked at my nails and then I looked at the invitation and something flashed that whenever my wife goes, she buys nail paints and asks which nail paint to buy. And so that is the knowledge about nail, and when I am nervous, definitely do nail biting. But yes, when they invited me, I really looked into what is this Nail Society of India and what is it onychology as a branch. So it was an eye-opener for me that anatomy, pathology, microbiology, and so many things are there in the nail, and it is a mirror of multiple diseases, and also used in forensics to collect forensic evidence. Branches have really over a period of time, I remember my days as an intern or a young doctor. In fact, when the patient used to come to us with some problem in the nail, hardly we could diagnose anything and give some sort of treatment, whatever we felt it is. And in medicine, people taught us about the systemic disorders of nail presentations, cyanosis, clubbing, and all platinikia, koilonychia. So like I am sure like it was told in 10 years from now, I don't know whether there will be a DM also in onychology, and I will not be surprised if it is there, because the branches are going so fast, and now the conferences have become so focused. There is nothing like general dermatology. Probably you will have to pick and choose area of your interest and go in that. So I am very happy that these type of conferences are organized in different states. The young dermatologist, as said by the president, that a small spark which may be a full-fledged fire after some time. And I wish the organizers, the delegates, all the very best and an academic feast for this conference. And thank you again for inviting me. Thank you. Jai Hind.
Now I request Dr. Abhishek Jha sir, Organizing Secretary on ONYCHOCON, to present a vote of thanks.
नमस्कार। ये एक ऐसा कॉन्फ्रेंस था जो बहुत कम समय मिला हमें, उसमें भी पहले हमारा क्यूटीकॉन था, उसके बाद फिर हमें 2 सप्ताह तक एक ईस्ट जोन अगरतला जाना था हमें, फिर उसके नेक्स्ट फिर हमें झारखंड जाना था। टाइम बहुत कम था, तो मैं इसके लिए तो सबका थैंक यू कहूँगा। जो भी यहाँ पे हैं सबको धन्यवाद, जिन्होंने मौका दिया, जो आए, जिन्होंने किया, जिन्होंने अरेंज किया, सबको धन्यवाद। ये संभव हुआ सिर्फ आपके वजह से। आवर चीफ गेस्ट ब्रिगेडियर डॉक्टर राजू अग्रवाल सर, our guest of honor, he is not guest actually, he is our patron, he is our guardian figure, Professor Dr. P.K. Roy sir, President NSI, Dr. Sachi sir, Vice President Dr. Shikha Bansal ma'am, immediate past President Dr. Vineet Rahlan, our organizing chairperson Dr. M.K. Sinha sir, our joint scientific chairperson Dr. Vikas Shankar, scientific co-chair Dr. Svetlina, our joint secretary Dr. Vishal Gaurav, and joint scientific secretary Dr. Shriparna Dev, and delegates and friends. Thank you very much. NAIL is really important, and I have seen that, I heard that one team came from Delhi by road to attend this conference. So thank you guys for coming. You're the young team, Dr. Anupam Das who came, who always joins us in most of our conferences. Chanda Grover ma'am, if we know NAIL, we know you, we know Archana ma'am and all the legends like Sachi sir and everyone. So NAIL is because of you. The importance of NAIL, I felt at home. When my wife, she is here only, she goes to the NAIL something, extending or something, and I think it's 2,000, 3,000, 4,000, I don't know the exact rate, but so NAIL is so important for us aesthetically and clinically also. At the end, I would like to thank the pharma companies who at the very short notice, they have closing at this time. We all know that this is the closing time for them. Still they are present till this time. They helped us. So all the pharma companies, thank you so much. And the event management team, the snappers, Raja, Adhikari and everyone, thank you so much. I hope that we will have this extended program till tomorrow. You all stay, you attend the meetings, attend the scientific programs. Again, I thank you, and we had prelims done by Anupam. So we have 4 teams who are qualified. IJMS Patna, Nikhil Sharma and Shivani. Third place on the third rank, FMC Pune. That was Dr. Diksha Garg and Dr. Rahul Nair. And I'm happy to announce the top 2 teams were from Patna. The second was AIIMS Patna with Dr. Mishkat and Dr. S.S. Viswas. And I'm really happy to announce the first place where I belong to, my PMCH, and team for PMCH from Patna, Dr. Neha Nidhi and Dr. Jaya. So big round of applause to them. I wish them all the best for tomorrow's quiz. Everyone is winner. There was not much margin. So congratulations to all the participants as well. Thank you so much.
I'll request everyone.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I would request everyone to join us for dinner. And यही पे ना